this is moxifloxacin, which is of course preservative free. So now this is the end of the surgery.
Beautiful demonstration, Dr. Satyamurthy.
Yeah,
sir, right.
thank you very much. Thank you.
So great. Now we have in current times so many options for EDOF lenses, and EDOF of course has had certain advantages over the traditional multifocals, such as lower rate of halos, glare, and still having a good amount of range of vision. But now when you look at all the options which are available, so when you have all the options available, such as Minivel, you have Lucidus, you have Vivity, you also have Symphony. So is there a way in which you actually choose and pick up the lens that has to be used for a particular patient?
No, is that a question posed to me? Can you please?
Yes.
So, I can't hear I didn't hear it properly.
Okay, so my question was that now there are so many options of EDOF lenses. Right. So you have Vivity, you have Symphony, you have Lucidus, Minivel. Yeah. Right. You have Lara from Carl Zeiss. So if you look at so many options, so do you really pick and choose which one to be used in what kind of patients, or you feel all of them, they work equally good?
No, the basic thing is, so it is wrong on our part if we don't suggest EDOF, any trifocal lens or EDOF lens to the patient, because the intermediate distance is very, very important in our life. So now again, which lens, that depends on what patient can afford. So all the lenses, all the trifocal lenses are doing extremely well. And the glare and halos, which we used to discuss so much about multifocal lenses and other things, are not there now. You can, any patient for them. Now they have come up with a nice toric trifocal lenses also. So any company for that matter is okay. And this is very economically placed. So one can go ahead with this particular lens.
So it is more reasonable compared to the other ones like Lara or Vivity. Compared to the other ones, the Minivel is more reasonable for the patient. So they can, basically get the same benefit at lower cost, for example.
Yeah. So that's why.
Am I audible? It is.
Yeah, now it is audible. Yeah.
Okay.
Yeah. What was the question actually?
No. What I was saying is basically for Minivel, one of the advantage over the other EDOF lenses may be the cost factor, because it is more reasonable for the patient.
Yeah.
Right. Yes.
Correct, that's right. So the cost is one thing which again pushes the patient out. So don't suggest first monofocal lenses to the patient. In case patient has got astigmatism, toric trifocals are there. In case if patient says I can't afford anything like that, then probably monofocals are, you have no other option but to put them. But I feel trifocal lenses should be given a choice.
So traditionally when a patient is diabetic, we try to avoid implanting a trifocal or a bifocal or a traditional multifocal lenses in them.
This is very important actually. Even I want the opinion of other people also. There are two schools of thought. Some vitreoretinal surgeons feel that if you put any trifocal lens or the rings, they come in the way of treating the diabetic retinopathy. You can't do laser properly. But other people say that you can do it, and some people say that so now I really don't know whether I can provide you a better answer here. Maybe the
but what do you follow, sir?
I personally feel there is no difference. Unless patient has got a CSME or something like maculopathy, then you can't give. But otherwise, if macula is healthy, then I think one should go ahead and give.
All right. Okay.
One should go.
And I think earlier the school of thought used to be that in the future a diabetic patient may get a retinopathy, and that is why we should not go for multifocals. But now that trend is slowly changed, and today we are using multifocals, trifocals for even patients with diabetic retinopathy without any macular issues.
Correct. If as long as macula is healthy and you can give 6/6 vision to the patient with a good color contrast, then there should not be any problem. You can as well go ahead and put a trifocal lens. With the video indirectly delivered laser, with the indirect delivered laser, there shouldn't be a problem at all. So I think that question doesn't arise if it's a diabetic or non-diabetic. Whether macula is healthy or not healthy, that is the one which we should always see.
And as far as the IOL power calculation goes, in case of EDOF lenses, you aim for emetropia or do you aim for slightly myopia?
The EDOF lenses, dominant eye emetropia, non-dominant eye maybe you can increase by another 0.5 diopters so that the near vision is not affected. So this is what I am following. But other trifocal lenses like panoptics where I have no financial interest, you can make the patient emetrope both eyes. So like that. So near vision add how much it gives.
You know, if you go for micro monovision, Shilpa.
Yeah, you can go for it, that's what, this is micro monovision. Ultimately, patient should be happy and then should not blame you for implanting such a, costly lens and then patient is not happy with the near vision.
Yeah, and patient education as far as the near vision is concerned.
Exactly. Yeah.
Telling them beforehand always helps. Thank you so much, sir. Wonderful surgery.
Thank you.
As usual. Thank you so much.
So next surgeon is ready, so we'll go ahead with, thank you.
Thank you, sir, for the excellent surgery. The next session will be a keynote address by Dr. Mohan Rajan after this surgery. Next surgery will be by Dr. Anurag Mishra. Dr. Rajeshri, I request you to go ahead.
Can we take some questions in the meantime?
Can switch on the lights, please? Good
I
morning,
had
everyone.
a question.
Yeah, please go ahead, Dr. Satyajit.
I wanted to ask in these patients who we recommend trifocal lenses, and you said when the macula is healthy, long-standing diabetics, do you suggest that we do a OCT-A in these patients to see any pre-diabetic changes before we are putting a trifocal lens? Just to do a routine OCT and see the macula is healthy, can we go one step further, or is it being just going over the board, trying to do a OCT-A in a long-standing diabetic to see pre-diabetic changes?
Is anybody there, or the question is left to the...
You can answer.
Okay, thank you. That's my favorite topic. It's multifocal IOL and the retinal diseases. So they have done a quite lot of study where doing OCT in these cases, in these lenses, especially when you put the TRIDOF, EDOF or multifocal or any kind of focality kind of higher end lenses when you put, it's always better to do an OCT. OCT-A might not be required unless you have some drusen's or anything to detect early kind of MNVs or PEDs or anything of that kind of sort. But OCT, especially the high definition OCTs and the Heidelberg OCTs, they pick up even the smallest kind of this thing also. So it's always better. If you want to know before the drusen develops, then there is something called as adaptometer that's been launched in the ASCRS. That tend to see the lipid cholesterol or the drusens, early drusens, before actually happening it pathologically. So that those machines are also available if you want to get it detected, and then you can go on with the multifocality of the lenses. But I usually suggest whenever there is high-end lenses being put, it's always better to be on a safer side rather than the patient regretting later.
I think what Dr. Satyajit was wanting to ask is long-standing diabetics with no evident diabetic retinopathy, and we are going in for trifocals. If there are small capillary dropouts in the deep plexus or in OCT-A, we can maybe warn the patient that maybe in 6 months or 1 year or 1.5 years, you may get some diabetic changes.
Yeah.
So just for that, I think.
I agree with your point, madam. In the OCT itself, you have a foveal ischemia, there will be widening of the FAZ.
Yes.
So if they have OCT, that is more enough. If you have OCTA, you can always look into there is any capillary dropouts in the posterior pole.
Because the expectations increase when with trifocals.
So I think the take-home message is that all cataract surgeons, when they are going for high-end lenses, premium lenses, it is necessary to have an OCT as an armamentarium in their practice, isn't it?
Yeah, I think I agree. I just want to add that, in fact, I want to endorse what Dr. Pooja said and Dr. Shilpa said, and of course Dr. Srinivas, that counseling is the key for the patient satisfaction. If you have the patient mentally prepared for what he is supposed to expect over the years, I think that is the most important thing.
I think OCT is a must nowadays, I think, as a routine pre-operative cataract workup. Many centers don't do that as well, but because many times you have a dense cataract, you can miss an ERM, you can use a lamellar macular hole, but the OCT will pick it up. So that's the advantage of the OCT, especially the high resolution OCTs which are now there. I think OCT is definitely a must for all patients, whether you put premium IOLs or
Yeah, I
regular
think whether
IOLs.
it is premium or not,
Yeah, need to tell the patient what exactly is expecting
Yes.
after the surgery. Yeah.
Sir, I think couple of years back, there was a publication in ophthalmology, so it came from Bascom Palmer. So they had seen that even when pre-operative in a patient who had cataract, the retina was checked by retina specialist. Then also they missed 12% of the cases when there were minor vitreoretinal disorders which would have affected the post-operative outcomes, such as you have said, thin epiretinal membranes, vitreomacular attractions, causing also having lamellar small holes. So these were all missed, and it is a part of also patient education, because we can tell patient already about the guarded visual prognosis, then they accept it much better, because if they land up in poor vision post-operatively, then they will blame the surgery. Yeah.
We did a study and we found out as high as 25% of the patients we missed an ERM. So when we did the OCT, when we didn't do the OCT, 25%, which is pretty high.
Exactly.
Yeah, because the cataract sometimes very dense, you're not able to, but the OCT will pick up.
So is anybody actually following what Dr. Satyajit said about the longevity of diabetes? Like for example, if there is no diabetic retinopathy, but the patient has been diabetic for 10 years and wants a multifocal, so would you still go ahead and do a multifocal for them? Or if it is...
If I find the macula is fine, I will go ahead with doing a multifocal. There's no evidence of diabetic retinopathy.
Okay.
I think the key is the present multifocal lenses do not alter the management of diabetic retinopathy in any way. Maybe injections, of course, injections it is not going to affect at all. Lasers is possible, and surgery also is possible. Macular surgery also is possible with a multifocal in place. It was only with the older lenses where the rings were few that we used to have the edge effect. And because of the edge effect, there used to be a lot of distortion of the image during vitrectomy and during laser. With the present lenses, I don't think it's a concern at all.
Point of view or the laser point of view is the point of view of the surgeon. The surgeon, the patient expectations, because when you have a problem in the macula and you put a multifocal lens, the patient will not have obviously good contrast vision and obviously not good visual acuity as well. So near vision will be affected, the distant vision will be affected, everything will be affected. So its expectations are very high when it comes for a multifocal lens, and that is what we have to look at. Not from the point of view of lasers or the vitrectomy, we don't have any problem. Even ERM peeling, we do everything. So with the multifocal lenses in place. But the point of view of the patient, I think the expectations are very high when you come for a premium IOLs. He wants 6/5 and 6 vision the very next day, and he doesn't want any compromise. Because he's paying up his this thing. So that I think we have to keep that in the back of our mind always when you do the.
Sir, I just wanted to know what the court has to say if I don't do a OCT and the patient has some problem and I do a multifocal. How do I stand legally if I don't do a OCT and put a multifocal and then the patient has any problem? Where do I stand in the law of court?
If it's a pre-existing disease, if it's been established, then definitely it's a kind of negligence. Because
it's like now B scan. If you don't do a B scan for a mature cataract and go ahead and do a surgery, it's like that. So obviously the court will not take a point.
But sometimes the progression of DR might happen after cataract surgery also. So that might be difficult to prove.
But that is another thing. But
Yeah,
something
but if
which
you
was
have like
pre-existing.
brucens, if you have an MNV, if you have a subretinal fibrosis,
But I didn't do an OCT.
Yeah, then it's
so I don't stand in the law of court.
It's not correct. Yes.
Yeah.
So I think we have our next surgeon, Dr. Anurag Mishra. Are you there? Dr. KP?
Sir, just a minute, sir. We will,
Gilbert, can you?
yes, sir. We will present the case history first.
Yeah, go ahead.
So this is a case of 75-year male. We are operating his right eye for cataract surgery with a grade of nucleus sclerosis 2 to 3 grade of cataract, and the IOL that we'll be using is pan-optics lens. Over to you, sir.
I have my chopper, yeah.
Good morning,
Just done.
Dr. Anurag.
So it will be a combination of 3D and 2D surgeries. When 3D surgeries are on, it will be on the central screen, and the 2D are on the left and the right. When the 3D goes on, I think they will give you an intimation.
Do I have a
Request
mic?
everybody to please wear the 3D glasses when it's on.
So, am I audible at the venue?
Yes.
So, good morning, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. This is Dr. Anurag about to start off my case. This is, as has been already briefed to you, a 70-year-old gentleman with not much difference in the delta. So, the corneal profile is doing fine. Somewhat myopic. No, I just need HPMC. Just give me my blades, please. My blades. Yeah. Where is the other blade? 2.2. No, not that. Yeah. That's not 2.8, that's 2.2. Give me that blade, yes. Give me that blade and this one. No. Right, so no, the sleeve is doing fine, just give me the blades. The blades, sir. Yeah, the other one. Righto, so as you can probably gauge from the screen itself, this is a pretty softish, centration is not there. So which way do I need to move? Little down, thoda isko idhar. Is it done now? Is it zoomed more? Okay, can you reduce it then? Just a little bit. I think the zoom that I'm getting from the microscope view and the one that's projected on the screen are different from each other. Yeah, that's, no, that's too much, that's too much, that's too much, that's too much. Please scale it up. Little more, yeah, that'll do. So is it better now? Okay, so this is a 2.2 millimeter section given flush at 180 degrees because this is the right eye. And the side put as well.
Oh, that was nice. Simultaneous entry of main incision and the side port.
Yes, so it actually spares the conjunctiva from your touch, essentially, before all the 3 sections are made. Oculan, please. So a little bit of preservative-free xylocaine into the anterior chamber. And I have my capsulotomy needle. I want that, please. My capsulotomy needle inside. Okay, right, thank you. So a little bit of HPMC. Thoda idhar rakhiyega, thank you.
Anurag, can you use the retro-illumination?
I actually don't know where that's function. Okay. Yes, it is. Not as bright as I get in my Lumira, but yes, it's good. I don't know what difference does it make at the venue end, of course. So the retro actually is a lot of fun when you watch the fluid wave go, just like that.
See the fluid will go very clearly.
Pretty strong believer of this concept which was described by Dr. Vasavada and co. almost a decade and a half back of rotating the nucleus a few times before you start your phaco. It essentially kills all the equatorial epithelial cells and prevents future PCO. So I always do that in my practice. Can we switch back to the normal illumination? Yes, sir. Yes, sir. Thank you. All right, so I would just like to draw your attention towards my parameters at this point in time. I think you can see that on your screen if you can. So I'm operating at an IOP of 20. So the intraocular pressure is being maintained at 20. And look at the chamber stability already. So this is as physiological as it can get. You know, you're not stretching any ocular tissue more than its limits.
What is the vacuum you are using now?
It's
Pretty high.
400, sir.
400, okay.
But the AFR is something I always keep low. So that's set at 23. And that's something you should be keeping low when you're using this particular phaco system, because the bore of the aspiration tubing is narrow. You need to set a higher vacuum and a low AFR. That's the recommended practice, and I find it very useful in mine. But the attention has to be drawn to the chamber stability. It is stupendous, even at an IOP of 20, which equals to a bottle height of 27 centimeters of water. That's amazing.
Which machine is it?
So you use more, use less of fluid. So what's the CD up till now? Can somebody tell me? 1.8. So 1.8 CDE, and we are already through with our chopping. So we go to the quad mode and start eating away piece by piece. At this point, anybody who aspires to use a Centurion or is already using it, I would just recommend the bevel to be turned a little sideways. You pronate your hand a little bit so that nozzle works even better, and the pieces are consumed like zip-zap. So just turn it sideways a little, come to the safe plane, use energy judiciously only when it is occupied by the nuclear fragment, not always. So it's a bad habit to keep your foot on the foot pedal all the time. So that consumes more energy. And you just stay at the middle, because the fluidics, the fallibility of the system is so good that it drags piece after piece, dislodges them from the bag, and takes it to the tip.
It was a very good demonstration of in situ chopping that you have shown. So I think it was very nice to chop everything in pizza pie kind of fashion and then remove them one by one.
Absolutely. You have to make sure that the posterior plate cracks completely. This is true for all grades of cataract. This is, of course, a softish one.
What is the AFR you are using, Anurag?
23, sir.
That's
I
all?
never go beyond that. Yeah.
23.
Yes.
You see, the fallibility is really fantastic.
And we are done. Oops, sorry. There's just a small chunk of epinucleus left, so I'll just take it off. So that's what I was saying. The bore size of so the CD now stands at 9.25. So this is one of the reasons why I have completely switched off from post-operative corticosteroids. I don't give my patients topical steroids at all now. It's all on non-steroidal anti-inflammatory agents once a day at 9 p.m. Gives me tremendous dose compliance from the patients, and it's preservative free as well. So if you have a CD value of less than 10 in any case, and it's been largely uncomplicated otherwise, you don't need to put them on steroids at all.
So it's been since how long now, Dr. Anurag, that you are using steroids?
At least for 2.5 to 3 years. All premium patients, at least flax patients, we don't use steroids at all. In fact, if I get my figures right, I think 85% of the patients walk out without any steroid drops in their bag.
That's interesting.
Seriously amazing.
And here also I'm using an IOP of 24 and the vacuum of 600, if you can see that. 600 panel mode with a 24 IOP, and look at the chamber stability. It at times becomes hard to believe with the kind of fluid consumption this machine does, it at times is hard to believe the kind of chamber stability it gives you for the particular grade of cataract concern. So we're done. Can I have the hydrocannula, please, for a while? So now we go on to the IOL delivery, the all-important IOL delivery, and as you all are already aware, we are implanting a Panoptix, which is a trifocal hydrophobic platform that's come from the house of Alcon Laboratories. The central bullseye is 1.2 millimeters, so even if your angle alpha misbehaves by an extent, you can still go ahead and implant it. It gives you a leverage of putting in this IOL, even if your angle alpha is D cartridge. Is it D?
Yes, yes.
Okay, fine. Can you load the lens? Yes. Do it. Right, so the central bullseye is 1.2, so even if your angle alpha is somewhere around 0.6, 0.7, you can still go ahead and implant it. The light transmission is superb. So I haven't had any patient who has complained of a reduced contrast sensitivity. However, we do have a discussion, I think, later in the day how to enhance or personalize or optimize your trifocal outcomes. One of those things that I would always emphasize is, before you plan any patient on a trifocal or a multifocal, one should always take a look at the contrast sensitivity that exists in the patient with the help of modulation transfer function curve, if eye trace is available with you. If eye trace is not accessible to you, then you can simply do it with an ETDRS chart normally. No, push. But it does need to be looked at. If the contrast sensitivity is already low, then he or she is not a proper candidate for a trifocal implant. That's something apart from angle alpha, I'm quoting angle alpha because that's always in talks.
Polish, visco.
Yeah, in visco I have an IOP of 55 or 46? Okay, so I've just scaled up my my IOP here for the IOL implant. I've just taken it to 46 because I would like the anterior chamber to be a little more bloated than I normally do, and take the IOL in, allow it to open there, take the irrigation cannula and give it a push, and it's done. So the trailing haptic should open on its own. Sometimes it gets stuck, and I think it has got, no, it's open now nicely. So that's all you need to do. And for any youngster watching, if you have constructed your wounds well, then you don't need to keep hydrating all the ports. Just hydrate one side port, preservative-free moxifloxacin. Okay, so just hydrate one side port and that's it. You don't need to render a white cornea by stromal hydration. Of course, I know that it disappears, it doesn't stay. But still, to me, this kind of an eye always looks better than the stromal hydrated eye, which has got whiteness all around the main wound. So you can see that the AC is very well formed. I'll just separate the lids to show you. Right? Is it visible?
Beautiful, beautiful surgery. Anurag.
Thank you so much. We are done here.
Yeah, beautiful demonstration.
So we have consumed 53 milliliters of fluid for this case, just because we have operated under a very low IOP condition. So that's what I was saying when I meant, what I meant in the morning was just before starting of the case, that I trust this system just because it uses so little fluid and so little energy. So the insulting factors on the eye, which are essentially our surgical parameters like the fluid and the energy, both of them can be kept at a minimum and you can still get a superb outcome. I mean, I don't think anybody saw any struggle per se during the surgery. So it keeps you at comfort, it keeps the patient at comfort as well, but it also gets the job done. So any questions?
Dr. Anurag, we noticed that you did not check for the eye to be, the wound to be tight.
I showed you the anterior chamber, ma'am. It was very well formed. You mean by dabbing the eye and seeing whether the leakage? No, I don't think that.
Since you didn't hydrate the other wounds.
Yeah, that's what I'm saying. It doesn't need to be done because when the eye looks like that, it always stays that way. Very firm. You don't need to render the eye stony hard. See, this is one of the practices that I have picked up after using, because we are a very high volume toric consumers. So after my torics, I started developing this habit of hydrating just one side port, because on principle, whichever material, whichever IOL you use, you should not overhydrate the eye or over turgid the eye after your toric IOL implant, because that itself can cause a bit of post-operative rotation, particularly in the first hour. The other reason why I have picked up this habit is after flax, after femto laser surgery, if you hydrate the wound too much, it sometimes leads to a corneal, if you have done your corneal incisions with the flax machine, of course. I mean, if you haven't done that, then it's fine. But if you have, I always prefer to do my corneal profile with the flax machine itself. So if you overhydrate the wound after flax, it tends to lead to a tight Deschmandt membrane fold and a tight deep stromal edema, which takes a long time to resolve. So these are the two reasons why I switched my habit to from hydrating all ports to hydrating just one port. It stays very stable.
Dr. Anurag, you did a beautiful surgery. Congratulations.
Thank you, Satyajit.
You made 3 ports.
Yes.
You used only 2.
Yeah. The other port is actually kept in reserve, because if the haptic does not get released from its genuine adhesion to the optic surface, which sometimes happens, you need to dislodge that. That is one reason. The other reason is, of course, torics. You have to align the torics, so that for that the second side port is used. And the third thing is, say you have, because I always use a coaxial IA, if you have a bit of sub-incisional cortex, which is not a very commonality, but still, if it remains a little bit of sub-incisional cortex, the other side port can be used to aspirate it out on the same go. And then the other side port is also used for one other purpose, one of the many other purposes, which I would be showcasing when I would be presenting on the video bouquet of cataract surgeries later today.
But could this incision not have been made when and as when you had required it, rather than making it in the beginning?
That's another way of looking at it, certainly. That's another way of looking at it. But still, these incisions are so small and in dimension. The irrigation cannula I use is 23 gauge. So it doesn't even require a 0.8, it requires a 0.6. So a 0.6 incision on either side is essentially astigmatically neutral. So I just pre-place it. I just pre-place it. Don't keep it for the end.
Thank you very much.
Anurag, I just have a question.
Yes, sir.
Fantastic surgery, everything went on very well.
Thank you so much,
But
sir.
I would tend to disagree with one thing, that is I keep the eye a little firm at the end of the surgery. The simple reason is, don't go by the anterior chamber depth, okay? Because these corneal incisions can leak. Please understand that. So every time the patient blinks, there is a micro leak. There is a small ingress of the fluid, okay, which you will not notice. But the AC will be deep, the CDLs will be negative, everything will be negative. But what I am trying to say is, if you keep it firm, then it closes the corneal valve much better, especially in the first few hours after the surgery. I'm not sure.
I completely agree with you, sir.
Yes.
But there's just one point that comes to the forefront out here, and that is if there is a micro leak from the corneal wound, the micro leak stays active for 48 hours. So even if you stromal hydrate, it disappears within a couple of hours, 2 to 3 hours at the most. So after that, it still is likely to micro leak. We can have different thoughts on it. And of course, I couldn't show you the turgidity of the globe. It would stay firm, but I didn't touch it to show. That's one mistake I did. But it works in my hands, but I completely agree with you. It is likely to leak. Yeah.
Shilpa, how many of you keep the eye firm at the end of surgery?
Yeah, I do. I do keep it firm. I hydrate all the
Aniket?
incision.
Yes.
Do hydrate all the ports.
Yeah, we
Keep
do
it
hydrate.
firm.
Yeah, I think so.
Yeah, I know. If there's a voting, I'm going to lose by 1,000 to 1.
It's just a discussion. No, fantastic surgery. No, I always ask the patient whether you're able to see the light at the end of the surgery, topical anesthesia. They're able to see the light, then probably I keep the pressure around 30 millimeters of mercury. So I keep it around 30, unless otherwise the patient has got glaucoma or something like that. I don't do that. But otherwise, I keep the eye a little firm.
Yeah, sorry.
So, probably last question, Dr. Anurag, is it's interesting to note that you're not using corticosteroids
Yes.
So in last 2 to 3 years that you have been using, and in fact, some studies have actually shown on the contrary that when you use flax, the chance of CME is actually higher.
Yes.
Because you release more prostaglandins, right? So in last 3 years, what has been your experience of, has there been any patient in which you had to really restart the steroids?
Absolutely.
Yeah? Okay.
There have been a few cases wherein because we have chosen our cases well, maybe that's the reason, but otherwise there have been a few cases, but I would say that majority of them, we had to start corticosteroids because they had manifestations which were indicating more towards allergy than an anterior chamber reaction per se. But yes, but those numbers are so minimal, believe me, they're so minimal that it has not changed, it has not forced me to change my strategy.
So for
in flax patients, the CME rate is higher, understood.
Right.
It is actually a fact. But I believe it is because of the fact that we employ more laser energy, we use more laser energy in fragmenting the nucleus where it is actually not that useful. What we have to remember is if the hardness of the cataract, the sclerosis of the cataract is too high and the light beam cannot penetrate into its deeper layers, it is not going to cut it. Laser is all about light. So if the light cannot reach the deeper layers, it's not going to cut it. So we have to scale the energy down then. We just do the capsulotomy, the corneal profile, little bit of nucleotomy just to give us a template and then come out. So use your flax energy, the laser energy, just as you use your phaco energy judiciously. Combination, it just goes down significantly. The other thing that I would like to say is, since this post-operative corticosteroids are not given to premium patients by and large, this is not universal, but by and large, we always tend to start it a day or two before the surgery. We always start it in any diabetic that's been a diabetic for more than 2 years, more than or equal to 2 years, and in any patient that has chosen a premium segment. Because we know that post-operatively also we are not going to put him on steroids. So 1 or 2 days before the surgery, and then it carries on for 6 weeks, the incidence of CME has significantly come down with that.
Yeah. Yes. And one last question is, which flax are you using? Which machine are you using for flax?
Sorry?
Which machine?
Which machine are you using for flax?
Which machine?
Are
for
you using
flax?
Yeah, Catalyst or Lensex?
No, I use the Lensex.
Lensex.
I have the Lensex.
Yeah, Vardhaman, I just want to, since he's using Lensex, Catalyst, you have the advantage. Huge advantage when compared to the Lensex because you have the center skipping, the software, which is a 6.0 software which is available now. It skips the center. So instead of using about 60 seconds of laser, you just use about 20 seconds.
Right.
So the incidence of CME, we have done a study now, and in fact one of my PG's thesis as well,
right,
is much less with this, because the amount of energy which is, even for the dense cataracts,
right,
the catalyst definitely does better, cuts better than the Lensex.
Right. Thanks Mohan, thanks Rajan and all the panelists. I think we need to move forward. We will go to the next surgery. The surgeons are ready, the case is ready.
Microphone.
Next case, please. The next case is actually the planning a toric IOL in the patient. I think before the surgery, I think we just give a brief summary of the patient, please.
Yeah, sir. So this is a 77-year-old male. We are operating the left eye for cataract. The lens that we'll be using is an Alcon toric IOL, and so we have, this is the toric calculation that we have done. The incision would be at 0 degrees and the IOL placement or the alignment would be at 6 degrees. I'll be showing you a video demonstrating the toric marking. Video, please.
Yes, sir.
Switch on the lights, please. This is phaco foot. Where is the microscope foot pedal? Table up. Yes. Table up. Yes. Table up. Lights off. Lights off. Lights off. Table lights off. That's it. Lights off, please.
Sir, this is recording video, sir.
Is my mic on? Sir, wait.
Yes, sir. Yes, sir.
Yes,
Mic on,
we
sir.
can hear you.
Yes, Dr. Harshal, it is on. Right. We can hear you very well.
Can you put saline, please? So, can you hear me, Dr. Vardhan?
Yes, yes, we can hear you, but they are,
Okay.
yes, now we can see you also, yes.
So, I just marked, can you show the marking video, please, which we just did on slit lamp?
Yes, we have just seen it, the marking video was seen, and it was.
Okay, so the point.
So you always mark on slit lamp.
Yeah, so first of all, good morning everybody, and thanks to the entire team of Joshi Eye Institute, Dr. Krishna Prasad, Dr. Satyamurthy and Dr. Srinivas for their kind invitation. And it's a great honor and privilege to come here again and again. It's just like a home. And so I always mark it on slit lamp, and I always mark, if you can see here, I mark with a 26 gauge needle. So I scratch the epithelium at 0 and 180 degree, and then I put ink on the 26 gauge needle, and then I put these marks. So even if the ink fades away, you can see that these marks, they always remain there.
Right.
So can you just put the table up, please, little bit up. Table up. No, up, more up. Yeah, perfect, thanks. So let me settle down with all the settings. Can I have a retro illumination, please? So this gentleman has almost 3 diopters of astigmatism. So we are planning TORIC IOL, and his teep axis is at 6 degrees. So we need to implant IOL at 6 degrees. Can I have more retro, please? Entire retro, full retro. No, more retro. This is the maximum? Is it focused there, Dr. Vardhan?
Yeah, we can say it, definitely retro in addition to this would have been better, but I think we can still bring out.
Can you do more retro, please? Retro, this is the maximum? Okay. No, brightness is fine. I think it's not in full retro mode. Okay. Is it focused there?
Yes,
Dr.
yes,
Vardhan? Okay.
well focused.
So this is under topical anesthesia. Can I have my forceps? No. Yes. And yeah. Yes. So this is the 1.2 mm keratome.
Right.
I am entering, making a first side port. I always use this calibrated 1.2 mm keratome so that we don't have to struggle for, no, visco I need, visco. And this is the modified visco cannula which I modified. It's a 23 gauge cannula,
right,
which fits in through side port very easily. It goes inside. Saline please on cornea, little bit. Yeah, thank you. Can I have 2.2 keratome? Yes. I need 15 number blade, please, or I'll just. Never mind. I'll do like this. So I'll have to make a 3 planar incision. So this is the main port which we have made, viscoelastic, and cystitome, please.
So the inner lip, as we have seen, you just slightly open up like a trapezoid, is it?
Yes. So I love to do all the procedure under retro, but here I can't get a full retro, but never mind. Can I get a visco, please? Visco, no. Don't put anything now. Visco. And my forceps, please. Rexis forceps. So the sizing of capsulorhexis is of very crucial in all these premium lenses. So one should always learn to use micro forceps, micro scissors. They come in handy in different kind of situation. So after making a rhexis of 5.25, you just take off all the viscoelastic before you start doing hydro. You can see the fluid wave running through. Always burp the nucleus. So that you have good hydrodissection. Visco please, and phaco. Is it focused there, Vardhaman?
Yes. Well
Okay,
focused,
okay.
well focused.
I need my chopper, just a minute.
So which phaco machine will you be using?
This is Centurion, which
Centurion.
I have been given. Yes.
Remove the zero, retro.
I need continuous irrigation, please. No, keep it on. Just stop it once, yeah. Yes. Can you start the infusion, please? Keep continuous flow on, please. So every machine has a different feel, of course. I'm not used to this machine, but you just need to hold the nucleus there and chop it. You can see.
Very nice chop. Yes, we can see it.
You
nice.
rotate the nucleus.
Beautiful.
You just first make sure that you have the perfect chop there. You need to have two good division. And then again, go there, keep a good hold, chop it. So it's the lateral separation which does the magic. And your good hold on the nuclear pieces. So what are the settings right now? I'm not aware.
What is the IOP and the flow rate you're using? Ashul?
What IOP you set up? Okay. Flow is 40 and IOP is 80. That's what he's telling me.
18. Quite physiological. Very good.
IOP is 80.
That's what he has given. You can reduce down the IOP, yeah?
80 or 18?
18.
80?
80.
Reduce the IOP, yeah?
Okay. I think that's...
So to get a good hold is the key in chopping. You get a good hold, you separate the pieces like pieces of cake. Just be in center and then finish off the job. So this machine has excellent chamber stability. So this is the last piece. and we are done with the nucleotomy part.
Nice.
Okay, give visco. So if you can appreciate the curve of this cannula, I will show you. So this is the curve which has 22 millimeter length. So this is modified by me and it fits easily through side port. So that's the biggest advantage of this
Nice.
cannula. Yeah. We'll take a photograph. Okay. So see, this is the advantage of using the pre-calibrated side port, that this is a 1.2 mm incision and these instruments they easily fit through 1.2 mm.
So usually, Dr. Harshal, you do bimanual eye?
Yes. No, always by
Always
manual.
by
Yeah. I think that gives more advantage.
It gives better reach.
Yes, of course.
Yes. Even I use bimanual in all my cases.
Which company bimanual is this? Is it a Duet?
Which company is this? Bimanual IA?
Looks a little big, no?
I think Alcon people can tell which bimanual IA is this. It's Epsilon, okay. Oh, I
Epsilon,
can see some nuclear piece which is there, hidden there. So just give me viscoelastic. Maybe give cannula, aspiration cannula. Yes. Visco, please. Can you give me the handpiece once? Phaco.
One of the TPA companies,
Yes.
they reimburse more if you do coaxial than bimanual.
Really?
Which company is that? You please tell them to meet me. I use only coaxial. I need some money now.
It's Phaco. Okay, put it on Phaco, no? Yeah. Okay. Bimanual IA. Visco, some visco, yeah. I need continuous flow, yes. Can I have capsular polishing mode, please? Polishing mode? Okay. Keratome, please. I need continuous irrigation. 2.8. Yeah, give me. Which cartridge we are using here? It's fine then, don't need to enlarge, no, 2.8. So before implanting, I'll just would like to polish a little bit. Oh, one more piece is there. Give me aspiration cannula. That's enough, yeah. So you need to be careful of these UFOs which may fly and, come on the next day or maybe, after a few days.
I think it's more common than what you can imagine, especially when you have a small pupil and hard cataract. Small pieces can go underneath the iris and get caught in the ciliary, the sulcus area, and
Yes.
can cause recurrent inflammation as well.
Yes, true.
So
That's
this
true.
I think we have to keep that in mind and always make sure that you retract the iris and see
Yes.
or look for small pupils.
So usually during that, this irrigation does help in dislodging them so that you are... Okay, now we know that. Lens, yeah.
It's more common with the
loaded the
nozzle
lens?
because the
Okay,
nozzle
give me.
pushes it on either side.
Yeah, that's
So,
what,
yeah.
yes.
So it can, because it's working on both sides and small pieces can go underneath the iris and get caught, especially when you have small people, you can miss it.
Yeah, so I'm going to use, which lens is it? T7? T6? Which model is this? It's T7, yeah, it's T7. So you can see these three holes which are, three marks which are there, laser marks. So you need to align them with the steep axis. Can I get forceps, please? Yeah.
Injector, rotator, push.
Pusher. And I need थोड़ा IOP बढ़ाइएगा. Oh, it's fine, yeah. Irrigation, yeah. Is it focused there?
Yes, it's well focused.
And I need Kugelens hook. Dialer, lens dialer, yeah. No, this is not dialer. Other one? Yes. So now the IOL goes in the bag. And I'll need to rotate these marks to it was almost 4 degrees or somewhere, no? 4 or 6. Yeah. So you can easily rotate if you overshoot it. So okay. So we are there now. You can see. Can I get a ring, please? Ring. So you're almost there at 6 degrees. Hydro stitch, yeah. So this is the modified hydro stitch cannula, which I routinely use. It has the advantage that you can easily reach all the walls of the incisions by just rotating your hand.
It's a very ergonomic design, basically.
Yeah, so especially for topical cases, it's very good. It's 27 gauge cannula and it has a 1 millimeter tip there. नीचे देखेंगे थोड़ा नरेंद्र जी नीचे yes so I think you can see it now
Yes.
that lens is well placed at this chamber is well formed and always be careful that you always keep on looking at the lens when you are taking off the speculum बस खुली रखेंगे आँख को नरेंद्र जी बहुत अच्छा हो गया है and you always zoom down and watch that finishes the case. Thank you very much. Any questions
Beautiful.
from the audience?
Congratulations, Dr. Harshul. It was a very beautiful demonstration of
Thank you.
all your techniques and also instruments.
Thank you so much.
One of the
खोल
benefits,
लीजिए आँख खोल लीजिए.
one of the benefits of doing hydroimplantation, because I have seen since morning all the
Yeah.
surgeons prefer to do hydroimplantation, but I think in toric it has a particular advantage.
Yes, because any residual OVD behind the IOL can cause post-operative rotation of the toric lens. So it's very advantageous.
Absolutely.
So I described this technique in 2010, hydroimplantation. It was published in Journal of Cataract and Refractive Surgery.
Absolutely.
And
I
I'm
think
so
that-
happy that it's been 12 years and now more and more surgeons, almost I keep on seeing that 70% of the surgeons are using hydroimplantation. It saves you time as well as it saves you from the side effects of the OVD, HPMC, which is most commonly used. It prevents early capsular bag distension and inflammation also, you know,
Absolutely.
in the eye.
Absolutely. I
So
think it was-
especially for toric lenses and any premium lenses.
And you have been using now earthly for a very long time, as we know, and today you had experience of using also Centurion.
Yes.
Like, what has been your experience about that?
No, it's a wonderful machine. I always done live surgery here in MM Joshi on Centurion. It's a very nice machine. Especially the cutting and the cutting of this machine is very good. Yeah. So CD was just 4 seconds. That's what he's saying. Yeah, in this case.
Wonderful surgery, Arshul.
Thank you so much, Dr. Mohan. Oh yes.
He wants to. What word should be Dr. Saab?
Thank you. All well. All well.
बहुत अच्छा.
It went up perfect.
सब समझ आ रहा था मुझे.
जी जी जी.
डॉक्टरी लाइन मेरी नहीं है, लेकिन फिर भी कुछ ना कुछ तो अच्छा लगता है.
Perfect.
First time we are seeing live the patient congratulating the doctor.
No, this is the trust of Mr. Narendra on Dr. KP that yes, he allowed us to operate and that's great of you. Yeah, and everything is perfect.
सारा दिन मुझे ड्राइवर और क्लीनर के साथ में डील करना पड़ता है. डॉक्टर के साथ भी डील करना है. बहुत खुशी हुई.
Amazing.
Thank you very much.
Arshul,
Right.
do you patch the patients,
No.
toric patients?
No sir.
And do you keep them for 1 or 2
Yeah.
hours?
Yeah. Not any patient. We don't patch any
You
patient.
discharge
Sir.
them immediately or you keep them for a couple of hours? And
Just 1 hour, sir.
1 hour.
So we start all the topical medications after 1 hour and we instruct them how to put medicine and then we let them go home.
Okay. And
Yeah.
Dr. Harshul, if somebody has a high myopia and high axial length, now there are some proponents of using CTR in
Yeah.
those patients along with toric IOLs. So is there a cutoff that you have? Do you use CTRs in some patients?
No, I've never used and I've done a lot of high myopia with toric, but the beauty of this, especially Alcon toric lenses, especially Alcon platform, is that it's a very techy material. So once it goes in the capsular bag, after a few days it gives a good addition to the capsular bag. So I've done high myop also. They are doing, all are doing very pretty well. No, yeah. So I've never used CTR, but of course there are people who
Vardhaman,
actually,
I want how the CTR is going to help.
So the hypothesis is that because it's a very large bag, it's a highly myopic eye. I mean, they use it if the axis length is more than 26 millimeters. So if it is more than 26 millimeters, the bag is very high, so the chance of rotation increases. So the CTR makes the, let us say the...
CTR will stretch the bag more, no?
Sir, it
Sir,
means
it's actually-
not because yes.
Sorry, can I chip in?
So the dimensions of the bag, so although the CTR will kind of give a buttress around 360 degrees, but the hypothesis is that it is going to make the shrink wrap mechanism of also the capsule much better, so the adherence will be faster, and the space inside the lens will also be slightly lesser, and in the lens capsule will also be slightly lesser. So maybe it is a tighter placement of the lens. That's a hypothesis.
It's actually the shrinkage
But I
of
would
the...
say that, please, I would echo what Ashul says.
Right.
Acris of toric material is totally different from
yes,
all other
yes.
torics.
Absolutely.
True.
I think it's in one level, all other torics on a different level.
Yes.
Altogether, I think even high myopes, please don't overinflate the bag.
Right.
Okay? And I always keep these patients for 2 hours and ask them to lie down flat.
Right.
Especially high myop patients, if you don't want the lens, because the rotation of the lenses is the highest in the first few hours after surgery.
Absolutely.
And I check the patient again on slit lamp and then send the patient.
Absolutely.
Vardhaman, am I
patch them
audible?
for 1 or 2 hours, or 3 hours. Also.
Absolutely.
Even Dr. David Chang has published it that he doesn't even want his patients to walk to the parking area. He wants them to lie down for 2 hours and then, especially the story cases.
But Dr. Mohan Rajan, I never felt that it makes any difference, because we never care whether patient is lying or he is supine, sitting. So, are there studies which have proved that no patient should lie down
There
on
are
the...
studies which have proved that the rotation, if at all it takes place, within the first
few hours, I think
First hour is and it ranks among 80%. But they have not specified the material and the design of the IOL, of course, and Acrisoft, as we've already discussed, it has a very good track record. The other thing about the capsular bag size, I think when the shrink happens from all around, if you have a larger bag and it shrinks from all around, what happens is it pushes the optic a little forward. Either the whole optic goes forward or one part of the optic goes forward. If one part goes, then it causes a tilt and induces cylinder. If the whole optic goes forward, then it induces a sphere. There is a myopic shift. But with the Acrisoft, again, since they have a stable force haptics, which they actually act as shock absorbers, even if there is a shrink, and it fits in all sizes of capsular bags. So even if it has a shrink post-operatively, since at the optic haptic bend, they have that spring load effect already generated, which keeps the optic stable even if the haptics are squeezed in. So that's the reason why this doesn't happen. The implantation of a CTR in high myopics is not something that I always do, even I do, or I would recommend. However, if you do have a chance of looking at the zonules and evaluating them, and if you think that they are weak, particularly all around, or even if it's in one sector, and you're planning a toric IOL, and the toric requirement is high as Harshul's patient moments back, then I would definitely recommend a CTR to be placed, because then you would not have these cylinders behaving stable. The post-operative astigmatic drift might happen. So if you have one sectoral zonular weakness or weakness all around, if the patient has a pre-existing disease which is likely to render the zonules weak, then it's a good idea to put in a CTR before putting in the toric IOL.
Can we have the lights on, please, here in the hall? As the next surgeon gets ready, I think we have our keynote address, FACO challenges, from our own Rajnikant of ophthalmology, Dr. Mohan Rajan.
Dr. Mohan Rajan, incidentally, is my batchmate in Shankar Netralaya. I was doing my retina fellowship while he was doing his comprehensive ophthalmology fellowship. And from then on, I know him, and he's been a very dynamic man. He started carried on his father's, he's a second generation ophthalmologist in Rajan Eye Care. and has done a wonderful job. It is figuring in the top 10 hospitals in the country today. He's a very versatile and multifaceted person, and I think he's a great entertainer in the OPL, the OPLs that we have in our conferences nowadays. I think must have all experienced. He has got a record 55 or so, 58 or 55, I'm not very sure about the figure, but in all of them he has been the winner. So that I think is a very great thing about him. He's a multifaceted person, and I'm sure we're all going to benefit from his talk today. Thank you for coming to Hubli, Dr. Rajan, Mohan Rajan.
Thank you.
Please continue.
Yeah, good morning, ladies and gentlemen. Let me at the outset thank MM Joshi Eye Institute for the wonderful hospitality, love and affection they always show. Thank you, GP, my very close friend. In fact, GP was the first person to know about my affair with Sujata, so I have very special regard for him always in Shankar Netralia. And these are my financial interests. These are the golden moments, in 2017, when I got SPB here for a concert. I thought it will be a concert like in the room, but it was like an IPL match, about 17,000 people were there in the open stadium on the Golden Jubilee anniversary. It is a real golden voice of SP Balasubramanian, who is no more with us, but it was really a fantastic, then I knew the power of, at that time, of MM Joshi Eye Institute in this area, in this entire Karnataka. Really fantastic. It was a really awesome experience for all of us. And I was made the chief guest when the former chief minister of Karnataka, Jagdish Katar, was a guest of honor. So MM Joshi sir said, no, you are the chief guest, Sir, so chief minister is there. No, you are the chief guest. So he'll be the guest of honor. So that was the love and respect he had for all of us. And I'm going to show you the next few minutes about the various scenarios as far as the phaco challenge. Phaco itself is a challenge, and every situation is so different. The difference between an ordinary and extraordinary surgeon is how you manage the complications and still give good visual acuity. So this is an Argentina flag sign you can see here, very, very common in type 1 intermittent cataracts. The type 1 intermittent cataracts are cataracts which have got very high ventricular pressure. The type 2 and type 3 don't have much, but type 1, as soon as it touched, it will go to the periphery. But the problem with this Argentina flag sign is that you can lose the nucleus because it can go across the equator. You can see here, this is another patient who had a Argentina flag sign. You can see this is a member of parliament, and which operated. He wanted a multifocal lens. These guys commit a lot of sins and come to you, and as soon as you touch the cornea, the lens, it goes. The physician was watching through the side tube. So I just came back from Brazil for a conference. I said, this is a new technique I learned in Argentina and Brazil. So this is called the Argentina flag sign. He didn't even understand what it is. But what is important is how to prevent this Argentina flag sign. You can put a 27 gauge needle into the you can see here how I'm trying to do that, 27 or 26 gauge, and aspirate the front of the front compartment, and then go ahead and do put a blue Rex, and then go ahead with the Rexes in the usual way. And this will take care of the Argentina flag sign in about 50% of the cases. If you have access to the femto Rexes, we are talking about lens X and catalyst. This is probably one of the best ways to do it. And most of the patients I do this as well. Or you have access to Zepto Rexes. How many of you are having Zepto here? Yeah, Zepto is also, only thing is it's sometimes in shallow chambers because it's more or less an invasive, but it creates a beautiful rexes like this. You can see, this is another patient. You can see here how this Argentina flag sign, I've done a lot of work on this before I developed a technique called puncho rexes. You can see there is a pressure underneath the anterior capsule, there is a bulky nucleus, there is a pressure in front of the posterior capsule, there is also positive vitreous pressure. These are the 4 components you have to take care. So these are when you put a 27 gauge needle into the front compartment, what happens? It takes care only of the front, that is the anterior this thing. So if you do a puncho rexis, that is go with a phaco needle, either a 0 degree or a 15 degree bevel down. You can see these are the vacuum parameters I use. continuous phaco power, you can just punch the anterior capsule. Same time, give a burst of phaco power which will debulk the nucleus and push the nucleus back. You can see here again in this particular case, I put Blue Rex there. Don't use very high molecular weight viscoelastic. Don't use Hyalon or Viscode or anything that will occlude the tube. You don't want anything to. Just use simple HPMC. Go vertically down. If you go tangentially, then you will develop an Argentina flax. And do vertically down, very simple technique. Go all the way down on a foot switch, that is the punch. If you punch it, then you punch the anterior capsule, then you will 200% of the time you will not get any Argentina flag sign. If you have a rexus which is escaping to the periphery like this, you can see here, as I am doing this, the rexus is escaping to the periphery. So going beyond the 7 millimeters area, if you go beyond the 7 millimeter area where the anterior zonules get attached there, then it's more likely to lose the rexus there if you go in the same way. But pull it in the same direction, okay? Pull it in the same direction. This is called the little rescue technique. Pull it in the same direction. You can see here, and you can, yeah, I'm just showing that to show you that if you pull it in the same direction, then you can retrieve this rexus, and this is called the little Brian Little of UK, which developed the technique. Many of you have seen dense brown cataracts is like a piece of granite inside the eye. You can see here, the very, seeing many of you do ECC or SICS, probably a good idea to do it, but if you do that, if you use a lot of phaco power, you can end up in a corneal burn like this. These corneal burns are, please don't underestimate these corneal burns. This can be very dangerous. The corneal burns can cause irregular astigmatism, wound gaping, infection, endophthalmitis as well, and it's very difficult to close these corneal burns. You can see here, I'm putting multiple sutures to close this corneal burn. So this is one another. Again, you can see here I'm putting arcuate incisions. These arcuate incisions, you can see how it's leaking, these arcuate incisions. I put it on the femto. This patient had a very dense brown cataract as well. Please don't go ahead with the phacoemulsification. When you have a leaking incision, please close it down. Close it down, then go ahead, because this patient, if you try to do these things, the chamber is going to be shallow, and this got a very dense brown cataract, and you will have a white cornea the next day, and you will have complications because the posterior capsule can keep coming forward, and all these problems can occur. So always close this incision, make sure it is watertight, and then go ahead with the phacoemulsification, and this patient did very well. I'm just going through quickly because I don't have much time. The descemetous membrane detachment. I'm sure many of you have seen this corneal edema on the day 1 on a grade 2 cataract. If you see a grade 2 or a grade 1 uneventful surgery, when you have not used much phaco energy, and if you see limbus to limbus corneal edema, there are two things you have to think of. One is the descemetous membrane detachment, another is a TAS, okay, toxic anterior segment syndrome. If it's TAS, it's going to be use of topical steroids and systemic steroids as well. But if it's going to be a descemetous detachment like this, and you can see, if you have access to AS OCT, probably you can seek the descemetous detachment and go ahead. This is a pre and post-operative, that is post air bubble into the anterior chamber. You can see this, I'm using just injecting air bubble. You can see the descemetous detachment here. Don't allow it to wait for a long time, because see it early, because otherwise you can I see patients refer to me after even 1 month or 2 months we have done it, but still this is something which you have to, we have to keep in the back of the mind. When you have corneal edema like this, and always do an AS OCT to find out if there is descemetous detachment. Unknowingly or knowingly, this can happen during surgery as well. Posterior polar cataract, I'm sure Ashul Tak is going to talk about it. I'm going to just go through. Look at the fellow eye. If you have a posterior polar cataract, mature cataract in one eye, look at the fellow eye. This is very important. This is a very important golden message I want to give. If the fellow eye has got an AC IOL or a PC IOL in the sulcus, or an iris claw lens, or a glued IOL or something like that, it probably has a posterior polar cataract. Or ask the patient how much time it took for surgery. He would have told me that he would tell you normally it takes about 10 minutes for surgery. This patient took about 1 hour, probably the nucleus would have gone inside. So always look at the fellow, ask the history, is very important. This is a posterior polar cataract, little older patient. I'm doing rexus. The rexus is a very important thing, make it about 5 millimeter. Why 5 millimeter? We don't want a bigger rexus, because if you want to do optic capture, you can't do that as well. So this is a hydro delineation, no hydro dissection. The 3 conditions, I will not do hydro dissection. One, the posterior polar cataract, previous vitrectomized eyes, and patients who got traumatic cataract as well. You can see I'm trying to go ahead and do the phacoemulsification slow motion technique using low flow parameters. And you can see here, as soon as I remove the epinucleus, you can see there's a huge defect on the posterior capsule. These defects are very, it's not like a posterior capsule rupture. It's like a pre-existing defect. It's like two pillars on the posterior capsule. Always use tricot, preservative-free tricot. Because unless you use tricot, because vitreous is a colorless substance, and unless otherwise you are a vitreoretinal surgeon like a GP, he'll be able to see vitreous even in the middle of the night. But I'm just telling you, anterior segment surgeons always use tricot because it can delineate the vitreous much better. Just you have to remove the vitreous which is there. Always use a bimanual technique. Once I have a posterior polar cataract and PC rupture, I always go in for a bimanual. Bimanual means separate the irrigation from the aspiration, separate the irrigation from the cutter. So that is again always remove the vitreous first and then go ahead and remove the cortex and the epinucleus. Don't try to remove the epinucleus and cortex in the presence of vitreous, because every time you remove the epinucleus and cortex, you'll produce traction on the vitreous base. So always put a multi-piece lens, because it's like a say if you try to put a lens in the bag, it's going to go into the posterior segment the next day. You can see here, I'm trying to put this multi-piece MA60 lens, and then I don't leave it in the sulcus. I always lock the lens. It is very important to lock the lens. Why? So you have to be, if you lock the lens into the capsular rhexis margin, that is the haptic is in the sulcus, the optic is in the rhexis margin. You can see the ovalization of the rhexis margin is a final endpoint for you. This lens will get locked permanently. It will not move a micron, no Idiot syndrome, no secondary glaucoma, no inflammation, no decentration as well. You can see here 2 months, 6 months, 2 years, and this doesn't move a micron. Again, posterior polar, all the posterior polar cataracts nowadays I'm doing the femto, even if the patient cannot afford, because femto has better control. Girl with a posterior polar cataract, I went ahead and did a purposing, and then you can see there's a dense plaque on the posterior capsule. These plaques are very difficult to YAG, okay, because you require a lot of YAG energy. So what I do is just do a plaquectomy. So just try to remove the plaques gently, and sometimes you can use a bimanual technique as well. You can see I'm trying to pull the plaque without damaging the underlying posterior capsule. I'm using a bimanual technique also, and this patient I put a symphony lens and the patient did very well. These are the pearls in the PPC, peribulbar anesthesia, rhexis. Do not attempt to rotate the nucleus, inject viscoelastic every time you come out of the eye. So black cataracts, many of you would have probably phacoemulsification, ECC or SICS. I always do only phaco in this way. In these patients, you can see here, this particular case, I have a few more minutes to go, GP, and so this just to show you this black cataract, I'm using my chopper. This is a Mohan Rajan chopper. I don't have any financial. It is made by Apasam. You can see how it breaks up the nuclear. This thing, it's a 2 millimeter chopper. It is available as 1.75, 2 millimeter. 2 millimeter is what I recommend for the black cataracts, and you can see here how it goes in and opens up the posterior nuclear plate. If you want to stab somebody in the abdomen, you can use this 2 millimeter chopper. It's a multi-piece chopper as well. You can see here this IFIS, very common in patients. Patients don't tell. Go into the history. Patients don't tell. There's no point in stopping the medication. In fact, stopping is dangerous. Can produce urinary retention. IFIS is something which you have to keep in mind always. There's something which you can see here. Whenever you see IFIS, when your patient has IFIS less than 6 millimeter, straight away start using the pupil retractors, either a malignant ring or this thing. So anticipate PCR in traumatic cataract. You can see this is a hydro rupture. That is, every time you do a hydro dissection, you need to decompress the nucleus. You can see here, I'm trying to give a hydro dissection, but I don't decompress the nucleus. You can see how the anterior nucleus, anterior capsule opens up, and this can extend to the posterior capsule, produce a hydro rupture. When you have a PCR, you can see when you use a coaxial elimination, coaxial irrigation aspiration means the irrigation aspiration of the same port.
Switch it off.
So this is what you should not do. When you have PCR, many of us become jittery. You may be operating on a VIP patient or a doctor. So what you should not do is to do not pull out. Do not pull out. You can see here, when you have a PCR, you have a tendency, when you see the PCR, you get jittery and pull out of the eye. When you pull out of the eye, what happens is, vitreous is like a tsunami. What is a small PCR? Becomes a huge PCR, and the entire vitreous starts coming into the anterior chamber. The nucleus starts going into the vitreous cavity. Immediately I shift over to the bimanual technique, which is again very, very important. You can see here another patient with the posterior polar cataract, and I'm trying to remove epinucleus, you can see I inject viscoelastic, preferably viscode will go and plug it and then immediately shift to the biomanual. Okay, from coaxial immediately shift to the biomanual and then take care of the vitreous first and then take care of the epinucleus and the cortex. And just to show you that if you have PCR with femto, it doesn't mean that you will have technology, you can get away with the PCR. Just to show you this, femto patient had a PCR also. When you have PCR, what happens is the pupil becomes small. Always use iris hooks before you put the lens in the sulcus, because sometimes you do not know whether you put the lens in the sulcus, and sometimes it can go into the this thing. Nucleus drop, again, the predisposing factors. This is a patient with nucleus drop. If the nucleus goes inside completely, then you need to go refer it to the vitreoretinal surgeon. We have the vitreoretinal surgeon backup. I myself is a VR surgeon, and we do that. But if you are anti-segments, if you have something like this, wherein the nucleus is there in the pupillary area, I can do what is called the anterior assisted levitation, and then go ahead with the lens implantation of choice, either an iris claw lens. In this particular case, I put a AC IOL, and this is to show you this AC IOL in this particular patient. So these are other factors, other things which I wanted to tell you, but I was running short of time. I will just stop here and go to the last slide of mine, which is again just to show you this intraoperative zonal dialysis which can occur. Microspherophakia, this is a dislocated lens, and of course the ocular episotomy, everybody will be knowing by this technique which I have demonstrated. You can see here, this is a green injector. This green injector, sometimes the haptic can get caught. Okay, the haptic, try to pull the haptic, the entire lens can get damaged and you need to expand the lens. So just take a simple 11 blade and open up the cartridge. This I call it ocular episotomy. Episotomy, I am sure everybody is familiar with when you are doing your OG postings. So take home messages: phaco complications, prevention, recognition, management, and optimum results. And take home this thing is JRD data said, strive for perfection, you will reach excellence. Thank you very much for the wonderful opportunity and the patient attention. And again, I would like to thank Joshi Eye Institute and all the people for the thing. I would like to give you a message here. I am standing for the post, as you all know, for the Vice President of AOS. Next month is the month of May is the online elections. This time it's completely online. I'm available, accessible, approachable for you. And I have 3 decades of service in the AOS. This is a color atlas of retina and optic nerve, which I'll be presenting now, probably when Joshi sir comes. And if you have, this contains about 350, 400 photographs, all from our Rajan Eye Care fundus camera, and high definition photographs is like spotters. Any of you wants this, please message me or call me. I'll be able to send a book to you. Thank you very much for the wonderful opportunity and the patient attention. Always love the entire Joshi family.
Thank you so much, sir, for the wonderful presentation. It's always a joy to see your videos, especially the puncto rexes, which is a novel idea. Thank you so much, sir. I think we move to the live surgery.
Yeah, Dr. Shilpa.
Can we have the...
Am I audible?
Over? Yes, you're audible.
Okay.
We can see you now.
Yeah. See, this is another EDOF lens from Care Group. This is magnificent. Okay, the features are similar. This is a hydrophobic lens with a yellow chromophore. So, loading is simple, like how we load the other monofocal lenses from Care Group. Okay, and then the only thing is this haptic has to be bent over the optic, otherwise it will get caught between the plunger and the injector. So lock it. It's a uniplanar lens. It is extended EDOF lens, that's what they say, and highly economically priced, and we can suggest it to all those patients who cannot afford the multifocal trifocal lenses from imported companies. Expensive as far as the cost is concerned. This is okay. So now light nodima, light nodtare. So now here the surgery is emulsification is over. All I have to do is just implant the lens. please tell me if it is centered there or not. Centered.
Yes, it is centered.
Okay, right.
Centered
So here under BSS, I am going to implant this. It is a modified C-loop lens, that is for better stability. So all you have to do is just guide the leading haptic to open up towards the left hand side and gently in jerks push it. Now push the entire thing into the bag. Wait for the lens to unfold. You see this? Beautifully it has unfolded. So this is the magnificent, the extended EDOF lens from Care Group. Now one word about the rexis size. It should be about 5 to 5.5 millimeter as far as circular. That's the reason why today we talk about flax or Zepto, like Dr. Mohan Rajan said, where you get a centered, that is important. Light node, ಸ್ವಲ್ಪ ಕೆಳಗೆ ನೋಡಿ. So that is important because once the fibrosis takes place, the lens should not get decentered. If decentration is more than 0.5 millimeters, then again the patient will have problems because of the angle alpha. Okay. Yeah. So with this, any questions?
Sir,
Yeah.
wonderful demonstration, especially
Thank you.
Trying to very slowly unfold the lens and trying to keep the lens in the bag using the irrigation cannula.
Yeah.
That was really very nice.
Thank you.
Sir,
Yeah,
this
yeah.
lens we can see a hole there
Yeah, this.
near the optic haptic.
Yeah, that is for the centration, better centration, and nothing else. Or maybe you can dial the thing, but I prefer to put the dialer at optic haptic junction, so that gives a better stability while dialing the lens. Yeah. Okay. Thank you very much. Anything else, Dr. Shilpa?
Anybody in the audience, any questions?
Thank you. ಆಪರೇಷನ್ ತುಂಬ ಚೆನ್ನಾಗಾಯ್ತಮ್ಮ.
Deliberative 3D.
Yeah. ಒಂದು ಅರ್ಧ ಗಂಟೆ ಪಟ್ಟಿ ಕಟ್ಟಿದ್ದೀನಿ. ಆಪರೇಷನ್ ತುಂಬ ಚೆನ್ನಾಗಾಯ್ತು ರೀ. ಸೀಮಂತ್.
Thank you, sir. Okay, thank you. I want to thank, I think we are going to finish this cataract 2D, 3D session now. Our next session will be 3D retina. So I want to thank all the moderators and all the chairpersons who have chaired this session and have shared their knowledge.
Now this session we'll be seeing Srinivas sir operate, and it will be chaired by Dr. Guru Prasad and Dr. Vishal. So I request you to please come.
Give one mic. Rajeshri, you can come this side. Rajeshri, come this side. You read they will give you the mic, you can read the case.
So this is a case of a 30.
First ask them, are they able to hear you?
Am I audible? Am I audible, sir?
No, we can't hear you. Your mic is off. Your mic is off, Rajeshri.
Ma'am, go ahead, ma'am.
Am I audible?
No, no. Speak louder.
Am I audible? Am I audible?
Yeah, we can
Yeah.
hear you.
So this is a 36-year-old male who presented with us with left eye diminished vision. He is a known hypertensive with an uncontrolled blood pressure of 140 by 110 millimeters of mercury, which got controlled eventually. So he was diagnosed with left eye sub-ILM hemorrhage, for which he is going to get operated by Dr. Srinivas Joshi, sir. Over to you, sir.
Good morning. Are you able to hear me?
Dr. Vishal?
Hi sir, morning, how are you?
Yeah, good. Can you just increase the auditorium volume, please? It's very feeble here.
Are we heard, Dr. Srinivas? Can you hear us?
Yes, sir. Guru sir, I am able to hear you.
Right. So, Dr. Srinivas is a very prolific surgeon, a high volume surgeon present in the present day, and he is also a recipient of several international awards, of which 5 are Red Buckler Awards from the ASRS, all consecutive awards. And I think that is testimony to his surgical skills. You will see his surgical skills today in the life surgery. And I'm very happy to have with me Dr. Manisha Agarwal as well.
Okay.
Dr. Srinivas, this is for your information.
Okay, great.
She is also
She has joined.
to moderate this life surgery session.
Very nice.
Along with, of course, Vishal Govindhari.
So I think Dr. Rajeshri has already spoken about this case. So here I have with me Sister Shanta, who will be assisting me today. Dr. Rajeshri will be our assisting surgeon. Can I have the... So I am just doing a 25 gauge vitrectomy here. So 4 millimeter forceps, 4 millimeter from the limbus. This is the Alcon 25 gauge system. So this is what we are doing is the 3D. So I request everybody to wear the 3D glasses. Infusion on, stop. So I just check my infusion always. Yes, plaster. So the advantages of the 3D visualizations here, I think Dr. Giriraj, are you there?
Yes, sir.
Can you just tell a few words about the 3D Ingenuity color channel, what we are going to use? Forceps. Yes. Yes, you are audible.
With the latest Ingenuity 1.4 software, we are privileged to have multiple color channels to help us in our surgeries. We have blue color channel, green color channel, monochrome, reduced red, and various sorts of color temperatures to assist us in the different steps of the surgery. As we did literature search, and it has been said that some of the color channels help us in visualizing vitreous, some help us in visualizing the ILM, and soon enough
inverter.
We are going to start our own thing on that. So in this, Dr. Srinivas sir will demonstrate those color channels, how those are going to help us. Sir is doing par focalization. It is part of the Ingenuity system to help us get the most out of the depth perception which is available to us.
So this is the Sub-ILM hemorrhage which Dr. Rajeshri was mentioning about. So the patient is a known case of hypertension, but now his hypertension is under control, and so this ILM was not resolving. We waited for a week or two. So since it was not resolving, then we thought of posting it up for the surgery. I welcome Dr. Manisha madam also. Has come from Delhi, and Dr. Pooja Sinha has come from Patna.
Hi Srinivas, good morning.
Yes, yeah, good morning madam.
So I just wanted to ask you that any specific reason why you thought of doing a surgical intervention and not do a YAG hyalodotomy for this?
Very good question madam. Actually, so this is, we thought of doing this intervention, but few literatures and reports have suggested that pre-hyaloid hemorrhage, the YAG hyalodotomy works the best. We have sometimes the risk of causing a retinal hole, especially in the sub-ILM bleeds, and also the retinal detachment formation also, as stated by Gabriel et al., a very well-known study which has shown about, although there are very rare occurrences of sub-ILM bleeds, but I think since it was not resolving and covering most of the posterior pole area, so that is when we decided to go ahead with a surgical intervention in this case, madam.
Right.
So this is Vishal here. Did the patient have any trauma by any chance?
Yeah, I did ask that very well, and the patient did not have any incidents of trauma. So this is, no, don't move. Alagad battery, Dayamati alagad battery. So this is what Giraj is showing you about the color channels. Now we are operating it under green. So under green you see the vitreous a little more clearer, and now you can see the sub-ILM bleed. And we have another option called as reduced red. So that actually helps the vitreoretinal surgeons a lot, especially when it is a bloody retina or where there is too much of blood. So here, I don't know if you are appreciating it on the silver screen there, but on the OLED screen here, that is called as organic light emitting diode screen, I am able to appreciate the color channels more better. Can I have the IVT? So there was no history of trauma in this case, Vishal.
And
so I'm just doing using an IVTA to stain the vitreous. Can we switch off that light?
I would like to know from Dr. Manisha about the difference in safety levels when it comes to YAG hyalotomy between subhyaloid hemorrhage and subintimal hemorrhage.
So usually we would prefer to do a YAG hyalotomy for a subhyaloid hemorrhage. And I would agree when Srinivas also said that when we are seeing a sub-ILM bleed, probably it's better to opt for a surgical intervention. And, sorry?
Even if grossly elevated.
Yeah, and of course if it is grossly elevated, then of course the safety goes up. You
So
are
here I'm
more
just
in a
doing
safer zone.
a PVD induction here.
Wonderful, Srinivas.
Thank you, sir. So the PVD has been induced now. Now after this I'll straight away go ahead with staining. Now you can see the vitreous. Giraj is just changing the different color channels. Now this is the green channel. Giraj, you can go to the monochrome, showing different color channels.
Wonderful.
So this is the monochrome. As you can see, the monochrome here, you can see the edge of the ILM pretty well. The stained ILM you see very well, especially when you take this monochrome. And you see the choroidal vessels so neatly, so clearly. And again, I am really sorry if you are not able to appreciate it on the silver screen there, because it's very difficult to emulate 14:9 OLED screen in the auditorium. It costs crores of rupees.
It's beautifully visible, Srinivas.
Okay, thank you, madam. So this is again in the blue mode, but I don't like the blue mode, although some of the papers have suggested that in the blue it is seen, but it differs. What I would like to say here is, in the color channels you just need to play with these colors. If you love photography, I think this is the best way, the best instrument for you is to use this the 3D visualization system. Not just the color channels, you have something called as the temperature scale here. I'll be just showing it. Giraj, can you show the temperature scale? So how you have in the house automation, you have the cool colors and the hot colors. So similarly, now we have it in the 3D visualization system also. See, now you can see the color is at around 6000 Kelvin, which is a hotter color. And now we will slowly move on to cooler colors. So again, that's a kind of advantage you can have when you are not able to see these few kind of membranes very properly. So you can, and another important parts of these 3D visualization system is the saturation and the hue. and the yellow. I'll be showing the yellow contrast very soon while doing the ILM peeling. Why yellow? Yellow increases the contrast sensitivity. ಅಳಗಾಡ್ಬೇಡ್ರಿ, ಆಪರೇಷನ್ ಆಗ್ತಾ ಇದೆ, ಏನಾದ್ರು ತ್ರಾಸಾದರೆ ಹೇಳ್ರಿ, ಹಂಗೆ ಒಮ್ಮೆ ಅಳಗಾಡ್ಬೇಡ್ರಿ. So you have something called as I was telling about the yellow contrast. Yellow cuts all the blue light. So that's why it increases the contrast sensitivity which comes from the eye to the camera. So that's the advantage of the yellow. And apart from that, what you have is the gamma, the saturation and the hue. You need to mention it. So this is what you can see is the yellow color. You can see the contrast increases, the contrast is slightly better. Can I have the BBG please? So here I am using something called as the brilliant blue green dye, just to stain. Since it's a sub-ILM bleed, I need to take out the ILM in this case.
Srinivas, in RTO also you have the color channels?
RTO of Zeiss?
Yes.
I am not sure, sir. I think Manisha madam may be knowing because Shroff people have that.
No, I don't think it has these color.
No, color channels I don't think it has.
Okay.
Srinivas, do you commonly use a 25 gauge or would you have preferred a 27 in this case?
I thought of using a 27 in this case, but I thought if it's a subretinal hemorrhage also, then I have kept the TPA ready. So again I have to convert from 27 to 25. So I thought I'll just use the 25. Otherwise 27 also would have worked really nice in this case. Flat lens please. Now while on the Intra-op OCT of the Zeiss, but
you can very well appreciate the blood moving around from the time you've induced
inside.
the PVD.
Yes. No. Can I have my own this thing, not this one. Idu beda nange. Visco. Yeah, I will show it on the Intra-op OCT as well. It's the Zeiss Rescan 700. But one second, I'll just switch off I'll just center it and then you can. So this I have shifted to what we call it as the flat lens.
So does that mean that the ILM peel magnification required is not adequate and you had to shift to a contact lens?
No, nothing like that. I always appreciate that depth perception is better with the contact lens, especially when we are using the flat lens. You are able to see, ma'am, or?
Yeah, it's very nicely visible.
Yeah, just to add to what Dr. Manisha said, I think for this case, I think the Ingenuity system alone, that is the Resight 700 system alone would have helped to visualize. For a macular hole, especially when you're doing, when you're playing with the ILM to do inverse peeling or to stuff the hole or to do an ILM transplant, for such cases, I think we need to have the flat lens. But for this particular case, I think you could have probably managed with the Resight. Dr. Vishal, what do you think?
My experience with the Ingenuity is very
go on
limited,
top.
but
Now you are able to see this on the
Resight,
screen.
It's quite comfortable to sort of handle any of
left
these
side
cases with
Vital.
the 60 diopter lens.
Down. No, take the right side, right hand side of the mostly contact lens ತೋರಿಸ್ತಾ ಇದೆ ಇನ್ನೂ ಅದು. ರೈಟ್, ಕೆಳಗಡೆ ನಾವು ಟ್ರೈ ಮಾಡು, ಫಸ್ಟ್ ಕೆಳಗಡೆಯಿಂದ ಟ್ರೈ ಮಾಡಪ್ಪ ವಿಠಲ್. ಅಲ್ಲ ಅದನ್ನೇ ಹಿಡಿದು ಟ್ರೈ ಮಾಡಬೇಕು, ಕೆಳಗಡೆಯಿಂದ ಟ್ರೈ ಮಾಡಿ ಫಸ್ಟು. ಎಸ್, ಹಾಂ, ಈಗ ಮೇಲೆ ಹೋಗು.
The OCT controls, IOCT controls on the right.
ಇನ್ನು ಮೇಲೆ ಹೋಗು. ಯಾ, ಇನ್ನು ಮೇಲೆ. ಯಾ, now you have to use the left hand now. Once it is centered, then take the left hand. Yeah, ಸೆಂಟರಿಗೆ ತೊಗೊಂಬರ್ರಿ, ಇನ್ನು ಮೇಲ್ ಹೋಗ್ರಿ. ನೋ, ವಿಠಲ್ ಮೇಲ್ ಹೋಗಪ್ಪ. ಎಸ್. Now you take the left. I don't know if you are able to appreciate this here on the Ingenuity screen. No, madam. If not, then I'll move ahead.
No, Srinivas, it's not really
Okay.
appreciated.
No, I think it's because it has to be converted from the OLED screen there. I think it needs a lot of changes in the resolution. Can you just Vittal, plaster, fogging up the glass. Now, can I have the ILM forceps, please? Algat battery, Yajmandra. So I'll switch off the Intra-op OCT part here. Now you can see the ILM. Don't touch the microscope, please. No. Off. Now you can see this is the ILM. Forceps ಬೇರೆದು ಕೊಡ್ರಿ. .25 gauge forceps, please. No, I need a 25 gauge. Is it clear, madam? Or it is slightly...
It's clear, we can see.
Yeah, I remove the tear bubble. Now you can see this in different colors. This is the monochrome where the blood gets reduced. Now you can see the tip of the ILM. I'm not, if you are able to make out. So that gets highlighted. That's what I wanted to show it. Can I have the ILM forceps, please?
Hello, Sri. Hello. Hello, Dr. Srinivas. Yeah.
Yes, any?
Dr. Sanjay Rasal here. Good morning.
Yeah, you can see this ILM edge, Vishal?
Yes, it's quite clearly seen, sir.
Yeah. It's very nice demonstration of the ILM peeling. But is it really necessary to use a flat lens here, because don't you feel the field is getting restricted here at the cost of magnification?
Yeah, change it to monochrome now, Giraj. Yeah, now you can see the one which I was not able to see clearly. Once you stain this ILM, it's clearly visible now. Now you know where is the edge of the ILM, so that it will be easier for you to...
Sir, Guru Prasad sir suggests that you shift back to the re-sight for better field, if it's possible.
It's re-sight only. You mean the lens?
Yeah.
Yes.
Okay, I will do that. I'm just about to finish this, and then I'll show you in that as well. I need a back flush. So this I completely peeled it now. I'll zoom down if you want. Is it better now?
The field is getting very restricted because of the lens, flat lens. Sri.
मजा नहीं आ रहा है यार, जितना आना चाहिए उतना नहीं आ रहा है. Srinivas, please switch back to re-sight. It will be much better for the audience.
Okay, fine. Yeah. Shift it back. Remove the.
So actually, still maintains focus.
I think the contact lens zoomed up too much, no?
Saline heart resistor. It's slightly higher magnified, I agree with you, but as you go on to the macular surgery, you need more magnification, and I always say there is a lot of difference between the silver screen and the OLED screen, what we see here. You are able to see now, sir?
It's much better.
I have the back flush. So I've just removed that ILM. I'll just be trying to clear the blood now.
So Srinivas, if you didn't have to really peel the ILM beyond where the blood was, did you really require staining it?
Good question, madam. Sometimes if you don't see the edge of it, what I usually do is I start from the edge and then go towards that. So identifying the edge in the non-ILM bleed area is what I identify. So if you saw, I started my peel, although there was a kind of gap in between the ILM, I could have just peeled that, but I wanted to first start from the periphery and then go to the center. No, go back to the normal. Please don't change the color channel unless I tell it. See, now you can see this is the whole blood. I am just trying to remove it. And now you can go into the reduced red.
Yeah, it's okay. Oh, that's okay.
Monochrome. So here now you can see the blood is being aspirated. No, please don't change the color channel. So it's almost coming to the end of the surgery. Now you can see the macula looks pretty good.
श्री अभी मजा आ रहा है.
You can go to yellow, Giraj. Now you can see, sir. Guru sir. Is it better now? Dr. Vishal?
It's quite clear, sir, now.
Mask. So now you can see this completely, the sub-ILM bleed has been removed. And I think I'm coming to the closing of the surgery. If any questions, then I can probably take it. I'm just shifting my, this is foggy. Yeah. So you want, Guru sir, are you there?
Yeah, I am there.
Yes sir, you wanted to know something, I didn't get that point.
No. Manisha wanted to know actually. She wanted to know whether ILM staining was really required.
Yeah, that I already answered, sir.
Is answered, okay.
Yeah.
So what is that yellow crescentic lesion in the temple to the edge of the blood?
This one.
Is it a fold? Is it a fold due to redundancy
caused? No, it's not looking like a fold. It's looking something like the choroidal rupture.
No, I don't think it's a choroidal rupture because the convexity is towards the disc and not the concavity.
Sir, you are not audible to me. Can you speak little louder? Please don't talk inside the OT, Gilbert, Babu. Yeah. Yes, sir. Please go ahead, sir.
The concavity is towards, is away from the disc. It's not towards the disc. That's one reason why I feel it is not a choroidal rupture. It looks more like a fold to me from here. Like a retinal fold caused by redundancy, maybe because the hemorrhage was there for some time and that must have caused some stretching and redundancy of the retina causing this fold. I would like to know from Vishal and Manisha also what could be the cause for this fold.
Sir, it's looking subretinal for me here.
It looks little deep is what I thought, sir.
If you see the edges also, sir, then it's going under the blood vessel. So
it's a subretinal,
it looks like a subretinal only.
No history of trauma, no?
He didn't give any history of trauma.
I see something whitish over the disc also, Srinivas.
Yeah, that was because of the disc edema, madam. He had a disc edema because of malignant hypertension, indentar.
But there are no other changes in this eye secondary to hypertension.
No, there are. There is a venous dilatation here. You can see there is a tortuosity of the vessels. There is disc edema and there is
You can see the splinter type of hemorrhages are already seen, madam. Here is one, this is another.
No choroidal hypertensive changes.
So I am just trying to check the periphery, just look for if there are any breaks, especially when we are doing a PVD induction, we have to be very careful and look for if there are any peripheral breaks. Does it look like a break? No, it's at the aura. Okay. So I'm just checking the other half now. Okay. Good.
The thin film of the heme that you still see,
This one, madam?
Yeah.
Yeah, that is the edge of it. That's the stained one because the patient was admitted to control the hypertension and we had to wait for nearly 2 weeks. So by that time, that's why I said operating on him was a better choice, was because it was not resolving, and secondly it was already causing the stain, and for the interest of the other people here, the iron or the heme, which is very toxic to the retina, so most of the surgeons prefer to operate it and remove this blood as early as possible rather than waiting for months together. As we all know, either it's a sub-ILM bleed or the subretinal hemorrhage are known to cause. But if it was a subretinal hemorrhage, again the treatment plan would have been different. If it was a subretinal hemorrhage, I would have done vitrectomy with subretinal TPA injection and then use a pneumatic displacement, that is the gas, to do that. So now I have done a fluid air exchange, which is my routine. I do it in almost all my cases. That's it. Thank you very much.
Congratulations, Srinivas, on that wonderful surgery. It was really enjoyable, especially with the 3D and your extremely deft hand. Just a question, I think before you removed the cannulas, I should have asked this question. Why was it air-filled, and that too completely air-filled at the end? Filling with air, I can understand you want to get rid of all the debris which would have got dissipated in the vitreous cavity and make them go to the bottom of the vitreous cavity, and then there's a chance to remove it. But again, allowing some fluid to fill the vitreous cavity, I think would be a better idea. What is your reason for filling it up with air and keeping it in a phakic patient, a young phakic patient who would probably
the air goes off in a 3 or 4 days. But to be very frank with you, sir, I had a very bad end of once in a well set up case. But I don't say that in the fluid there will not be, the reasons are different, but I've learnt it from different mentors, and I've adopted the style of going ahead with the leaving the fully air filled. As you said, you have in your point as well, any of the debris, especially if it's a silicone oil filled eye, when we remove the silicone oil and then we do a multiple fluid air exchange, we do a skimming kind of technique where usually the silicone oil floats on the fluid and then we remove it, and in those cases also I leave air filled. And in this case also, if there are any residual hemorrhages just around at the edge of it, so I would like to ask him, and since some people say there was a little bit of fold on the nasal side, so putting an air filled also might give a short term tamponade for this patient, like ironing out of this. So these are the few things which I thought that I should leave it air filled in this case.
What do you do, Dr. Manisha, Dr. Vishal?
Sir, I normally do an air exchange, and that's a total air exchange. Yes. I actually would like, because my experience relatively is lesser compared to yours, with the air exchange, the cataract rates are much lesser compared to, let's say, a gas.
Yes.
So we don't find so much cataract, though your point is very valid that the air touching the PC does instigate the cataract formation. But we've not found that the air exchange patients develop cataracts as much. But I would like your experience. And
early rosette cataracts are what been reported, but they usually go off once the air goes off.
Yeah.
So usually we see in C3F8 kind of patients, we see the cataract formations happening. But even with the SF6 also, I have seen not much of cataract formation happening, but air stays very shorter time. And I think even the temporary tamponade, what is required, I think really helps the patient. That was my only idea in this case. Any other suggestions? I would have loved to know.
I probably would not have done a fluid air exchange at the end, especially in a case like this, and I would agree with sir that young phakic patient I probably would prefer leaving saline, because at the end of the day it is going to aggravate the cataract formation. Only places where I actually find fluid air exchange useful is when, especially in diabetic vitrectomies, where I would not like to have any kind of a post-op hypotony leading to a recurrent bleed after the surgery. Sometimes also when you are wanting that the sclerotomy, you are doing a resurgery and the sclerotomy closures may not be very good, or you are reusing the instruments again when the sclerotomies may not be very fine, and you want to have a better closure of the sclerotomies, you might land up doing a partial FGE. But I probably would avoid doing a complete fluid air exchange in every case.
Yeah, it's an individual perception, madam. I prefer doing it from past 9 years. I've been doing it. So touch wood, and things are going well. It's basically the individual choice, individual perspective.
Whatever you find safer.
Whatever you find safer for your own patients, I think would be really useful. So I have with my team Dr. Rajashri. You can show your face in the camera. And Dr. Giriraj is here, who we are, and Dr. Rohan is also there in the auditorium. So we are working on the various color channels in the Ingenuity, and we are working on the gamma, the hue and the saturation to see how different the surgeon's comfortability is there, especially in PDR cases, in ILM peeling, in ERM peeling. In those cases, how we can reduce the dye visualization, the utilization, and with the less dye, how better you can see the edge, so that it will not be that toxic to the retina. So we are doing that investigator-initiated trial very soon, and probably within 3 months we should be ready with our data. And thank you very much. I think it's taken already 25 minutes, so I'll not take much time.
Congratulations, Srinivas. Very elegant surgery.
Thank you.
Great surgery.
We'll see you in the auditorium very soon.
Immaculate surgery, Srinivas. Very nice.
Thank you, sir. Thank you. I have also my sister, Shanta and Vittal. I would like to introduce, because they are our core team. So Guru sir said about the red buckler. So if I win any award, I think I contributed to my whole team, because it's their success, their helping, which helps my temperament to keep down. And I give the award to my mentors, to teachers, and all my staff, my fellows and the residents who have helped me in this. Thank you very much.
Thank you, sir. So now we'll be moving to the other OT to watch Krishna Prasad sir operate a cataract case. It will be femtosecond assisted cataract surgery. So over to you guys.
So the next patient in line.
Check.
So next patient in line is a female, 53 years old, and sir will be operating the left eye with BCVA 612 and IOL power 23.5. He'll be putting Optiflex Trio with flax.
This is Dr. Krishna Prasad once again. So I'll be demonstrating a case of cataract surgery using the femtosecond laser. So we call it as a flax, femtosecond laser assisted cataract surgery. I'll be planning a trifocal from the company Biotech, the Optiflex Trio, my favorite trifocal. So I'll be starting it already. We have not done the corneal incisions. I'll tell you the reason later. And tomorrow probably we are planning a case with corneal incisions as well as orchid incisions for the using the flax. This is just a nucleotomy as well as the capsulotomy that has been done with the femtosecond laser. So I just let the aqueous out, fill it with oculon. So I just use always some amount of intracameral xylocaine. Let the oculon out and fill it with viscoelastic methyl cellulose. You have a carbon dioxide bubble already there. Light nodima, Lata, very good. So this step would have been probably taken care if we had used the corneal incisions. So it's already a free floating capsulotomy. It's a 5.2 millimeters rexis. Very precisely 5.2. Normally when we are operating normally, we say 5 millimeters, but that's again a destiny. But here it is precisely, so you can just see it is cut all over. I just pulled off that 5.2 millimeters. Already the anterior rexis is also cut in the same way. I let the aqueous out, purge the carbon dioxide bubbles. So hydrodissection, already there is some amount of pneumodissection that has happened. So this is basically to purge the carbon dioxide bubbles. I don't hydrodelineate. You can see that disc of anterior. It's already 6 pizza cuts that you can see. This is what we call the chop mode. I just want to kind of show you just all the 6 cuts are already there, precisely cut. So now I enter, it's already a pre-cut nucleus. So job is already done. I just have to go and pick it up. It can be even a single-handed technique. It was an NS2 case. So everything just falls apart, no time. Can you have the OptiFlex trio? So here the cataract becomes a no-brainer. Now back to our lens implantation. Lens please. Okay, I'll do the IA.
KP, the cortical aspiration will do anything different?
Exactly. See, the point is normally when we do cortical aspiration, those cortex which are basically projecting from the rexis margin, they give a cue. Here the anterior rexis is also cut the anterior capsule, anterior cortex a bit. So you don't have those projecting ends. You can see here, I need to go in and try to pick them up. I don't have any leading clues from the cortex which is projecting from the rexis margin. So that can make the little IA slightly challenging, and there is some learning curve for that.
Can you center it please, KP?
Okay. Thanks. Keep commenting about the centering as well as the focus.
Yeah, it's better now.
So,
what I do sometimes I catch the posterior edge. Of course, a little dangerous, but
that is, I think, normally I say it as it's like catching the snake by the head. The tail of the snake is on the PC.
Yeah.
The head is at the rexis. So always you catch the snake. I think only Mohan Rajan can catch the snake by its tail.
No, I can do that as well, but ideally in a flax, I think you should go underneath the rexis and go all the way to the equator and pull it out.
So can I have the lens? So this is the injector. So I'll just fill the viscoelastic. It again goes to 2.2, but my entry has been 2.8. So this is the lens which is, you can make out. I'll just zoom it up for you. You can make out the rings. I'll be describing this later in the conference, this part. This is actually a wonderful lens, marketed by Biotech. It's a
really very good lens. I have used this lens now, and really fantastic. Patients have very good vision for distance, intermediate and near also. It's OptiFlex trio, no?
Yes, OptiFlex trio.
Yeah.
So, back to the eye. You can see it's a perfect rexis silhouette with the flax. So I do hydro implantation. So I go in. It goes very easily, of course. I'm going into the bag. It's the haptic opening to the left. It's a very smooth delivery. You can see the rings, the central 1.2 millimeters clear zone. It has the maximum light transmission. That is the advantage of OptiFlex diode. It is almost 88%, which makes the photic phenomena and the reduced contrast sensitivity not a big problem, which is most of the, compared to the most other trifocals available. So,
And I find this lens similar to the Panoptics.
yeah, almost
same, almost same.
Yeah, the result, especially bilateral implants, patients are very happy, especially for intermediate vision. You can actually see it's a well-centered, there's a perfect, overlap of 0.5 millimeters all over because it's a 5 millimeter femtorexis, and it's probably an ideal case to do a trifocal using a femto platform. So thank you very much, guys, for being with us, and thank you very much for your patient attention and the kind moderation.
Very beautiful surgery, very nice demonstration of the flax. Flax makes the life very, very easy. My contention is that flax, if you have access to flax, you should use it for almost every case. Especially patients who are coming with 6'9", 6'6" vision, you can't afford to make any mistake. And I think flax works wonderfully well as well. Of course, even complex situations like what I showed in my this thing, wherein posterior polar cataracts, brown cataracts and all, the flax situation, the flax system works very well. Yeah.
What was the reason for not making the corneal incision with femto?
No, actually we have a case posted with the orchids. I thought I'll just show that with the orchids.
Yeah.
And this was the left eye. So this was actually earlier planned with the 3D format. So there was little problem operating the left eye. I had to really turn my neck, and the actual position of the incision would be determined only after putting the patient on the table. So considering these facts, I thought I'll just not do the incisions with the femto. Tomorrow we have a case where we have even planned an arcade for an astigmatism less than 1 diopters, where you're not planning a toric. You can as well use the femto platform to move very accurate 90% incisions, a 2 paired arcade incision, which will actually cause a very predictable and an excellent way of taking care of the smaller astigmatisms, and the advantage of femto being there. So that will be showing tomorrow. So that's why we just showed a nucleotomy and a capsulotomy. People can ask that they do perfect rexis without a need for femto, but I think it's the question of the reproducibility. 1 out of 1,000 may go every, and probably for the patient it is 100%. So probably if money is not a concern, and with probably technology moving forward, I think trying to automate certain steps, trying to make certain steps independent of the surgeon would be the way forward. So hope that when things become more easy and affordable, probably we will be requiring less surgical skills and probably less human errors, giving more predictable results to our patients. Thank you very much.
Absolutely. Very nice demonstration. The LensX works very well for the corneal incisions, and I use the catalyst. It's not very good for the corneal incisions. But the AK, I'm doing the astigmatic keratotomy regularly. Now the new version of the catalyst, which is 6.0, you can even have the toric marking, just like the Callisto. So you can have the marking on the cornea, so which is there, which is available. I think the lens AR has also got a marking on the rexis also, which is another important feature. But the LensX works very well for the cornea. Whereas the catalyst is the fastest as far as the rexis is concerned. It takes only 1.2 seconds for the rexis. And invariably it's a free floating. Here also it's free floating, I saw that. In a mature cataracts you need to you have to be a little careful because there can be skip areas. So don't pull out the rexis like the usual immature cataracts in a flax. In the mature cataracts always skip areas will be there, small attachments will be there. So try to put a blue rex and then try to look for areas of attachment and try to use a rexis forceps. Otherwise this can tear the rexis and go behind. It can have a PCR or even a nucleus drop.
So thank you very much.
Wonderful.
Because of the short of time, I think we'll move to the next program. Thank you so much.
Fantastic. Great.
Thank you, sir. Thank you to all the chairpersons and moderators. So we move on to our next segment. I'd like to call upon the following people. This will be a cataract session, different strokes. So Dr. Shivanand Bubnade, Dr. Srinivas Deshpande, Dr. Anand Kanbur, Dr. Sajid Tebla, Dr. Mohan Rajan, and Dr. Sanjay Rasal. If you can please come forward, we'll start with our first talk of the next session, which will be by Dr. Satyajit Sinha. The topic of this talk will be managing posterior polar cataract.
A very good morning to all of you. It's an absolute honor and privilege to be here. I have been visiting Dr. M.M. Joshi Eye Hospital since 1997 when I was a postgraduate, like all our young colleagues sitting at the back. So it's almost like 25 years we have been visiting this center. And my Charan Sparsh to Dr. M.M. Joshi sir, who will be joining us. We have been spellbound by all the surgeries that have been happening since morning, and now I would like to take you to posterior polar cataract. And I especially want my young colleagues to see some of the good things and the not so good things that I'll be doing in surgery and how to really manage posterior polar cataract. Because cataract surgery by itself is becoming so predictable that it's not even called cataract surgery, now it's called refractive surgery. But posterior polar cataract still remains one of the most unpredictable surgeries, no matter how skilled you are. And it's very difficult to ascertain what will happen next. So we start with this surgery, and this is something that you see over here that I'm wriggling and going in. Now for my young colleagues who are sitting at the back, this is not what I want you to take home. It should be a smooth, straight, one-time straight incision, a three-planar incision, which will hurt your corneal edges least and help in healing better and give you lesser astigmatism. Once you have gone in, you fill the viscoelastic, anterior chamber with the viscoelastic. Even making these ports, the side ports and the main incision that you are making, they should not be leaky, they should not be too tight, it should not hurt the posterior capsule, because at the end of the day, we have a doubt in our mind that the posterior capsule may be compromised. A good way of also knowing it is whether it's torn or not is by doing an anterior segment OCT of the posterior capsule. Now you do a good rhexis, you want to make sure that this rhexis has been done properly, because if it runs off, so now if the rhexis runs off, then you are in deep trouble, because then you will have double trouble. You will have a posterior, compromised posterior capsule and a running rhexis, then things will go haywire. So once you have done that, you want to go into the anterior chamber and remove a little viscoelastic before you start the hydrodelineation, and do not do hydrodissection, which we have all learned over the years. You can do multiple hydrodelineations, as you can see here, and you will see the golden ring that comes, which confirms that you have done the hydrodelineation properly. Once you have done that, then you go in, and because these are very soft cataracts, you don't have anything to hold and chop. These are all soft cataracts, so you may want to make the rhexis a little bigger initially, so that it's easier for the nucleus and the cortex to come out. But as Dr. Mohan Rajan was saying, if you make it around 5 millimeter, then it's easy to have to do a IOL capture if in case you have an advertent posterior capsule rupture. Now in this case you will see that the nucleus and the cortex easily, the epinucleus easily comes out, and part of the epinucleus which is still there. Now this is one thing that you have to keep in mind all the time, that when you are coming out of the anterior chamber, especially when you have a posterior capsule, PPC, you should always refill it with viscoelastic before coming out. At no time there should be any decompression which should put stress on the posterior capsule. Once you have put the viscoelastic in the anterior chamber, then you can go ahead and make a side port again if you are doing a bimanual. And then here you will see that when I am slowly removing all the epinucleus, I will not go all the way right till the center to remove the epinucleus. The central part you want to remove right in the end because you don't want to put any stress on that point where the posterior polar cataract is. So slowly you remove all the epinucleus from all the sides, and you have to be as gentle as possible, and in between don't keep coming out and going in, which will hurt the posterior capsule. So once you have removed slowly, then the rest of the epinucleus will come out by itself. It will come into your aspiration port. So you have to be very gentle in these posterior capsule cases. And then once all the epinucleus has come and all the cortex, you have removed all the cortex, even the loading of this lens during the posterior polar cataract, once you have finished the case, once you have finished removing all the nucleus and the epinucleus and the cortex, you have a sigh of relief. But that is not the end of the case. In posterior polar cataract, the posterior capsule can rupture at any time. So even loading the intraocular lens is very important so that the haptic doesn't break or there is no pull and push, so on and so forth, and there's no sudden injection and there's no sudden jerk. So once you have taken care of carefully injecting the, loading the intraocular lens, you will see that some remnant cortical matter is still remaining on the posterior capsule. I have especially not cleaned it because in posterior polar cataract, don't go chasing the little cortical matter which is remaining on the posterior capsule. You can do that later. Once you slowly inject this IOL into the bag, and even when you are rotating the intraocular lens, you have to be very careful that you are not putting any stress on the posterior capsule. So now once you have put this intraocular lens into the bag, then you can go and remove all the viscoelastic which is there at the back, and it is very important, especially in these premium kind of lenses, that you remove the viscoelastic from behind, and that is the time whatever little cortex is remaining on the posterior capsule surface, you can remove that one at that time also while you are removing the remnant viscoelastic which is there. And also at the end of the surgery, when you are hydrating the wounds, don't make it too tight to put so much stress on the posterior capsule. Thank you so much for your patient hearing.
Thank you, sir.
Wonderful, wonderful talk, Satyajit. I think it was beautifully mentioned about all the protocols. With, is there any pre-operative thing you will do these patients, because especially when you have access to IOL Master 700, you can actually find out what exactly is the status of the
Especially like I said in the middle, we would like to do an anterior segment OCT to see any pre-existing, if tear is there in that posterior polar cataract, so that you can be better prepared when you are doing the surgery.
Regular anterior segment OCT may not show you the posterior aspect of the eye, but the IOL Master 700 has got subsose OCT, be able to see the posterior pole of the cataract.
Yes.
How many of you use that regularly, Sanjay?
Actually, OCT in such a cases definitely give you an idea about the status of the posterior capsule, whether there is a pre-existing defect or not, and accordingly you can plan your surgery and anticipate the further complications as well.
Correct, yes.
So nowadays I do 100% femto for all these posterior polar cataracts. For simple reason is that the control is much better. The intraoperative control is much better. And even if you have a PC TAD, I'm able to manage it much better if I do a femto. Because the femto advantage is that it's all, the rexis is there, it's all pre-cut. So you just have to go and pick it up like what KP just showed.
Correct,
Yeah.
yes.
Yeah, anything.
Most of the time we see they are not posterior polar cataract only.
okay, what you had done, it not look like posterior polar. On the examination, it looks like posterior polar cataract, but it is not like that only. And out of 10 cases, we see 9 are remain like that only. What you had shown, it is a real posterior polar. So suppose those who don't have IOL master and anterior OCT and all that, we go like that. We go blindly only and do the surgery in most of the time. 1 minute. Most of the time we don't get it. Even so many times mature cataract, brown cataract, this and that. Last moment we see there is a very thick plaque is there, and that also we are able to manage, and they are really not posterior polar cataract. Whatever we are discussing since long, since so many years, but most of the cases are not posterior.
Exactly. Not every posterior polar cataract is not exactly a posterior polar cataract. It is a posterior subcapsular cataract, and most of the times we get away with that. So that is what he wanted to tell.
Correct.
So one need to be ready for the situation if it really arises. One should be ready with the vitrectomy and the possible complication and extension of the PC tear to the equator.
Yes.
Then it becomes messy.
Yes.
So it is always better to be prepared.
No, absolutely, I agree with you, because even if you have a posterior subcapsular with the posterior polar component, you have to be a little careful. So just follow the protocols, injecting viscoelastic, using low flow parameters, slow motion phaco, whatever Satyajit mentioned just now. All these things we can probably follow. The bullseye posterior, that's like an onion pearl. These are the cataracts which are very dangerous. So these can open up. Even by at the end of the surgery, I have seen 2-3 patients, when you overhydrate, the lens is in the back, it can open up. So you have to be, don't overhydrate it also.
Correct.
So till the surgery is over, it is not over.
It's not
in this
over.
posterior polar cataract, my opinion.
Even the antechamber has to be kept all the time formed.
Absolutely.
It should not become shallow at any point of the surgery.
Right.
The moment it shallows, the PC opens up.
Yes, that is what I was showing you. You have to fill viscoelastic.
Who is the next?
Thank you very much.
Thank you, sir. So it's time for 3D again. Over to Dr. Aniket Shastri, who will be operating IPCL. We will have 3 live surgeries after this.
Yeah, good morning. Am I audible in the auditorium there?
Yes, sir, you are audible.
Yeah.
Yeah, very much audible.
Thank you. So I am Dr. Aniket Shastri here. I am going to operate on. Okay, please share the case history.
Yeah, yes, sir. So, sir will be operating female 21 years old, right eye, with best corrected vision acuity 6/18, subjective acceptance of -18 diopter spherical and -2.50 cylindrical at 60 degree. The anterior chamber depth is 3.21 and wide to wide is 11.75. So, sir will be doing IPCL for this patient.
So, Dr. Aniket, you will be operating toric phakic IOL in this case.
3D session.
Hello? Hello, can you hear me?
No, I can hear you.
Yeah. It means
I'll
you
be
are operating on
operating.
a young patient who has a refractive error and astigmatism component as well, and you will be operating toric phakic IOL.
Yeah, toric phakic IOL. I'll be using toric IPCL from Care Group.
Okay.
So one good thing about toric IPCL is that you need not worry about any other axis. You just have to place the lens at 0-180. And now I'm going to start. Usually when I place my side port entries, when I'm doing phaco, if this is your 12 o'clock and 6 o'clock, so me sitting temporarily, I do my phaco side port slightly toward this half. But when I'm doing a phakic IOL, I just try to go slightly on that side, the other half, because it makes handling and of the lens inside the AC far better. So I'll be using both the side ports, And there are some long side ports, but these short side ports, I like this because the length is very small and I need not bother about anything entering deep into the AC. I will be using I'm just now installing a preservative free lignocaine, basically for my comfort more than patient's comfort. And now, this is HPMC that is going into the AC.
You said you will be aligning the phakic IOL, toric IOL at 180 degree. You need not
That
worry
is the thing about IPCL from Care Group.
So it is a smart toric phakic IOL.
Similar to that.
Okay.
Similar to that. All their phakic IOLs from the beginning have been in such a way that you place it at 0-180. You need not bother about rotating and all those things. It usually goes through a 2.8.
So audience wants to know what type of corneal marking method you have used in this case.
I am very much comfortable with marking on the slit lamp only, sir.
Okay, very nice.
I mark it on the slit lamp.
Can you have a word on the slit lamp marking method here?
Yeah. And some people mark only 2, but from the beginning I am used to marking at all the 4s, 12 o'clock, 9 o'clock, 3 o'clock and 6 o'clock, just that it gives me more comfort there.
What viscoelastic are you using, Aniket?
Sir, it's simple HPMC, sir.
HPMC, okay.
Yeah, it becomes easy to take it out later, and even if it goes behind the lens, it comes off easily to those ports.
Why not Helon?
The Helon can have, but sometimes I have found it difficult to take it out once it is somewhere behind the lens or something. So I find this more easy.
Helon will come in one bolus, no?
Yeah, it will definitely come, but if some kind of it gets behind the lens or something, somewhat I have been using HPMC from beginning, it's been more comfortable. So, I'll have this, just a minute. So this is the butterfly cartridge that comes with IPCL. The focus is fine.
Yeah, very nice.
Yeah. So what I usually do is I use a combination of saline, BSS and visco, not just visco, because I find that the unfolding becomes more easy. So we'll have the IPCL now. So this is a lens. The IPCL from Care Group, and if you see there are a lot of multiple holes here. One thing is the orientation of the lens that is important, and because we are operating on the right eye, if these 2 holes are clear, if it's clearly visible, these are the ones that should be at the forehead. And then once one end of the lens is in the cartridge, you can just have to tuck the other end so that you maintain the convexity upwards. It's not like our IOL where we just try to tap it with concavity upwards. So here it's the convexity upwards, and I keep tapping this as I keep closing the cartridge. So then what happens is it starts rolling inside, maintaining the convexity upwards. So just keep doing it slowly.
I think the most important aspect of the phakic IOL is the loading.
So once that is done,
Yeah.
I have locked it, and always check for free movement.
Very nice.
Okay.
So this is a hydrophilic lens, no?
Acrylic, sir, yeah. Try to look straight, straight ನೋಡ್ತಾರಮ್ಮ, straight ನೋಡ್ತಾರೋ. So always check this, whether it's moving freely before entering the anterior chamber. Sometimes entering the anterior chamber becomes tough because the main port may not be that wide. So I tell the patient to look towards me because most of these are under topical. So they are looking towards me and I push the cartridge and it becomes easier. And always the insertion of phakic IOL is when your cartridge is in the anterior chamber, never wound assisted. So this is what I told, that I find that once you use a combination of HPMC and BSS when we are loading the lens, it opens up quite easily. Can we go to retro, please? It becomes more evident there. Who is here? Yeah.
Yeah, very nice.
Yeah, this becomes very nice now.
Yes.
Yeah. So then you slowly tuck in the sulcus. This tucking becomes easier if your side ports are away from the center here, from this midline, because for these side you always have the main port to adjust. And these small 2 dots here and 2 dots here are the toric alignment for the lens. Now the lens is in the AC properly in the sulcus. Aye.
The center hole is there, no?
Yes, this is the version 2 of the IPCL that has a central hole. I'll just show that now. I'll just show the central hole now.
Yeah.
You're able to see now? I think there is
Yes.
the central hole can be seen. There is an air bubble behind that. Even if it doesn't come out, don't worry. Eventually, it will come out by tomorrow. So never go. I mean, it's quite obvious. It makes sense, common sense, but still, it has to be told that never go behind the phakic oil to clean any amount of visco there. There are so many holes here. You can always place your aspiration port close to any of these holes and press your pedal, and whatever visco little bit is there behind, it easily comes out. Yeah. You can see the central hole now.
Yes.
Clearly visible.
Yeah.
I mean.
So we use the sodium hyaluronate, which is made by many companies now, Indian companies, Coivisc, the bio.
So if you see, I have aligned the lens in 0-180. So and after this,
very nice.
I'll just close the case now.
This is a very nice tip. You're hydrating the port before you come out.
Straight ನೋಡಮ್ಮ ಮುಗಿತು. I will put some Vigamox, moxifloxacin, and case is done.
Very nice. Aniket, very nice.
Thank
What
you.
are the other phakic IOLs you're using?
Sir, here we use the IPCL from Care Group and also the ICL from the Star.
What about the biotech iCryl?
Sir, no personal experience. I have not used it.
What about RIL? I think somebody is demonstrating.
These are the two things which we use frequently here. I mean, the only two things which we use.
Any of you using other
Anyone who has used can definitely add.
Dr. Aniket, Dr. Sajid Tebla here.
Hello, sir.
Hello. I want to ask only two basic questions.
Sir.
First things, during phaco and cataract surgery, we require CCC to stabilize the IOL and prevent the PCO. Here there is no CCC, so we are putting directly over the capsule.
Yes.
So there is a stability, is there proper?
Sir, the one thing is the sizing of, one is there, it is not on the crystalline lens, it's not sitting on any of the crystalline lens. There is a vault there by which there is at least around 300 to 350 micron gap between the crystalline lens and the posterior part of the IPCL. That is why that fear is not there, that it is touching the lens, it causes any trouble there. Second point is the sizing of the lens by which the pre-op measurements which we do, and the lens is sized and it is customized and then being sent to us. So with that, it properly sits in the AC without much, and we have had experience now for more than 10 years now with both the sets of lenses, and the both are working very well.
Suppose any patient develop cataract in future, so are you going to use same incisions?
I think by the time he develops, I mean, his old age cataract, I think we can always put new incision. This would have been completely healed and scarred.
The temporal and nasal and everything has used that, na? That's why I'm telling you.
We can always go 1 or 2 clock hours on either
Here
side.
and there, okay.
Not an issue.
Very nice surgeries, thank you.
Thank you, thank you.
So I want to ask you one question. What are the chances of cataract formation in this patient, since the patient is very young, 21 years?
Sorry, can you please repeat?
What are the chances of cataract formation?
Sir, with the present setup, sorry? Yeah, I think, okay, right.
What are the chances of cataract formation in this patient?
Sir, with the present set of lenses and the design which we have not seen cataract formation in our setup, being using any kind of lenses. With this central flow, with the central hole which Mohan Rajan sir was asking me, that is the one that has actually created, what you call a revolution in phakic IOLs, where the aqueous that was being trapped behind and that toxic aqueous was causing the subcapsular cataract, that gets that gets completely drained out, and that central hole there prevents the formation of cataract.
But sir, there are 3 entries inside the eye, so much manipulation. I think there is a chance of patient getting cataract. And have you counseled the patient for this?
Yeah, all the patients are told regarding that.
They are told.
Yeah, there will always be a told, but till now we have not faced any issue like that.
Thank you.
The cataract formation is almost minimal, especially with the newer versions, especially the volting is very, very important. That is why the sizing of the lens is very important. So if you do the sizing, very important, that is what do you measure? How do you measure the white to white? What is the method you use?
Sir, I personally use the value from the topography, and also the main thing which is the manual. I use the
caliper?
Yeah, caliper.
Digital caliper.
Yeah. That gives excellent results.
Yeah, absolutely.
Whatever high-end machines you have, the digital calipers work excellent actually.
Yeah. Well, nowadays we are using the digital caliper. We are also using the IOL Master 700. So which gives that white to white. That sizing is very important, and cataract is absolutely nil. We have not seen any cataract in the past 10 years. Since Star ICL, we are using plenty of them. We have the V4 version, and now we have the central hole also. So everything is there. The volting is very, very important. If the volting is not there, everything depends on the sizing. I think sizing is very, very important. So wondering why the companies are not coming with the preloaded phakic IOLs. They should come out with the preloaded. It is a good option, because loading is one of the major problems in all these phakic IOLs. Very good surgery, Aniket.
Thank you.
Fantastic.
Thank you for your attention. Thank you. I think Madam is ready.
Thank you, Dr. Aniket. Next surgery will be a squint surgery by Dr. Deepti Joshi.
Good morning, Deepti. Where is she? You have to shift to the next theta.
Can we have the details of patient?
Dr. Sushma.
Hello.
Hello.
Deepti, good morning.
Good morning, sir. How are you?
Fine, Deepti. Always nice to see you again.
Oh, yes, the Nobel Prize winner.
I like your cap.
Oh, thank you, sir.
Yeah.
The children enter the OT looking at my cap, so...
Absolutely. Very nice.
I request Dr. Sushma to just give a brief introduction about the case.
So I would like to...
Good afternoon, everyone.
Request Dr. Anurag Mishra to join, please. Pediatric ophthalmologist Dr. Anurag Mishra. Please come forward.
Good afternoon, everyone. Welcome to IFS Squint
Welcome,
session.
Anurag.
Good morning, Anurag sir. I think good afternoon, Anurag sir.
Yeah, about details. Patient is 14-year-old and she has exotropia, and the patient has 45 prism diopters of deviation for distance and 40 prism diopters for near. So we have decided to operate for left eye lateral rectus recession and medial rectus plication. So lateral rectus recession will be shown here. Over to Dr. Deepti Joshi.
Hello everyone. So there are basically in squint surgery, we can do the surgery either by giving an incision here, that is the limbal incision, or...
Your screen is not visible. Hello, microscope screen is not visible. Microscope view is
Gilbert, 2D.
Yeah, it's a 2D, but it's not visible. Screen is off.
Just a minute, sir. Just a minute, sir. Gilbert.
Yeah, it's visible now. Yeah, you can go ahead with
It's visible?
Go ahead. Dr. Dipti, you can go ahead.
Yes sir, yes sir. So as I was saying, normally when we do squint surgery, there are two incisions. Either we give incision at the limbus, which is the regular squint surgery which has been shown all these days in the eye fest. There is another type of squint surgery where we give incision at the fornix over here. So today I would be showing you a fornix based incision for performing a lateral rectus recession. What basically is the advantage is, in case of limbal incision, there would be lot of bleed in the interpalpebral area, there would be lot of sutures in the interpalpebral area. So all those things can be avoided when we use the fornix based incision. So more of like a cosmetic. Cataract is going sutureless, so we thought why not we go sutureless too, and that is what we would be showing. So this is my traction suture. I am just taking the traction suture and pulling the eye more towards medially. So for the fornix incision, I take the incision nearly, this is the left eye. So I take the incision infero-temporally, because in case I have to do inferior oblique muscle, through the same incision I can do both the inferior oblique as well as the lateral rectus incision. I mean the muscle surgery, and the suture incision I take is almost of about 3 to 4 millimeter incision. I open up and expose the bare sclera. See, why do I take 8 millimeter behind? Because I know my lateral rectus is attached somewhere here, 7.7 millimeter. So my incision is behind. So when I pass my hook, I am actually directly holding the lateral rectus muscle. So this is the lateral rectus. Now what do I do? With the help of Stevens hook, I just release, with the help of Stevens hook, I release the conjunctiva, all the adhesions above the lateral rectus muscle, and I pull out my hook outside. So now I have, is it in the center? Yes. So now what do? I open up the conjunctiva way superiorly and expose the bare sclera here also. So now I pass my Green's hook below, and this is my lateral rectus muscle. So in case you want to reconfirm, you can just confirm either by doing pole test or by retracting the conjunctiva. So now the next step would be to dissect the whole muscle. You have to take care that you don't pull the conjunctiva too much, because that is what we are aiming here for. So you release all the intermuscular septa, the suspensory ligaments. Take care that your IO comes close by, so not too much of dissection.
Your assistant is doing a fabulous job, Dr.
Yes,
Deepti,
so
is giving you exposure
I have to give an
unparalleled. Absolutely fantastic.
Absolutely.
I love the way she held the hook while you were dissecting the conjunctiva first, because if you apply a little more pressure, then the head of the hook will just split the muscle open and come out.
I think in a squint surgery, more than the surgeon, the assistant is more important. So I would like to thank my fellow here, Dr. Prabha, who has been assisting me.
But Anurag, how did you know that she? Even I could be assisting.
I presumed, sir, looking at the stability of the hands.
And Dipti, one more thing I would like to highlight here is,
Yes, sir.
your dissection is spot on.
Thank you. Thank you.
You are mobilizing the muscle very nicely. The check ligaments and the suspensory ligaments are cut very nicely. Your surgery is literally bloodless, going bloodless. So visibility is excellent.
Thank you, sir. I think I would like to give one point to all the surgeons who want to do squint surgery. In case you are a bit skeptical about the bleeding point of it, so you can use Occurest plus some drop which is nafazoline, xylometazoline drops,
phenylephrine.
or even the
Drosin works very well.
Phenylephrine.
Yes, all those
are-
drops just before the surgery will actually reduce the bleeding on table.
Dr. Dipti, is this the place where you normally take your muscle knots?
No,
Because-
I would be going more closer.
Absolutely,
but
that is what I...
Yes, but then here, so now this is the muzzle, and now we just clear up all the area. This is an 8 millimeter
Strengthen the
incision.
muscle little bit.
So how much of recession are you planning for this?
This is an 7 millimeter incision. I would be doing plication later, which is not a part of this live surgery. There I am doing a 7 millimeter plication. So the thing is, the thing comes here up to 7 millimeter. So I will be retracting it, and retract here also please for me. Take one more.
So you didn't mark the sclera, did you?
She marked it. I can ask her to remark it again. Calipers please. Can you please remark it again?
So you just create a dimple there, you don't need to use any dye?
No, I don't use any dye. She just creates the dimple over there, sir. Perfect. So this...
And just one mark, that's it? You
Yes,
don't
I
mark-
use one mark. Later she marks it for the second mark once again, sir.
Okay.
So this will be my marker. So I take my scleral bite over there, and can you just release that? So
just asking, if you have 2 to 3 marks taken from the muscle insertion
Yes.
at the same time, wouldn't it ensure that you are going absolutely spot parallel to the spiral of Tillox that way?
yes, we can do that also. So that option is also there of taking 2 to 3 marks also. But I think from before I've been used up to this, and I think that option is also available with us.
I think the second bite is very important because that decides that there is no any kind of a slanting of the insertion.
Yes, so
So that's exactly the reason why I was saying that maybe pre-placing the marks would be of great help.
This is more a problem when you take an inferior incision. If you are
Yeah.
spot on the muzzle,
The location of the incision is very important
Can you
because
show me 8 millimeter
already
from
the
here,
conjunctival incision is inferotemporal. That's why placing the marking and doing all this procedure becomes little cumbersome.
So Dr. Dipti, is there any reason why you're planning a plication in this case and not a resection?
Sir, I have actually shifted from resection to plication from past 3 years. So more or less basically there are few advantages. It is in my hand. I finish plication within 3 minutes, but in case of resection I take maybe another 2-3 minutes extra. And there is an advantage that if at all I have to plan a repeat surgery, the chances of anterior segment ischemia is there. People tell about reversal in case of plication, but then no sir, I have noticed that after 3-4 months if I open up, the fibrosis is way too much. Reversal in case of plication is also tough. And the amount of reversal plication which I can do is more than that of what I can do for resection. This is what I have noted in my hands. So that's why...
But what are the chances of the non-absorbable suture slipping and your effect being denounced in the process?
I use absorbable sutures, sir.
For plication?
For plication also, I have shifted to 6-0. We use the modified plication technique which was highlighted in the APOS, American Association of Pediatric Ophthalmology in 2017. So that technique we have been using. I think that is not a part of this thing. I had showed it in the last IFest actually. So in case someone is giving a talk, the plication can run in the background and they can be seeing the plication in the next 5 minutes also. So that can also be done actually. So
Yeah, we can do that. See, we can have the next talk. By the time the talk is over, we can just show the plication end stage so that you get an idea what exactly.
So this is I just take one bite for the conjunctiva. So just one suture. This can actually be closed even with a glue. So, and remember your suture, your incision all goes. Why do I take it more posterior is, it goes inside and the patient doesn't usually appreciate the scar, the knot. Current era when people come to us before the marriageable age that हमें जल्दी से ठीक होना है, scar नहीं दिखना है. So I think at this time fornix suture really works best for them. So this is my post-op of a lateral rectus recession done via the fornix suture. So this would be the head straight if I keep. So this is the thing. I think patient wouldn't be appreciating much of a scar in this area which they consider as an interpalpebral zone. So this is what we would like to highlight, that even the squint can become a bloodless, sutureless surgery if it is done in a proper way. Let us make the cosmetic surgery more and more cosmetic. So any questions from the audience side?
That was a brilliant surgery, Deepthi. It was really fantastic. Yeah.
Thank you, sir.
Because
yes, absolutely, and I completely
I'm looking
agree with
forward to the actually plication, because we still do resection only, but the plication is.
I'll be doing it
We
in
will
the
not
background.
disappoint you. We
Yeah,
will be coming
fantastic.
to
Very nice.
application. Yeah.
Yeah.
I think and for plication I'll open it up in the limbal root and I'll be doing the plication, sir. So you can keep observing. If someone has any doubt, they can ask me as and when I'm doing the plication procedure. Huh?
You can finish one talk, but then we will be operating the plication. We will show the plication.
Background naditirli beda. Alla but
So
idu
we'll move on to the next session. It's a video bouquet of complex phaco cases by Dr. Anurag Mishra.
Go slow.
He will take 12 minutes, 10 minutes, sir. 2 minute discussion. 12 minutes. You show the way you tighten the.
I'll take the knot and I'll keep it ready. Okay.
Righto. Thank you so much,
Neeve kudu.
KP sir, the whole team of
Aina
MM
ಮುಗಿಸ್ಬಿಡ್ತೀನಿ
Joshi
ಸರ್ ಈಗ
for
ಅದಕ್ಕೆ
the
10 ಮಿನಿಟ್ಸ್
honorable
ಅಂದ್ರೆ ಈಗ
invite.
ಕೂಡಬೇಕಿನ್ನ
Good afternoon, ladies and gentlemen. Greetings and regards.
ಅದೇ
Yet
ಅದಕ್ಕೆ
another
ನಾನು
time
ಕೂಡಬೇಕೀಗ
from the land of Lord Jagannath. Now,
ಅಲ್ಲ ಮಸಲ್ ಐಸ
this is obviously a bouquet, a collection, a plethora of 3 or 4 surgeries, which I would be showcasing in due course of time. All of them had some of the things in common. All these 3 patients that I would be showing in a while from now were one-eyed. All of them needed a high toric implant, T7 and thereafter, T7, 8 or 9. And of course, along with both these factors being common, they had posed a few different challenges as well. The first case, which is case number 1, was one-eyed because the other eye had gone in for a corneal decompensation. And the reason why there was a corneal decompensation is, as you can see here, the hexagonal cell on specular is not available, it's not showing at all. So this was a case of Fuchs, and if you see the endothelial picture caught on slit lamp, you cannot see the hexagonal architecture at all. So it was that flat. So this eye also had a very low endothelial cell count, and on top of that, the cataract was hard, very leathery, and the patient had chosen flax. Now, when you are registering the patient under the flax machine, if the color of the iris and the color of the nucleus closely matches each other, the machine does not register the eye. I use the flax machine with Varion, and it does not register the eye. So that's the first difficulty. So that's what's the message popping up. The registration is not valid. So you have to do everything manually. So we start off the case. This is the capsule. We have to fix the 2 cursors on the highest and the lowest point so that the machine decides its offset of 500 microns on either side. Now, when we decide the nucleus management, I do not go the full length of the nucleus because I want to cut down on the energy used, since this is a case of Fuchs. So I just use a small depth of the nucleus to give me a template so that the chopping would be easier later on. but at the same time it will also save me on the laser energy. So that's what I do. So now we go to the rhexis, it does the rhexis, it does the nucleotomy just in the superficial plane so that I know where are the cleavage planes, and it helps me in chopping later on. A one-eyed patient, a hard cataract, and finally we do the corneal applications, and the corneal incisions are also made, the main and the side incisions. The reason why Lensex produces more effective corneal applications is because it has a variable numerical aperture. It changes its focus. It comes back from the nucleus and focuses on the cornea while it fires laser beam. Now inside the OT, when you see this incision opens up very nicely. You don't have to do anything. Just put in the spatula and it opens up. There's a lot of air bubbles inside. As expected, pneumatic dissection has already happened. So you do a soft shell technique of visco insertion, chondroitin and HPMC combined, both of them being dispersive, coat the endothelium well, and then the rhexis can be lifted off. Just shake it a little bit to ensure that it's free from all its attachments. All the while, I did have my own share of trepidations because this was a one-eyed patient and the other eye was lost. So look at the way the templates are helping me. The chop is clean. You don't have a shelved or a multi-level chop here. The chops are clean, the side walls are clearly defined, and we are doing pretty well on the CD count. The chopping is over under a CD of 2. The IOP is set at 30. As I showed you in the morning, I always keep low IOP very, very low indeed, so that the structures are not stretched at all. And then the pieces are consumed one by one. The CD count in such a cataract, had we not used flax to create that template, would have been somewhere in the range of 20s or 25s. But since we have done this, we would be probably managed to finish off the nucleus management at least within a span of 15 or 16, which is pretty good. Not to mention, time and again, I did remove my phaco needle and refilled the anterior chamber with viscoelastic just to provide a mechanical coat. So this is 19.26 CDE, which is pretty good. But these patients need to be followed up very frequently in the post-operative period just to ensure that the cornea is clear and there's no edema and the endothelial function is right. So this is case number 1. Case number 2 was aphakic because the other eye had a scarred CNVM, and obviously this patient had delayed his surgery way too much and finally presented with a hypermature cataract. We did an anterior segment OCT, and as you can see, there are a lot of fluid-filled pockets in the mid-periphery. These are not patients wherein a milky cortex will come out the moment you puncture the anterior capsule. No. But these patients have the maximum chance of producing an Argentinian flag sign because of the mid-periphery, these fluid-filled pockets really, really rip them apart. So what I do is when I enter the capsule, such cases you should aim for a small rhexis to start with. So that's the rule. And the moment you start doing the rhexis, you can already see a bulge of the cortex. It's trying to project out. These are areas wherein it's very likely to run to the periphery. You might lose the rhexis. So keep it right at the center and do a small rhexis. After the rhexis is complete, many people spiral it out and enlarge the rhexis at the same time. Not something that I very commonly do. I do what I call an SRCS, or a small rhexis cataract surgery. I don't extend the rhexis to start with unless it's a very hard cataract. But there are a few principles that you have to keep remembering. Once you're through with rhexis and you begin chopping, since you have a smaller gateway, a smaller doorway through which the nuclear fragments have to come out, you have to remember to chop this nucleus into really, really small fragments. Otherwise, it will create a disproportion while being dislodged, and it might just, that the mechanical stretch might just tear it apart. So when you start chopping, the IOP again is 30 in this case. So the chopping, the pies have to be small in dimension so that while dislodging, you don't have an issue. The cataract's not very hard. They're usually not hard in such cases. If you manage the rhexis and the cortex well, then usually your job is done. So one by one, the pies are just dislodged. This is an unedited video, and quickly they get consumed, all thanks to the supreme fluidics and mechanics and dynamics of the hair and phaco machines that you receive these days in the package. Now, after you implant and I'm a very avid visco hater when it comes to IOL implants. So I always implant my torics under BSS. But after the IOL goes in, I realize that the rhexis opening is too small and it might just cause a phimosis. So under the cover of the same BSS and aligning it, I try to extend the rhexis now. So this is the cover of no viscoelastics used. The microrhexis forceps introduced through the other side port. So this is how the other side port is used in my surgeries, apart from dialing them in. You need to have a good dexterity to be able to do this. You need to have an orientation because the capsule starts fluttering under the flow of BSS. So you need to change hands, go back to your left hand, and just hold the capsule, move it around, all the while imagining that the circumferential margin is somewhere and you need a good coverage of the anterior capsular margin as well. So the size has to be good, the centration has to be good, but yet the job needs to be completed. So this was another one-eyed patient in whom we did this and later on extended the rhexis and aligned finally. Case number 3 was another patient who was one-eyed and the other eye was lost because of pre-thesical stage, and this patient had a long-standing history of rheumatoid arthritis and repeated attacks of iridocyclitis, because of which the pupil was looking like this when we opened. So this is what we did. The pupil was very small and it was loaded with pigments all around. So after entering and creating the 3 ports on the 3 sides of the cornea, the first job, of course, this was a T9 implant. So you punch a hole through the cyclitic membrane. That's what I did. And then just move in and manage the pupil mechanically with some more visco, and now do what I call a pigmentorhexis. So the iris pigments attached to the pupillary margin are all removed. Now the pupil behaves and looks much more circular. Now goes in the Malugan ring. So you have to use the ring in this case. And this is the way to implant it actually. The distal scroll goes in, the side scrolls go in and engage the pupillary margin right away. The proximal scroll is dislodged and engaged in the same move. So this is the best way to handle this bulky device. You don't leave it floating in the anterior chamber much because it might touch the endothelium. There's nothing much in the nucleus to show. However, after the IOL is implanted, as I said at the beginning, I'm a visco hater when it comes to toric implants. So again, I would try to do the subsequent maneuvers under the cover of BSS only, while the IOP is being maintained at 55 for this particular step. So I dislodge the proximal scroll while BSS is flowing, no viscoelastic used. So this is a little tricky because it's a bulky device. So I'm just trying to nudge the proximal scroll up by supporting the rest of the ring with the BSS cannula. So that's what I'm trying to do. It's getting slipped time and again. Have to be careful here because you might just drag the iris along as well and cause a ciliary body bleed. So the head is popping now for the hook of the plunger to go in, all done under BSS, and eventually engage the scroll. So the hook is also designed in such a manner that once it comes out, the vertical dimension of the hook does have a danger of touching the catchment membrane at the wound. So you just have to be careful. Now it's ready to get pulled in, but midway through it's getting pulled in, you have to support when the side scrolls are dislodged from the pupillary margin. That's where you have to support because the horizontal dimension increases. So the BSS cannula does it. Just give it a little support so that they are sucked in. But for the distal scroll, you have to give a counter support with the second instrument because that just bites into the iris a little more. So therein you have to give a counter traction and then subsequently it finally releases it. Have to be soft and very calculative. And that's when you finally cross-check for the alignment again. And then, so this was case 4, but in the interest of time, I'll just skip it. Thank you so much for the attention.
Very nicely done. Anurag does really wonderful videos. I think all the 3 cases were really challenging. And I will also do a femto when you have a compromised cornea. But if you don't have femto, what are the parameters you will follow? I'm asking whether you'll use BSS plus, whether you use a soft shell technique.
Soft shell is something I would obviously use for any hard cataract with or without
BSS plus for these
compromise. BSS plus are honestly, I have never found any advantage over the BSS, normal BSS that we use. in endothelial compromises at least. But yes, the only thing that I would ensure is I stay as far from the endothelium as possible while chopping and the subsequent maneuvers, so that the energy does not hit it directly.
What is your experience with the BSS Plus?
For these patients, I think BSS Plus I use, definitely it's got an because it's got the glutathione in that, which is really cornea friendly. And Femto will be my choice. Only thing is, when I notice there's a very hard cataract and you try to bring the nucleus into the anterior chamber, I would do entirely completely in the back, and I will make it into smaller pieces. Sometimes I do octants. Whether it's possible in insects, I'm not sure, but octants it's possible in catalysts. So I make
it is possible on lenses as well.
Yeah.
It is also possible to honeycomb it and grade
Honeycomb, yes.
But the only concern I have is I don't want to use more of laser energy as well, since it's an endothelium compromise. And while you're doing a femto, you don't have an endothelial protection. You can't put in visco and then do femto. So the endothelium is exposed to the energy directly. So
yeah, that's right.
As less as possible.
Yeah, we have as I told you, we have the center sparing software which is there in the catalyst, which uses less energy and very less, 1/3 of the usual amount of energy. So that's a huge advantage. And I'll make it into smaller pieces and make sure that inject visco now and then you're doing that as well.
True.
In hypermature cataract, while putting an initial cut, are you preferring to wash out some lens matter or whatever the leaking fluid is there?
Normally, if it's a proper intermittent cataract and the milky cortex comes out, I do what I call an aqua sweep technique. The aqua sweep technique is nothing but go in with the hydrocannula, inject some amount of fluid away from the cut, and then sweep the capsule across so that all the milky fluid comes out through that opening. Now, the initial cut is very important. The initial cut should not be a radial cut alone. You cut it and then you lift it so that there is no radial direction of force. Once you have a triangular flap, it's very difficult for the rexus to open up into an Argentinian flag. But for this sort of a cataract, I would not use the aqua sweep because it doesn't help. Because there is no intumescence, there is no milky cortex, they're just fluid-filled cavities. So you have to do a small rexus, and then it's your choice. You can immediately expand it. After rotating the nucleus, which liberates all those fluid pockets, you can immediately expand it and spiral it out into a bigger axis. Or like I showed, you can do it after the IOL implant also. It's up to you.
After small cis.
I think Dr. Dipti is ready with the muscle. Muscle is very nicely exposed, and the surgical field is very much bloodless field. I am expecting her to plicate the muscle.
Is it clear now? Yes,
Yeah,
so
very much clear.
this is the medial rectus muscle, 7 millimeter plication. I have taken the suture already, suture bite 7 millimeter from the insertion. So what do? Now I go just exactly at the point of the insertion. Be very careful, sclera is very thin here. I just take a bite here. So this I come out here. Same thing I do on the other side also. I take a bite there. Okay, and same thing, just at the insertion, I come out here. Sorry.
Hello.
Hello.
Yeah, Anurag, you can come here.
Dr. Dipti,
Please come here.
Dr. Dipti, I think you said that the plication technique gives you a safeguard against anterior segment ischemia.
Yes, sir.
But I can see that the bites have involved the major ciliary arteries.
No, here it has involved, sir. But if I am planning to do a multiple muscles, then in those cases I spare all the vessels. I go ahead here. It would have taken this part. If I had to spare each of the muscle and then take, it would have taken time in my hand, sir. So this is just I'm showing the plication procedure. So this is exactly not the vessel sparing one which I would do normally. Time constraints, I'm just showing the plication here. So this, once I come out, now see the sides of the muscles are attached to the insertion, but the center is still not attached. If I don't take the center bite, then there will be 1 to 2 PD lag, 1 to 2 millimeter lag will happen. So I go back and I take a center bite exactly at the point where we have taken the suture. So So I go here also and I'm taking a reverse suture. So now is the point when I would actually be doing application. So I remove that Prabha, and I remove this also slowly. Remove, Prabha, leave. Yes, so now put the retractor please. Retractor, yes. So now I just pull and see the muzzle has plicated itself. So the muzzle, wherever I have taken the knot, has come. Just hold this, Prabha.
Wonderful.
So now what I do, I attach the center one also to the sclera in the centrally, so that people have a problem thinking when we plicate, it can result in a small bump. No, that is a wrong notion. So when I hold it like this, it basically takes care that the bump doesn't happen. The center is also tightly attached. So this center one, so now I tie this off. See, the muzzle is thoroughly plicated now. No bump, nothing. It gives as much result as the normal resection. Previously people used to just plicate the peripheries and the center one was not taken care of. So now with this procedure we are taking care that the whole of the muzzle width in the periphery as well as in the center comes and attaches. So this is now, if I can remove this suture, I'll just hold this. So it's a good retraction. Yes, now see the whole of that 7 millimeter has been plicated. So this is the plication. But when I have to, normally when I do in the OPD, in case vessel sparing, I isolate each of the muzzle and see, do the vessel sparing procedure. So now this conjunctiva just closes off like this. There is no cosmetic bump, if you can notice. So this is the modified plication which has been now used by majority of the people after the American Association of Pediatric Ophthalmology in 2017. So I think with this I wrap up my plication procedure also.
I think apart from the bump issue, which you showcased very nicely, I think the central suture also ensures that the muscle is flat against its point of insertion.
Yes, yes.
Because the middle part otherwise would sag.
Correct.
And might just add an effect of recession to it.
Yes, that was the reason people used to think that for plication you need to do 1 to 2 millimeter extra as compared to resection. That was the previous thought process. Now the same Parkes chart you can apply for the plication. Resection, same amount of resection if done for the plication works wonderfully also. Gives the same amount of the result actually.
Dr. Dippy, wonderful surgery, wonderful plication
Thank
of
you,
the medial rectus. As you said, this is a modified plication of the medial rectus.
Yes, sir.
Can you mention a few words about the modified hangback technique for the recession of the lateral rectus?
Hangback techniques, I do
Which
only.
will definitely give a titration of the recession effect of the lateral rectus.
Yes, yes. In hangback, I do only hangbacks, and normally I don't use for modified hangback. But hangback technique I usually do when it is, especially in those cases where like when I'm doing a loop myopexy, or in those cases where basically high myopes, sclera is very thin. So in those cases I just go and do the hangback. Very rarely I use the hangbacks actually, maybe few, till date I've done maybe 7 to 8 hangbacks. So that is same, we take the bite at the level of the insertion, as much amount of the muzzle where we need to actually take the bite on the sclera, we put the muzzle over there and attach it same at the point of the insertion. So basically the muzzle hangs back, you are not taking the bite on the sclera. So even if the sclera is thin, you are actually avoiding, and you can do lot of recession by hangback. If LR I can do only 8 millimeter in some cases, then I can go up to 13, 14, but I usually avoid that much of recession in any of the cases. So that is the thing, that's one of the advantages. So majorly I've done, whenever I've done for loop myopexy cases, as well as in cases where I've been doing high myop. So these two cases, but rarely, sir. In my hand.
For horizontal muscles, the hangback recession technique is mostly used wherein the patient has a variable angle, and you need to use adjustable sutures along with it, so that you titrate from the first course.
So large angles can be adjusted.
Very true. But
hangback, in its purest sense, actually helps the most when it comes to superior rectus in large cases of
very
DVD,
true, very true.
where you
100%. So I don't follow adjustable, sir. Somehow I feel when I'm adjusting in the OPD, my patient feels more pain and more, they are more, so I don't use adjustable much. I tell them if at all the need be, a second step will be done for them. So initial 1 or 2 years I've done adjustable, but somehow I am off adjustable nowadays, sir.
No, but the issue here is if the patient has a paradoxical diplopia on the first day, you have to do it. I mean, you have to take up early.
No, we can do, I can
No. I think, Anurag, taking that call so early on the first post-op day will be too early. Yeah,
No, it's
better to wait for, say, couple of
talking about the
weeks.
adjustment. If the adjustment needs to be done, it has to be done early. You cannot leave the large stumps of the suture for too long.
Yes, that's what. So if adjustment has to be done, it has to be done on the day one itself.
Exactly.
And that is the point. But then somehow with those day one adjustments and all, I was not really, my patients used to have a lot of pain. No, this is my personal experience. They used to feel that the anesthesia would be wearing off. They were having a lot of pain. They were not comfortable. They said the surgical pain was high. So they did not think that I am doing something out of the box for them to prevent their second step of surgery, their paradoxical diplopia. It was the patient comfort factor. So that was one thing which I noted. So now in case I have too much of recessions or adjustments and all, now I have got Botox in my hand. I use those as temporary procedures now. So, but adjustable sutures, I am off from it for past 4-5 years.
Inject 0.5 milliliter of xylocaine in the posterior
yes,
capsule,
done.
And then the patient will not have any pain at all.
Sure.
Yeah.
Thank you very much.
Thank you.
Very nice, Deepti.
Very nice surgery.
Wonderful.
Thank you, sir. Thank you.
A big round of applause to Deepti.
Thank you,
Thank
Deepti
you,
ma'am.
sir.
Very
Thank
nice.
you.
Also the Anurag Mishra, sir.
Something new.
Here I want to thank my mentor, Krishna Prasad, sir. So, no, I have to thank.
Actually, I was trying to thank Dr. Prabha, who assisted so well, and Dr. Govind Hegde, the anesthesiologist here, who are
And
part of the team.
assistants, my OT sisters, Ganga and Manjula, and my OT brothers, I think Suresh, he's been roaming from them. So I mean, without all these people, live surgery wouldn't have been possible. So a real big applause to them.
Deepti,
Yes, sir.
I'm offering Dr. Prabha a job and Rajan Aikar Chennai.
सर वो साउथ में नहीं आ रही है सर, वो नॉर्थ में जा रही है वो.
She's going to America, don't worry.
Rasar will be coming in now for the chopping techniques for beginners.
Thank you, sir.
Dr. Anurag Mishra, I wanted to ask you, in your first case, it was a grade 5 cataract. You could hardly make out the difference between the iris and the color of the lens. And one-eyed, so you opted for femto and phaco. So, wouldn't a simple SICS be much safer for this one-eyed person? I know you are a very highly skilled phaco surgeon, I know, but
But
for the take-home message.
I'm an underskilled SICS.
Now the lights on, please. Lights.
Yeah, that's basically the reason, to be perfectly honest with you. I'm really underskilled when it comes to SICS.
No, it's very safe, because provided you have the technology with you.
Just to add to that, I'm so sorry, sir, for interrupting you. This patient needed a T9, and I wanted him to have uncorrected 6x6 post-operatively. That probably prompted me.
But doing good SICS is a must to learn the phaco and to tackle any complications of the phacoemulsification.
Don't disagree, sir. Hands up in the air.
Yes, sir.
So with that
Thank you. I now request our next speaker, Dr. Sanjay Rasal from Kolhapur. He is director of the Sanjot Netralaya, a very dynamic person, ever smiling, very modest. I request you to please carry on with your talk, sir.
Thank you, Sri, for the kind words. And good afternoon, friends. First, I would like to thank Dr. KP, Dr. Srinivas, Dr. Satyamurthy, Guru Prasad sir, for inviting me and having me here. And it's always great pleasure to meet people, friends, after a long gap of COVID pandemic. So the topic given to me is chopping techniques for the beginners, but I don't see any beginner here. Everyone is an excellent phaco surgeon here, but going to the basics is always good, and would love to highlight on the different chopping techniques. Those are evolved over a period of time since the inception of the phacoemulsification way back. The first being the four quadrant or divide and conquer, the second stop and chop, And third is a quick chop. It's also called as a direct chop, a hold and chop, bury and chop. Various names are given by various surgeons. We will discuss all these three techniques on the parameters used in the phaco machines, techniques, basic technique you want, the phaco tip and foot switch positions at a various point of time, and precautions to be taken during surgery to avoid any intraoperative complications. So when you talk about the different chopping techniques, we essentially talk about the nucleus management in the cataract surgery. And I am thankful to the KP sir and team MM Joshi for giving me such an important topic, which is very basic and helpful to everyone. So before going to any technique, what is important to enter the anterior chamber with the bevel down. That is the most important step. In the formed anterior chamber with the visco, enter the anterior chamber and aspirate the surface cortex for the better visibility and estimation of the size of the nucleus and hardness of the nucleus to set a proper parameters on the phaco machine. That is the amount of energy that you need to emulsify a particular type of cataract. Once you aspirate the nucleus, rotate the phaco tip 180 degree, bring the bevel down and start trenching, because first two techniques, that is 4-quadrant technique and stop and chop, involve the fashioning or creation of the trench. So creation of the trench is very important step in first two techniques. One should start trenching from the proximal margin of the CCC. Do not injure the CCC. The motion or the direction of the movement should be forward, downward and again upward. One should not go directly into the substance. Your parameters should be sufficient enough to cut the nucleus and not push the nucleus, because undue strain will be there on sub-incisional zonules, and your depth of the trench should be 70 to 80% of the total thickness of the lens, and width should be around 1 to 125 times the width of the phaco tip. Once we have that longitudinal trench in 4-quadrant, then we rotate the nucleus 90 degree and try fashioning the another perpendicular trench. Here we need some instrument inside the anterior chamber to stabilize the nucleus, and the parameters should be sufficient enough to emulsify the nucleus or cut the nucleus hardness through and through. We should not get a lens clatter or a milking sign in the anterior chamber. That means our vacuum and flow rate are not sufficiently set on the machine, and our phaco power should be sufficient enough to cut the nucleus through and through. And once our trenches are there, they are sufficient depth, the end point is we can visualize the glow from the trench, bottom of the trench. And once we have that trench, perpendicular trenches, divide the nucleus in 4 pieces. Either we then emulsify these pieces one by one, or divide them in a small fragment, just like Dr. Mohan Rajan said, in hard cataracts, you divide them in a small pieces and emulsify with the mere say 20 power on the panel or say 30 power on the panel to save phaco energy. So this procedure is repeated sequentially to emulsify all the fragments in the 4-quadrant technique, and we can do complete phaco emulsification in a 4-quadrant technique. Now in a stop and chop, Cords and coach has modified this 4-quadrant technique to save the amount of energy that is being used during the emulsification and trenching. So they restricted their trench to a single trench, longitudinal trench, and this trench is formed. You see the glow shining at the bottom. Go at the bottom of the trench, and with the help of chopper or Sinskey hook and the phaco tip or any 2 instruments at the bottom of the trench, and apply lateral forces to divide the nucleus in 2 pieces. So this is how we divide the nucleus in 2 pieces to get a successful crack across the entire diameter of the nucleus. And once we have that 2 pieces, then we can emulsify these pieces one by one in a phaco chop mode.
Here the parameters will be little vacuum will be sufficient to hold the nucleus and chop it effectively. Your flow rate has to be sufficient to have a easy fallibility and eat up the fragments, and you chopped either with the vertical chop or horizontal chop. So this is about the stop and chop. Now coming to the quick chop or a direct chop, hold and chop and bury and chop, the idea is very simple. Enter the mid nucleus with the optimum phaco power, hold it with the high vacuum and crack directly with the chopper. Here we exploit the natural orientation of the lens fibers and use mechanical energy or say manual energy to crack the nucleus in two pieces rather than creating a trench. There are two types of quick chops. One is classical horizontal chop invented by the Nagara, and another is vertical chop. So before going to actual chopping, direct chopping or quick chopping, we should set our parameters on the panel. The vacuum should be kept on a fast, medium, slow rise depending on the personal preference and the machine you use, and you must be ready to handle that fast rise vacuum, and it should be sufficient to hold the nucleus properly while we divide it with the instrument. The bottle head should be kept depending on the surge control of the machine, and the flow rate should be, as I said, it should be for better fallibility and easy fragment removal. The ultrasonic power should be kept as per the hardness of the nucleus. Now we see the vertical chop being done here. The surface cortex is aspirated, the phaco tip is buried with the burst mode or panel mode or hyper burst mode. Hold the nucleus with the phaco tip, just withdraw a little, and with the sharp chopper you divide the nucleus in two pieces. You vertically go downwards, the forces act against the vacuum hold here, but you should have that proper hold with the vacuum and you should not release the vacuum. Crack the nucleus vertically and then make it a lateral movement so that you get a crack through and through. Once you have a crack, then you divide the remaining halves in the small pieces, sub-chop them, and then emulsify one by one sequentially. So here, the care should be taken not to injure the surrounding daily structures with the sharp chopper, which is more likely the CCC margin or iris may be injured. Even with the posterior capsule may touch the sharp chopper. Every time when you emulsify the nucleus, you just withdraw the chopper a bit and then emulsify the fragment. One can divide these nuclei in a multiple pieces, means you chop, leave it, and at the end of fragmentation, you eat each and every fragment separately. But personally, I emulsify immediately because already the fragment is engaged into the phaco tip and the energy is utilized to hold the fragment, and little energy is required to just emulsify that fragments. And added extra space is there to manage the remaining nuclear half of the cataract. Then comes the horizontal chop. Here, once we have buried the phaco tip into the central hardcore nucleus, here the chopper is blunt, tip elongated or ballpoint chopper. It is glided along the anterior surface of the nucleus and engaged along the equator of the nucleus. Once you engage the chopper and phaco tip, you encompass the nucleus. It is sandwiched between two instruments and you have firm control over the crack of the nucleus. You can crack any hard cataract with the horizontal nucleus with the minimum power on the panel. So these are some of the cases where you can chop the nucleus in two pieces with the horizontal technique. Definitely you feel like it is a blind technique, but once you master this technique, this is a really wonderful technique.
Excuse me, sir.
Can be used in any type of cataract.
The talk, sir.
Pardon me?
So in the interest of time, sorry to interrupt you, if you can conclude the talk.
I will skip this. Once we have two pieces, then the remaining half of the nuclei can be removed with the cross chop or X chop. The cross chop where we
cross the chopper and make an X along the phaco tip. Just hold the nucleus and cross it and chop the fragments and eat it up. This blunt chopper helps to protect the posterior capsule. Also, it doesn't injure the CCC margin. So that is the difference between the horizontal and vertical chop.
Yeah.
Last slide. Once we master the horizontal chop, just everyone has seen the case of flax wonderfully done by KP, and you see multiple 6 pieces were done by the femto. Similarly, you can divide right half of the nucleus with the mere single hold of the phaco probe, and you divide the nucleus in multiple pieces without using any phaco energy. So mastering the horizontal chopping technique really works wonders, does wonders and saves lot of phaco energy. So this slide shows the difference between horizontal and vertical chop, and I think hope this helps.
Very good.
Thank you very much.
Very good, Sanjay.
That was very.
I think you have gone through the fantastic basics to the advanced, the stop and chop, the divide and conquer, and the vertical chop, horizontal chop. All the basics is very, very important for all of us. I think we go on to the live surgery now. We have Andaman Kankaria, the superstar from Pune, and he's going to show us star ICL. Andaman, are you able to hear us? Vardhaman, can I connect the theatre, please?
Okay.
Yes.
So this is a 25-year-old female having left eye high myopia with amblyopia with a best corrected vision of 624 and a subjective refraction of -13.5 diopter spherical. The anterior chamber depth is 2.86 millimeters and white to white is 11.50 millimeters. So will be Dr. Vardhaman Kankriya sir would be doing an ICL for this with a power of -13.5 diopter sphere. So over to you, Dr. Kankriya sir.
Thank you so much. Thank you, Dr. Rajan sir. Am I audible?
Yes, very much.
Yes, I go ahead. Okay, thank you so much.
You are visible, audible.
Great, thank you, sir. Thank you. Good afternoon, and first of all, I would like to thank the entire team of Joshi Eye Hospital, Dr. KP sir, Dr. Satyamurthy, and Srinivas, the entire team, and my current assistant is Mr. Basavraj. He will be assisting me for the star ICL. Friends, I am going to
Can
demonstrate.
you show the internal camera?
So I'm going to demonstrate star ICL now. So basically this is the cartridge. As you can see, the most important thing in star ICL is actually the loading part. You have already seen how IPCL was performed in the afternoon by Dr. Aniket. So the implantation is similar, but the loading is the most crucial part, and that is the difference between the two. I have had honor and pleasure of using all the 4 phakic lenses which are there currently, which are the star ICL, IPCL, RIL from APA, and as well as the biotech acryl phakic lenses. Star ICL remains as my most preferred choice. More than 95% of my patients undergo star ICL. Star ICL basically come housed in a BSS. So as against the other lenses, they come housed in normal saline. In the past, star ICL also was coming housed in normal saline. They changed it from the time of V4C. So this is the cartridge. I have put majorly the BSS and some minor amount of HPMC viscoelastic. I prefer to use HPMC viscoelastic because it is very easy to remove it. So this is the ICL, as you can see. This comes housed in the BSS, and I'm using a very delicate sponge tipped applicator. So it is important that you don't hold or manipulate this ICL with a forceps. Okay, so this is what I'm going to do now. I'm loading the lens. As you can see, one part has gone under the lip, and I'm not going to use any forceps. I'm going to just tuck it in by a slow dialing rotatory motion of the sponge tipped applicator. So once that is done, we are going to reverse this cartridge and go from the front end of the nozzle. This is called as a front loading forceps. This is what I'm going to use now. This front loading forceps is going to hold this lens snugly, and then with a bimanual motion I'm going to take the lens ahead. Just short of the tip of the nozzle I'm going to leave it there. You have to make sure that these 3 holes are seen in the front anteriorly. That means that your lens is well aligned. Once that is done, I'm going to put a bit of BSS again into the cartridge. Yeah. And then I'm going to put a tiny bit of HPMC. Sure. And we are going to now assemble it with the injector system. So this is what is the loading of the star ICL looks like. This is how it is locked now. I'm just going to make sure that it has gone ahead. Yes, so now the lens is in place. It is supposed to be placed again back into BSS, and once the loading is done, we are going to move to the patient now. All right. So this lens is the EVO plus ICL, which is the current generation of star ICL procedures. The EVO plus has the advantage that the optical zone in the EVO is much larger than even the previous generation EVO ICLs and the V4C ICLs. You get approximately 0.3 to 0.4 millimeter larger optical zone at the level of the ICL that translates into much larger zone at the level of the corneal optical zone. Okay, so the kind of optical zone we are going to achieve with this EVO plus ICL is going to be close to 7 millimeters at the corneal plane. Can I have retro illumination, please? Retro. Yes, good. Thank you. Yes, so we have a patient, Mir Saab, he's there. Yes. So they will adjust the table in 2 seconds, then we'll start. Okay. Yeah.
I think it's important to load the lens first and then start the surgery.
Yeah, for
phakic IOL, it's the other way around.
Yes.
Yeah, very important.
Especially for the star ICL, because the loading is the main part.
Vardhaman, it's very much true in phakic IOL. It's not that true in IOL, standard IOL.
Correct. Of
because
course.
your standard IOL may become very steep if you keep loaded and do surgery afterwards, and then by the time you finish your phaco and IEA,
absolutely,
the lens become really steep and difficult to inject the lens.
Sir, I'll say mostly it is more relevant, more so for the star ICLs, because the other ICLs are easy to load. In star ICL, you have to be very sure about your loading, and then only you should proceed. Okay, so this is, I'm going ahead with the side ports. It's very crucial that for the beginner, your plane of the entry is very important because you have a clear lens behind you.
It has to be parallel to the iris.
So it has to be as much as possible parallel to the iris. I'm going to use a bit of Oculan, which is a preservative-free preservative-free.
But on the right side port, what you are making?
Yes.
Normally it's a little on the lower side, no?
Sir, I do what is called as a angled incisions for the side port. So if you have seen in the right side, it is angled slightly towards the upper side. Okay, and the left side is actually towards the center. Okay, because I use the right side basically to manipulate the leading haptics. Yeah.
That's right. If you have it lower down,
then
it'd be easier for you to access that 6 o'clock, no, when you're going to.
Yeah, so that I'll be doing from mostly the left side, sir.
Oh, left is it?
Yeah.
Okay.
So again, I'm going to fill this. It is important that you don't fill it too much. Okay, you should still see some strands of viscoelastic. Okay, so I'm going to use a 3.2 millimeter incision. Okay, so it is important that you use 3.2. And I'll be now implanting this lens that we have loaded. Okay. So
You
meets
center
up.
it, can you center it little?
Yeah, 1 second, sir. Is it
Towards-
centered now?
Yeah, a little down.
Is it okay?
Yeah, zoom down a little, it's possible?
1 second. Is
Zoom
it
down.
zoom out, sir?
Down, down.
Okay, zoom out.
Zoom out, yeah.
Yeah. Yeah. Is this okay? Okay.
Yeah, that's fine.
I think this is more for my liking. Yeah, slightly more zoom. We'll make it centered. I think there is a slight disconnect between, bus, that's right. Yeah. Is it okay? Yes.
That's fine.
All right, so we'll be implanting this lens now. Okay. साहब थोड़ा pressure आएगा, कोई चिंता की बात नहीं है. So we'll be implanting them. So yes, so you have to be very slow and gentle when you implant. This is what my mentor used to call this as. This is called as a Mickey Mousing sign. If you could see those 2 ears which are unfolding. So if you are sure about the Mickey Mousing sign, that means you are actually implanted the lens in the current rotation orientation. The second thing about the star ICL is that it has a orientation mark in the form of hole, which is the leading right and the trailing left foot plate. Okay, so you have to be aware about that, and you have to put small amount of viscoelastic above the lens, so that the lens is actually gives us enough space for tucking. सीधा देखना है? Yeah. Can I slightly zoom in? Zoom in a bit? Slightly. थोड़ा सा chin ऊपर रखेंगे सर हम.
The leading one you put straight away underneath the iris, is it?
No. Both are above the iris.
Only. Okay.
Both are above the iris. Okay. 1 second. So we are again. Just 1 second. Yeah. Is it focused now?
Right side. Okay.
Yeah.
Fine.
Okay. Yeah. Which side? Oh. Yeah.
Focus down
Right.
a little. Yeah.
Yeah. Not forces. मुझे ये कुछ ही भी चलेगा. यानी just earbud. So
center it little.
Okay. Just a second, sir.
Towards the 6 o'clock.
Is it okay? Yeah, good.
Focus down. Yeah, better.
Yes.
Yeah, that's
good.
fine.
Yeah, so I have already tucked in the leading haptics. Now I'll be going and tucking in the trailing ones. So this is the last haptic is the one which is remaining now to be tucked in. Yes. So we are through with both the haptics and the lenses in its place. Once this step is done, now the last step is basically that you have to remove the viscoelastics in details. Okay, so you have to do eye. So it is very important that all the viscoelastic has to be thoroughly removed. One of the things which come handy is that it has that aqua port which is there in the center, which started from the time of V4C. That helps us to remove the viscoelastics which is trapped behind the ICL. If you could see, there is a small wave which is going behind the ICL, which basically gently flushes out all the viscoelastic which is behind the lens. And of course, you have to make sure that everything that is above the lens, you have to remove it in one go. In terms of the viscoelastics, of course, preferred is, one of the preferred ones is HPMC. The other one that you can use is like Hilon, because it goes in and comes out as a bolus. It is better not to use the dispersive viscoelastics, because once they are trapped behind the ICL, it is very, very difficult to remove them. And basically now, more or less, our viscoelastic is out now. Still, I'm going to wait for a few more seconds. Yes.
Very nice, Vardhaman. Very nice.
Thank you, sir.
Very beautiful demonstration.
So once this is done, we are going to just hydrate the wounds again. And once that is through, we will be closing the procedure. मीर साहब जस्ट सामने ही देखना है.
So why do you
Surgery is
prefer
करना.
star to IPCL? What is your...
Sir, basically one of the definite thing is that it has the longevity of the outcomes that we are aware about, because the first star ICL was implanted in 1993 and it has been FDA approved, CE approved for almost 20 years, FDA approved for almost 15 years, and now the current generation EVO has also been recently FDA approved. So there is a long track record. Definitely one of the other advantages is having the material, because it uses the Collamer. Collamer is known to have a much more friendly basically material, and the chances of cataract formation is also seen to be lesser. There is a study which was published by Packer et al. For the current generation lenses for almost 4,000 cases, and they have seen that only one patient developed it. This is Moxie, yeah. So they had seen that only one patient had developed pupillary block out of 4,000 cases, and none of the patients had developed cataract in 6 years of follow-up. So overall, I think I'm very happy the consistency of the wall that I get with this star. The quality of the vision is excellent. Of course, the other lenses are also good. I've had pleasure of using all 4 of them. All 4 of them are good. They have some advantages such as easier loading maybe. And the other advantage is that they can also come in the 0.25 kind of sizes.
Yeah.
So that is, but however, for vast majority of the patients, we do believe that star definitely scores over the other ones as far as the current generation is concerned.
Yeah, Vardhaman, point well
Yes.
taken.
Yes.
You have justified your ICL use,
Yes.
but what if opens reverse way? What do you do?
No, if it opens the reverse way, I think basically you have to make sure that your loading is perfect, because if your loading is perfect, it is very, very unlikely that it will open the reverse way. But if at all, you have seen during the first, I think injection, as I have told, that we have to be very slow, you have to look at that Mickey Mousing sign. If at all with everything that you have done, it still has opened the reverse way, you have to take it out. Okay, so you have to remove the lens completely, reload it again, make sure that your orientation is perfect, and then again re-inject it.
Exactly.
So you should
That's
not try
the
to do
point.
acrobatics in a
highlighted.
small place of anterior chamber. But it is very unlikely. If your loading is good, everything is fine, it is extremely unlikely to have such an event actually.
But anything can happen in surgery. You know?
Yes, of course.
So you should be
Anything
ready
can
with
happen.
it.
Anything
The
can happen in
plan
surgery.
should be like one should remove the IOL and reload and re-implant it, rather than flipping in the anterior chamber.
Absolutely.
Flipping is absolutely contraindicated in
Absolutely.
phakic eyes.
Absolutely, sir. Absolutely.
So I halt here.
Yes.
We welcome His Highness and respected senior Dr. M.M. Joshi sir has arrived in the
great.
auditorium.
Thank
we
you.
welcome Dr. M.M.
Sure.
Joshi sir.
ठीक है, मुझे थोड़ा सा लाइन दे देना. Yes, sir.
Dr. Vardhaman,
Yeah.
earlier I used to see in live surgery after phakic IOL we constrict the pupil. Since
Yeah.
morning we are seeing they are keeping as it is.
Yes. So I prefer not to constrict the pupil because of 2 reasons. Number one is, of course, it helps in the next 1 day for the viscoelastic to come out behind the lens very easily. Second thing is that it actually will give you a pseudo low vault. If you are using pilocarpine, pilocarpine is going to kind of push down the lens, and the vault that you get will be falsely low. So we definitely would like to have a very reliable vault on the first day. It's one of the reasons that actually we don't do both the eyes together in ICL. We always do one eye today. We see the vault next day. If the vault is acceptable, then only we go ahead and plan the next eye. So simultaneous bilateral ICL is something that I don't advocate because of the vaulting issue. Because 1 out of 200 cases may still show small surprise. So this is the basic reason I don't prefer to use the pilocarpine.
Thank you, sir.
Sure.
That was a very lovely surgery.
Thank
in
you.
the interest of
Thank
time,
you.
we'll
Just a
switch over
moment,
to the
I
next
just
award.
have one more. Vardhaman,
Yes.
I saw when you loading the ICL.
Sir, one second. Dr. KP, you can start. Until then, we'll have the last question from the audience. Dr. KP, sir, you can start. Yeah, go ahead, Vardhaman, sir.
Yes. Please ask the question.
I was asking whether I saw you pulling on the ICL. So that's something I would do differently. I don't pull on the lens. I would rather withdraw the cartridge from the other end. So
what I do is actually I do a bimanual thing in which I pull it, and also at the same time I'm pulling from one side, and I'm pulling from both the ends basically. Okay, so the cartridge also I'm trying to withdraw from my left hand, and the lens holding forceps on my right hand will also slightly pull it.
So the other thing I was going to ask you is how much time before do you dip the cotton applicator in BSS?
Sir, can we take this question
Just-
after this surgery?
sure.
Like we
Sure.
just, in the interest of time,
Yes.
we just switch over to the next OR. KP sir, you are on screen,
thought he's not ready.
So,
if we can have all of you all wear the 3D glasses, we'll move over to the next surgery.
perfect.
Excellent surgery,
So-
surgery, Vardhaman.
Yes, thank you, thank you, thank you, thank you, sir.
Thank you, sir.
Are we on?
Now,
What about
Dr.
audio?
KP will be showing us an trabeculectomy.
So I
So,
request
KP, are you ready?
Yeah. I mean, am I audible?
Yes, very much.
I think we'll probably cut
You
the...
are audible as well as visible.
Yeah, I'll start away right away because you're all waiting for lunch. I don't want to stand between the two. Just spare 5 minutes for me. Did not open the conjunctiva because this is a very important technique I wanted to show. Now I don't use mitomycin soaked Merosol sponges anymore. Don't wait for 2 minutes. This is a new technique which is now getting a lot of popularity. This is to inject a dilute mitomycin subconjunctivally. Okay? And then spread it across and open the conjunctiva quickly. There is no question of you putting any...
KP,
Yeah.
can you highlight the dilution proportion?
It's the usually 0.04% only, same diluted, same thing.
Okay.
So there is no other, there are many variations, but that the same thing will work.
Okay.
So immediately you open the conjunctiva. This case I just wanted to know, he is an young chap with steroid-induced glaucoma. Basically it's a juvenile open angle glaucoma which got exaggerated by steroid use. It's basically a case of a very severe chronic allergic conjunctivitis, and he has used steroids in the past. Even though he's off steroids, now his pressures have been always high, and you can see the congestion, the overall congestion of the eye, which is the responsible, that is the allergy, that is the reason. So now I just dissect backwards. So we are just making some adjustments. See, look at this blackish pigment is something that you need to worry about, because I need to take the scleral incision just in front of that. If I include this in the my scleral flap, then there will be a bleeding underneath the flap. So I just want to do a cautery, and here it's a very congested eye. This is okay. So I am doing a cautery. Oh, get back to the original thing only. So a good cautery for a cataract surgeon, for postgraduates to remember that for a cataract surgery you don't have to do cautery, it is optional, and better you don't cauterize too much. But in a trabeculectomy this is important because the blood and blood products
has to be literally bloodless.
Because the blood and blood products in the area of the bleb can actually spell doom and can cause healing, can actually close the wound. So can have, now I am taking an incision in front of this blackish thing. That is where the perforators stay. Obviously you cannot have a bloodless bleed in a very congested eye like this, which is a chronic allergy eye.
What was IOP with the maximum medical therapy?
Very high actually. It was not getting controlled with 4 medications. So that is the usual stuff in the JOAG. Normally
rectangular flap you are taking.
See, I am taking a rectangular flap. Okay, this is my usual thing, because I use what is called as the adjustable sutures, not releasable, what is called adjustable sutures. So I just do this with the same thing. I am going to make a cut. So you should have a very
Just 3
fine...
millimeter away from limbus or more than that?
Yeah, around 3 millimeters. Can I have a cautery again? To slightly go into the clear cornea. So I'll again cauterize these. Number 2. Now there is a time to make a paracentesis so that I can fill the eye with viscoelastic. Don't overfill, and also make sure that it is a phakic eye, so you don't really go too much inside out. That's why we constrict the pupil with pilocarpine pre-op. In patients where we cannot constrict it completely, you are in trouble. Be careful. So now I make a opening, the ostium. I do a freehand cut. I don't use any punch. I do a rectangular freehand cut.
So this chunk, this block, rectangular block I am cutting. So now you have a nice, trabeculectomy opening. Whatever is the iris which is coming through that port, that you cut, because that is going to block it. Now this is the most important step, is to now put viscoelastic. So I just check the ostium. Now it is freely. So that means that you actually have nothing obstructing the outflow. This is my first level of calibration. Immediately I form the anterior chamber with viscoelastic. This is very important step, because you don't want 10-0 please. You don't want any hypotony which can actually create a vicious cycle of what we call as choroidal effusion or choroidal detachment. So I am just going to demonstrate an adjustable suture, and maybe we can wrap it up.
Won't the air bubble will serve the purpose here?
No, it's basically this eye, after the block many a times.
Because removing the visco after the trabeculectomy will be again a challenge.
We have a filter, Anything in the eye will go through the bleb, so there is no question. Even if you fill completely with viscoelastic, there are many cases, especially in pediatric glaucomas, we leave the eye completely visco-filled. Okay, so this is one area I am showing where I am just making a cut here. Can you see this? This is actually a...
leave the, KP, do you leave the visco there?
Yeah, I don't plan to remove it at all.
Oh, really?
Yeah, because there's a filter actually. Whatever is there in the eye, it's not like a cataract surgery where it has to go through the angle. Now we have a filter. So I'll just show you once again the adjustable suture. There are 2 adjustable, or sometimes we put 3 adjustable. Here, the thing is, it is not a complete, so it's just a slip knot. You can have 3 or 4 throws. Sometimes I put 2, sometimes put 3. So I'll again show you. Now AC is formed slightly. This is important. If the AC is completely flat, you will set up what is called as a choroidal effusion. You will end up with a shallow AC next.
How many throws you are taking there?
Only 3. Normally,
and then take
4 is. I tried 4, but I feel 3 is better, because I am going to adjust this post-operatively if necessary. So I am going to zoom this and show you again.
Your surgical field is very nicely visible. It is well centered.
Okay, see
So
now
that's a great.
hydro. So now the calibration level 2, I just let that visco out, and little BSS I am. So now know that eye is actually becoming hard. So this is the time to adjust my tension in the sutures. Slightly. See, now again we will calibrate it again. Look at the oozing or the... So now it is oozing now. It's coming out through this.
Very
Okay.
nice.
So calibration number 2 is oozing. At the same time, this is also becoming shallow. So now there is a need for a 3rd suture. Whatever you calibrate on the table will give you what you can expect post-op. No traps. The outcome should be a surprise on day 1, because you can always calibrate this. So
This is very important step of this trabeculectomy. One need to titrate the IOP.
So I can actually make this a filled, completely, a normal suture, or I can make this also adjustable. I also use releasable, but after starting this, I have reduced my releasable sutures to a great extent. Hydro, saline. So what you do is post-operatively. So now I just again hydrate this.
You don't tie a knot here.
I don't tie knot, it's just that.
Just
so what
3
happens
throws.
is, see, this is now, it's a eye is taut, but if I still put, it comes out. So what I do is, the point is that if at all I am having an underfiltration post-operatively, I just rub on this area vigorously, so that the knot actually loosens a bit. Not all, 1 or 2 will just loosen to the extent that I can actually form the bleb completely. So this is I think I'll quickly finish this. I have stopped using 8-0. 8-0 causes a lot of inflammation and causes more congestion and very symptomatic. 10-0 is the ideal suture. I just show you how to put a first 10-0. This is through and through, through the episcleral tissues, inside out sutures. So when we actually tie the knot, the knot goes inside. So you can see this patient has so much of congestion. Some bleeding is still happening whenever I touch conjunctiva. See, this is important. I am going through episclera. This is not like a pterygium closure where you do a conjunctiva to conjunctiva suture. In fact, this conjunctiva should come forward and it should be pulled. Yeah, otherwise the knot will move away.
Yes.
So the bite has to be through the episclera. So this comes forward, and once I suture this, the knot goes inside. Of course, this won't be like this. After 1 or 2 weeks, it will become loosened, which we remove it in the follow-ups. So now this knot, and the second knot is probably very important.
How do you prevent the retraction of the flap?
Exactly. So now I am showing, now this has to override this.
Yes.
This has to override this. I pull, I don't take at the edge, I take more inside, again through the episclera. So once I tie this, the conjunctiva comes forward and gets pulled onto the thing. So there should never be just an approximation to the limbus, it should ride on the clear cornea. So these sutures will make sure that it will not retract. And 10-0, having a good tensile strength, at the same time does not attract any kind of inflammation, hydro. So I'll just show you the, now I form the anterior chamber. We can see the bleb also forming.
Beautiful.
Okay, at the same time the AC is not being lost. If there's an overfiltration, there will be a sudden shallowing of AC and bleb becoming bigger. And the last final nail in the coffin is this suture. This is probably the most important part of the surgery, where you have to anchor the free conjunctival edge to the clear cornea. If you have taken a small peritomy, 40-degree arc peritomy, you can just one mattress suture is good enough. Otherwise, you can put an infinity suture. So what I do is, this is a suture again, 10-0, which we can remove later. Don't use 8-0 here. There are many other techniques like Moorfield's technique, where they have done a lot of etchings in the cornea to put this. I don't like even a corneal traction suture. You don't want to be cornea surgeon. This is good enough. And this will see that the bleb will not leak from the conjunctival free edge. And the last part, give me another 5 seconds. So we just now have a final calibration. We form the anterior chamber, and the bleb is big enough. You can have a nice PI, AC is formed. So this is my surgery, and we make sure that post-operative follow-ups, he will neither have overfiltration. I am going to put a cycloplegic so that we don't have a problem of a malignant glaucoma or any overfiltration. At the same time, if at all this case is bound to fraught with complication of bleb failure because of the age, as well as the inflammation, as well as a long-term AGM use, we are going to make sure that these steroids, these adjustable sutures are tackled, as well as we can even give a post-operative subconjunctival 5FU or mitomycin injections. Thank you very much for your kind attention.
Very nice.
Thank you very much.
KP, can we use alpha-gon Z to just reduce the bleeding?
You can. No, he is actually on all that.
No, on the table.
On the table. Sir, actually that works for maybe a normal patient.
Okay.
But this is a patient who's got, chronic inflammation. He's highly congested.
Yeah.
It's a chronic allergy, so it won't really work on that. Thank you so much.
Beautiful. Lovely surgery.
Aditya, bada channaga.
You don't take triangular flaps at all rectangular only.
No, not necessarily. Not necessarily, but this is the patient where I took a rectangular flap where I can use adjustable sutures.
Yeah.
I think these adjustable sutures work well with rectangular flap than triangular flaps. But you can always do it. There are many ways to do a trap. What is important is the calibration. What is important is creating some way by which you can modulate the filtration when the healing kicks in and when the bleb starts flattening.
Thank you, Dr. KP. A wonderful demonstration of trabeculectomy. So now we'll go ahead with felicitation function for Dr. Mohan Rajan. I'll I request Dr. Srinivas Joshi to take over.
Dr. Srinivas, 2 words. Hello, Dr. Srinivas. 2 words.
Yes, sir. Please go ahead.
I thank you, Dr. M. I want light.
Please put on the lights, please. Lights. Full lights.
I thank Dr. M.M. Joshi, sir, and MMJI Institute for such a wonderful CME. We are observing a series of CMEs last since 25 years. And I would like to say that I have attended more than 15 CMEs and become a part of it. And every time I have gained something. I hope this tradition of organizing CMEs and spreading knowledge will continue forever. Thank you, one and all.
Thank you, sir. Thank you so much.
So indeed, a very truly.
Guru Prasad, sir, please come up. So since Dr. Mohan Rajan is leaving by evening flight, I thought we should just felicitate him. I request M.M. Joshi, sir. Stage lights on, please. So Mohan Rajan, Dr. Mohan Rajan doesn't need any introduction, but to say a few words about him, he has presented many national and international papers and MSIS, MICS across the world, several innovations. To his credit, like Panchorexus, Mohan Rajan Chopper, and he has delivered 27 named orations and 46 publications, several awards. I think most of the age is, if you count it, it's more the awards than the numbers of years that we have spent here. I think he has won 58 OPL awards, and apart from that, he has received awards from AAO, APARS, ASCRS, ESCRS, APAO, WOC, POC, 2OC, what all you want to add it, he has, all OC awards he has won. And received more than 60, yeah, it's written here, and he has received Best Doctor Award twice from Government of Tamil Nadu.
One from DMK, one from ADMK.
Oh, from 2 political parties. And has trained and mentored more than 500 ophthalmologists, and of course, the ophthalmic premier, he has won several awards in that. So I would like, MM Joshi Eye Institute takes pride in honoring Dr. Mohan Rajan today. Thank you, sir. Thank you. And a kind request from all the delegates. He is our man from South India. So if you can oblige him by casting your votes for the post of Vice President, he will be really very happy.
Friends, I would like to thank M.M. Joshi, Eye Institute, the entire team here. Every time I come here, I find something very new. I learn. It's so inspiring and motivating. And I want to make it a visit every year. This is probably the 5th time I'm coming here. Really wonderful team, fantastic. They are a source of inspiration, motivation for all of us to do better and better in ophthalmology. Thank you very much for this great honor. And I would like to thank my guru, mentor, and also I'd like to felicitate him. As I told in the morning, this is a color atlas of retina and optic nerve, which I released just last month. The foreword is by Dr. Lingam Gopal, and it contains about 350, 400 high-resolution photographs, all from our fundus camera and Rajan Eye Care. To all spotters, anybody requires, please let me know. I'll send it across. Till the elections, it's free of cost.
So he is gifting us a 2000 rupees book, and make sure that all of you receive it before casting the vote. Thank you, sir. I would like to call up the chairpersons and the panelists, Dr. Shravan Pandit, sir, to please come up. Dr. Shravan Pandit, then Dr. Shilpa Kodkani, madam, Dr. Shivanand Bubnale, sir, Dr. Srinivas Deshpande, Dr. Anand Kanbur, and Dr. Sajid Tebla. Get. Yeah, and I request our organizing secretary, dynamic, smart young man, Dr. Abhishek Bowdekar, please come up on the dais. Dr. Shivanand, sir. Dr. Anand Kadbur, sir, from Bijapur. Dr. Srinivas Deshpande, sir, from Hospet. Dr. Sajid Tebla, sir, from Belgaum. He has not come. Vishal Govindhari. Vishal. So we have another faculty guest speaker, Dr. Vishal Govindhari, who is leaving tonight. He has to go to Kadapa. They have established a beautiful center in Kadapa. It's called as the Pushpagiri Eye Care Center. And he is soon going to be the right-hand man of Jagan Mohan, the Chief Minister of Andhra Pradesh. So a young dynamic vitreoretinal surgeon from Hyderabad. I request Joshi sir to please honor him. The rest set of the awards will be Dr. Vardhaman, he is also leaving. Dr. Vardhaman and Dr. Sanjay Russell to please come up. The rest set of awards to the speakers and the faculty will be given in the evening banquet. Dr. Vardhaman. Yeah, he'll attend the banquet and go, I think. Dr. Sanjay Russell, please. So thank you very much for the patient listening, and we'll have the first lunch break, and we'll see you all soon by half an hour. The North Karnataka cuisine has been prepared for you all. I hope you all enjoyed the first session, and we'll be back in the second session. We have interesting talks coming up, and we also have a talk from Dr. Guru Prasad sir on IOL drop, what to do next. I think that's a very important topic which most of the general ophthalmologists wants to know about it.
Now we'll all break for lunch. After that we'll assemble.
फ्लैश चार्ज कर किधर इधर वो फुल हो गया श्योर है
पानी नहीं रखा, पानी की बोतल नहीं रखा, बोतल नहीं रखा, ग्लास मैंने कहा किसका ग्लास है, पता नहीं भगवान का। हाँ तो उसको रोहन को बोलो हाथ से क्या करे।
रोहन ना अलग लेवल का क्रेजी आदमी है। मेरे को रोज डांटता है कि मैं कैंटीन में से कॉफ़ी क्यों पीता हूँ। मैं वो घर से अपना मग लेके आने दिन में 5 बार कॉफ़ी पीता हूँ, 5 मग लेके आऊँ, यहाँ पे रोज आके मग लूँ कॉफ़ी पीने के बाद दिमाग है कि नहीं तो प्लास्टिक कप भी यूज़ कर रहा है, वैसे मस्त
You cannot do that. People, जो लोग इतना दूर से आए वो कह रहे हैं कि यार इतना खर्चा किया तो कम से कम थोड़ा
क्या आ गया कुपस के लिए कॉल? हमारे पास भी नहीं है वैसे।
हमारे पास
Retina का
अपूर्वम का वीडियो
surgery is at 2:30 sharp. They will start.
अपूर्वम का सर्जरी है और रेटिना के टॉक्स 4-5।
सर ने वही बनाया खाने के बाद
सोना है। वेरी स्मार्टली दे रहे हैं रेटिना सर्जरी आपको।
See the best is 3D surgery है। Wear the glasses, किसी को नहीं पता चल रहा आप सो रहे हो। सो जाओ।
अरे एक अंकल यहाँ बैठ के सोए हुए थे, अंकल केवल क्लैप्स को उठ रहे थे। सोने के एसी में सोने के लिए आए थे।
खाने के बाद आएंगे। सारे हमसे फैकल्टी पहले निपटाए हैं, सारे लोकल फैकल्टी बात करते हैं।
देखेंगे कि अब विल हैव अ बीप, अगर टाइमर होगा तो बीप पहली बीप आने के बाद मतलब कि 1 मिनट बचा है तो उसमें वाइंड अप कर
लंच डिनर दोनों के कूपन डाले हुए हैं।
लंच डिनर कल का लंच
सब कुछ डाला हुआ है। तो एक बार माइक पे अनाउंस करूँगा तो ये चीज़
करवाना चाहिए था पहले जब जा रहे थे लंच के। और स्टार्टिंग में यू शुड हैव अनाउंस कि जो आए हैं दे हैव टू टेक देयर बैग जो फोल्डर है क्योंकि सबने नहीं दिया, काफ़ी लोग तो ऐसे नंदे आ गए।
इन्होंने जबरदस्त सबको दिए हैं बट सब लोग इधर उधर फेंक भी दे रहे हैं।
हाँ कोई नहीं कब फॉलो कर
फोल्डर को कौन नहीं है
रख के छोड़ दे। बारकोड लाइन में होता ना वो, हाँ इसमें आता था स्कैन करते हैं इसको बारकोड रीडर से एंड देन यू कैन डू इट।
ಹಾಕಿರ್ತಾರಲ್ಲ ಅದ್ರೊಳಗೆ ಒಂದು ಕೇಬಲ್ ಯೂಸ್ ಮಾಡ್ಬೇಕು ಆ ಟೈಪ್ ಪ್ರೈವೇಟ್ದವ್ರು ಅದೇ ಅಷ್ಟೇ ಕೇಬಲ್ ಬೆಳ್ಳಿ ಅವರು ತಾವು ತಮ್ಮ ಕೇಬಲ್ ಹಾಕ್ಕೊಡಲ್ರಿ ಅವ್ರು ಮಂದಿ ಕೇಬಲ್ ಯೂಸ್ ಮಾಡ್ತಾರೆ ನಮ್ಮ ಮನೆಗೆ ಯಾಕೆ ಯಾವುದೋ ಜಿಯೋ ಅದ ಚಲೋ ಬರ್ತದೆ ಸ್ಪೀಡ್ ಜಿಯೋ ಈಗ ಚಾಲು ಮಾಡಿದೆ ಸರ್ ಅದು ಪೋಲಿ ಯಾಕೆ ನೋಡಿ ಸರ್ ಈ ಕಡೆ ಪೋಲಿ ಓಕೆ ಅಂಡರ್ಗ್ರೌಂಡ್ ಇಲ್ಲ ಅದು ಅಂಡರ್ಗ್ರೌಂಡ್ ಇಲ್ಲ ಸರ್ ಯಾವುದು ಮಳೆ ಬಂದಾಗ ಎಲ್ಲ ಕಡೆ ಅಂಡರ್ಗ್ರೌಂಡ್ ಐತೆ ಬಟ್ ಅದು 3 Mbps ನಮ್ಮ ಹಾಸ್ಪಿಟಲ್ 3 Mbps I had
retina.
Dr. Manisha Agarwal, do we have her here? Dr. Vijay Nagaraj. Hey, just go down. And Dr. Vijay Nagaraj and Rajshekhar Diabetic. Dr. Pooja Sinha, yes ma'am. You be seated here, ma'am. And Dr. Vishal, yeah. Dr. Manjunath, BA. Dr. Manjunath. Okay. And Dr. Saurabh Shah. Hello. Yes, sir. Please come in front, sir. No. Okay. I'll just. You had a word with Apurva? Yeah, he's getting ready. He's ready. He's come actually. Okay, great. Tell them to start the feed over here. So the idea is Okay, good afternoon everyone. I hope you all have had a hearty lunch. So we're going to start with the next video session. It's a case of proliferative diabetic retinopathy, which is going to be operated upon by Dr. Apurva Ayachit. So we'll go over straight to the OT. So this session will be chaired by Dr. Manisha Agarwal, Dr. Vijay Nagaraj, and Dr. Rajshekhar Diabetic. And the moderators would be Dr. Vishal, Dr. Manjunath, and Dr. Saurabh Shah, and Dr. Pooja Sinha. So if we can have the feed, Rajeshri, can you hear me? Rajeshri?
Yes, ma'am. Go ahead, ma'am. Your mic on, ma'am.
Yeah. Can you hear me now?
Yeah, we can hear you.
Okay. So I'll be sharing a case of diabetic vitrectomy. Now the view is very hazy because of altered vitreous hemorrhage, and the B scan shows some membranes and tractional retinal detachment, and I have a suspicion that there is a combined retinal detachment as well, probably because of a break. And I can see inferotemporally there is some bullosity. So let's see, let's see how it goes. It will only be revealed after I clear the altered vitreous hemorrhage. So if the panelists and moderators have come on stage, we can start discussing the case. In my much shorter experience than most of the panelists, I feel that whenever there is an altered vitreous hemorrhage and TRD, it's a lot more difficult surgery as compared to a scarlet red vitreous hemorrhage, so to say. So would the panelists please comment on this observation?
Hello? It's audible. Yeah, can you hear, Apurva?
Yes.
Yeah. If things are ready, you can start the case.
Did you all hear my question? I mean,
the question was the difference between a scarlet red fresh hemorrhage versus an altered hemorrhage. How does it guide you towards surgical steps?
more than that, sir, is it possible that in altered vitreous hemorrhage, the membranes are more sinister? Have you seen anything like that? Although it is anecdotal, it's only based on my observation.
Yeah, compared to this fresh hemorrhage, definitely there will be some alteration in the vitreous which you can see in old vitreous hemorrhage. So they will be associated with some membranes.
Right. So I'll dive in straight to the surgery. I'm using 25 gauge vitrectomy here. With me I have our very experienced scrub nurse Mrs. Shanta and our senior fellow Dr. Rajeshri along with our floor nurse Mr. Vittal. So with the blessings of my mentor, I'll start the surgery inferotemporally, pseudophakic patient. So 3.5 mm. This patient was operated recently for cataract. On 18th he underwent a phaco with foldable IOL placement. You can see that there is a subhyaloid hemorrhage. I say it is subhyaloid because there is a hyaloid attachment at the posterior capsule also, as we know as the Berger space. So I've checked the infusion. It's in. So I'll tell sister to start the infusion. Infusion is at 30 mm of Hg. And now I'm going to place my trocars superotemporally and superonasally at again 3.5 mm. Notice how I retracted the conjunctiva. That will ensure that my conjunctival opening and the scleral opening are not in the same place. And okay, this went straight in, no problem. So we'll start. I'll just clear the anterior vitreous a little bit. Can you adjust?
Hey Apurva, have you considered any pre-op anti-VEGFs in this case?
Yes. So this patient received an anti-VEGF Avastin on the 18th along with his phaco surgery. So you can see that I am clearing the visual axis from the hemorrhage because otherwise this hemorrhage is going to impede my view. So I am going to clear it as much as possible without harming the posterior capsule. So I am doing that, and as long as my central visual axis...
Can you zoom out a little bit, Apurva? It's very zoomed up, too much.
Okay.
Little.
Should I zoom in?
Zoom down, zoom down.
Is it better now?
Yeah.
Okay.
Just can benefit of beginners, why do you choose for 25 gauge?
We mostly 100% of our cases are 25 gauge only, and for diabetic membranes it is easier to use 25 gauge because our cutter probes tend to act with multiple functions. Like many times we tend to use the cutter itself for segmentation, and you do a conformal delamination with the cutter itself. So our dependence on forceps and scissors comes down. With 27 gauge it's even better. You do not need any of those. The cutter does everything. So I'll ask Rajeshri to focus a bit. 1 second. Visco akidire. Okay. So yeah, the view is a little better now. Okay. Yeah. So now we have a combination of fresh vitreous hemorrhage and altered vitreous hemorrhage. Since the patient is pseudophakic, I have the luxury of crossing the midline, which I wouldn't do if the patient were phakic. I think even with less grades of cataract, it is always a nice thing to render the patient pseudophakic before a diabetic surgery for ease of peripheral dissection. So when we are doing an outside in vitrectomy, we truncate the vitreous like I am doing here.
You are using a recite.
Yes, sir.
Yeah.
I am using recite. So you can already see that the membranes are very adherent. I am doing an outside in, I am truncating the vitreous. The vitreous is quite held up.
Shanta sister, ಸ್ವಲ್ಪ lens ಒರೆಸ್ರಿ.
There are some blood strands at the posterior aspect of the lens also. That may also be impeding your view. So is it better now? Is it better now?
Yeah.
Okay. Can you please move the tubing? Yeah. When I say I am truncating the vitreous, what I mean is I am shortening the vitreous skirt. So if you imagine this as a long skirt, I am actually trimming it to make a shorter skirt. So that's what we call truncation. And here I have to be very careful because sometimes we don't know if the retina is being held up by membranes and we go with a very over enthusiastic approach to get rid of the apparent vitreous and end up with giant retinal tears. So, so that's my vitreous being released from its peripheral adhesions. So I will not be too aggressive in doing vitrectomy more anterior to that right away, because that I will do at the end once my posterior membrane dissection is over. So now as you can see, the membranes are held by this peripheral vitreous here. Can you focus, Rajan? Yeah. So this is something we have to free. The membranes have to be freed from the mid-peripheral and the peripheral vitreous, like I am doing right now. That ensures that when I start my membrane surgery, they are totally free from their attachments and they will come into my cutter easily if I choose to do a fold back delamination or a conformal delamination. So there we go. Here again I am cutting the attachments of the vitreous to the membranes. You can see now how the retina is pulled up by these membranes. You can see this concave configuration of the retina. This is typical of a tractional retinal detachment. Here you can see there is some convexity. There is probably a break somewhere around here which is causing SRF to go inside and probably causing a combined retinal detachment in this area. Here again it is a little convex, the detachment, but look at this. This is very concave, so this is probably purely a tractional component of the RD. So now if you notice, I am holding my cutter at an angle, at an acute angle, and I see that the membrane just folds back into my cutter. That's because I have freed the membranes from this peripheral vitreous attachments, and this is how you do a fold back delamination, where it just folds back into the cutter just by virtue of the angle of the cutter and the membranes being totally free from the surrounding vitreous. So the advantage of using these beveled 10K cutters is that you can go really close to the tissue. They are very high speed and they tend to be very safe without causing any vitreoretinal tractional jerky tractions. So here I am going to probably plan a chandelier surgery, as in a chandelier assisted bimanual surgery. You can see here that, okay. The panelists can feel free to please comment on whatever I am doing.
How many days before anti-VEGFs have been given?
I'm sorry?
When was the anti-VEGF?
18th of April, around 5 days ago.
5 days before.
So at this point, I will just look out for any bleeders. I think I'll feel better if I put a chandelier at this point itself. I don't want to, push my luck too much and, go with my cutter everywhere and have problems. So I'm going to go in with the chandelier and use bimanual surgery.
Just at this point, I just want to have a word with Dr. Guru sir. Has been improvement in his instrument. Does the indications of bimanual surgery have come down?
No, I think whenever there is a doubt that the membranes are strongly adhering to the retina, because the retina will also be atrophic. It won't be thick, it will be thin over a period of months to years. It's always better to err on being safer by putting in a chandelier, but we can always give a trial with forceps. We can use forceps in the beginning to get a feel of what is happening to the underlying retina when you pull.
Yes.
If you feel that it is going to break, then you put in a chandelier and do bimanual surgery.
Apurva, can you hear me?
Yes, ma'am.
I agree with sir that the kind of membrane that you are dealing with, sometimes what I do is I reduce my cutter speed, and the cutter then it itself acts like a scissor, and just by activating the suction, try to lift the edge of the membrane, and sometimes to our surprise, though it appears to be very tightly adherent, it's able to come off quite easily and you're able to get a plane, and then you can just remove it with the cutter itself.
How much cutter do you prefer, ma'am? That's the case.
I go down to something like 1,000 or 2,000.
Yeah.
Okay. So yes, in this case, I have a feeling that the underlying retina is quite thin. So I'm not going to push my luck, as I stated earlier. I'm going to dive straight into bimanual. So actually Rajshri is holding the light pipe itself. We are not using a chandelier. She is holding the light pipe for me. She is giving me the spot with her spotlight, and I find that gives a lot better exposure. If you have a good assistant, you can make them hold the light pipe instead of using a chandelier, wherein the control is a lot less. So I'm just going to clear the hazy view a bit. There's some dispersion of the hemorrhage. So give me the light pipe, please.
What's your experience with the hydrodissection, Apurva?
I have done that, sir. I have done hydrodissection in quite a few cases. It's a good tool, although the membranes are easier. Only if the membranes look relatively simple and the retina doesn't look too thin, I venture into hydrodissection. Otherwise, I don't.
Basically, you need a tight compartment. So in such cases, I think it will be useful.
So there.
Is there any active bleeder over here?
Yeah, I must check for that.
I think there is a oozer there.
Yeah, here somewhere, yes. So I'm going to raise my infusion to 60 first, and then I'm going to go ahead. The disc already looks quite compromised. If you see, it's not very perfused, so I should not keep my infusion at 60 for too long. I think that matters. So there is a hyaloid here which I can get rid of.
So rather than the pressure rise, won't it be better if you fixed a chandelier and then you are able to locate the bleeder?
Yes, ma'am, I'll do that. I can use a suction in one hand or a extrusion cannula in one hand and use diathermy in the other, because anyway I have another port through which I can put my light pipe or chandelier. So I'll do that, I think. Can you put the light pipe? I'll diathermy. extrusion. What instruments do the panelists use if you ever do viscodissection of membranes?
Same 25 gauge cutter. But prefer, I think many are using 27.
Backflush. So I'm using a back flush here, a flute needle. I'm going to blow on these. Okay. Yeah. So I'm just going to gently do this. With that, sometimes you can see that there are bleeders which I can cauterize.
We can also use proportional reflex.
Yeah, we can.
Like with extrusion.
Yeah.
Which also helps
But
in the
if
same
we have
fashion.
just aspirated the hemorrhage, we use a proportional reflux, we just end up refluxing the same red fluid. So that's one thing that tends to happen.
For the interest of the postgraduates, we have different kind of forceps like max grip, the end grasping, and which serve for the different purposes. And I would like to, like Apurva, to highlight on what type of forceps she is going to use.
I'm going to use
to
an end.
hold exactly which position and how she is going to look out for the secondary membranes in this case.
So secondary membranes, I just go by intuitive feel by using the cutter itself. I go with my cutter and I just nudge the membranes like this. As you could see, I could easily, that membrane just came out with no problems. So I'm basically getting the plane here very nicely.
Yeah. Problem with these cases are you will have multiple membranes.
Yeah, vitreoscheisis is a real problem.
Yeah, identifying a correct plane is the challenging.
Yes.
But I think in this kind of situation, the Intra-op OCT would be of some useful tool for you.
It's a very low resolution OCT. I wouldn't use it for this case. Green filter. I just want to demonstrate filter here and yellow filter.
Tell about this filter.
Yeah, so the yellow filter somehow makes the membrane stand out in better contrast. So this bridge just got cut. Now forceps. Chandelier hit kori. Forceps and scissors. There is one particular epicenter here, if you notice, that is really adherent. I don't want to again push my luck by using just a forceps, so I am going to go in bimanually and cut it. Okay, normal filter, no filter. Off, yes. So there. Can you show the light properly? This was a particularly adherent bit. I am going very, very slowly here. I hope that's visible. Yeah. Clean. Save for this epicenter, I think the membranes here nasally are quite okay to be lifted by forceps only. So I am just going to take care of this bimanually.
With the ingenuity, with the availability of the filters, the need of chromovitrectomy has reduced for you, or is it the same?
So
like
to say chromo, I just use BBG, and anyway without filters or no filters, I wouldn't use it at this stage. So yeah, coming to membrane surgery, I mean the macular surgeries, yes. So using, I mean BBG has come down at least in a percentage of my cases. So if it's easily visible, I think Dr. Srinivas also showed the monochrome setting in the morning. It's beautiful, the view is beautiful with monochrome.
I would like the audience to see that how she's like engaging the membranes and finding an appropriate plane to like engage the instruments. This is the most important part where we will like endeavor into making breaks which are not
so if you
appropriate in these
notice,
cases.
when I was pulling at this, I should be very cognizant of membranes at the distance also. I should not be...
Is the IOP lowered or?
Yes, it's lowered. I'll just get it back up after I clear this. I hope blood doesn't play spoil sport in my surgery. So this is the problem. You end up being too preoccupied with dissecting membranes and thinking to yourself that, oh, the surgery is going so well. And then you really look and you find blood which has clouded your view. So so you should switch from membrane dissection to aspiration of blood frequently, toggle between the two as frequently as possible, because more the bleeding, it's like game over. So although I shouldn't be saying it, but it's true. What do the panelists think?
Yeah, only thing is you should identify the bleeder as soon as possible. That's the only way which can prevent all these things.
Yes. There seems to be an active bleeder somewhere which is continuously oozing. So let's see where it is.
Was the patient with any aspirin or something like that?
No.
What is your practice, whether you want to stop the patients for an aspirin nowadays?
Yes, we don't stop the patient on aspirin, we stop clopidogrel.
Clopidogrel.
Yes, not aspirin. Yeah, better, much better, thankfully. So, right. So this seems to be away, so I'm going to just cut it off. Right. Okay. So you can go even higher than 60. Many times 60 is not enough, especially if the patient is hypertensive. You can go up to 80 also, but be mindful that it is quite high and come down to 60 as soon as you have gotten rid of the bleeding or the oozers. So, does anybody in the panel raise the pressure to more than 60?
No, I have never tried that, going above 60.
I also usually avoid actually raising the IOP, because as you mentioned that the discs are already compromised. So I think the moment you feel that there is an oozer, the best is to cauterize it before the blood spreads too much and it becomes like another membrane. And because even though at the end, if the surgery looks very clean, sometimes we are disappointed because the disc is totally gone.
True.
Apurva, this is Vishal here. Couple of things. One, you could use the tip of your cutter itself to hold the bleeder down. It's not very retina friendly, but if you're in a desperate situation where by the time you come out with your cutter and get your diathermy in, you're going to notice that bleed is going to be a lot. You could do that, or a quick fluid air exchange can help you.
True.
And then hold the bleeder down for some time.
Yeah. Okay. Backflash.
There's some, somebody can clear the lens.
Lens versus. This tip is too long. That's why it's not going in. So it's going to take a couple of more minutes for me to clear all this. And
Still there also.
Will a fluid air exchange help?
yeah, should I do that?
I think
So while we clear the field, we'll take one talk before and come back to the video, the surgery. So
Sure.
if we can, we'll have Dr. Vishal carry forward with his talk on the basics of OCT in retinal diseases. Can we have the lights?
Lights on, please.
Not here.
So we have our guest faculty, Dr. Vishal, a very promising youngster from Guntur in Andhra, and he is going to give us a talk on the basics of OCTs, which is going to be very useful for practitioners as well as postgraduates who are here. Dr. Vishal, I've had the good fortune of interaction with him in the recent webinars that we have had during the COVID times, and I think he'll do a great job in the next 10 minutes or so. He's done his DNB from Pushpagiri Vitreoretinal Institute and fellowship from the L.B. Prasad Institute, Hyderabad, and he's consultant in Vitreoretinal uveitis and pediatric retina services in Pushpagiri Vitreoretinal Society. Is it near Guntur?
It's the society, we are based out of Hyderabad.
Okay.
So thank you, sir. Thank you, Guru Prasad, sir, for the lovely introduction. It's always an honor and pleasure to work with you, and I thank Srinivas, sir, for the invite. So my talk today is basically a very quick view of how we can use the OCT in our practices. So the OCT has come a very long way for us, right from 1971 to where we stand today. And it works basically on low coherence interferometry, where two waves, one from the reference arm and one from the source arm, sort of meet the tissue of interest and come back to the detection probe. And based on the difference in interferometry, the tissue is shown on the printout. It's a very commonly used tool by the retinal physician and provides cross-sectional retinal imaging of micron resolution. As you can see, right from time domain to spectral domain to swept source, it has come a long way. Very quickly looking at how time domain was, you see the number of A scans the number of A scans have just gone up per second quite significantly. And what is very important is not the axial but the transverse resolution. This is where the OCT is sort of stuck. This is what separates cells from each other. The axial resolution has improved from time domain to swept source, but it is the transverse resolution where we are having further advances today in the form of adaptive optics. So just to quickly look at OCTs, on top here is the time domain, very granular. You are not able to see multiple outer retinal layers, much clearer in the spectral domain with 4 white bands in the outer retina and the inner retina quite clearly seen. And here you have swept source, a deeper incident light, so you can see the sclerochoroidal junction very nicely, and the retinal layer clarity is much better. So as you can see, with every generation things are getting better. You have all protocols which we use. We'll quickly look at what protocols we use. The simplest protocol we use is a 5-line raster. You can center it around the fovea like it is here, and you can have it horizontally, vertically, or at any angle. Here you have a 24-line radial scan where multiple slices are taken radially, And this is the most useful one, which is the 3D volume, where you have something like 512 A scans per line and 128 such scans taken. So that will give you a lot of three-dimensional data. This is the international nomenclature for OCT, which came out in 2014, where all these names were sort of agreed upon or partially agreed upon. So what's most important is the alternating bands. You have the hypo, which is the ganglion cell layer, then you have the hyper, which is the inner plexiform, then you have hypo, which is the hyper, which is the outer plexiform, and then the hypo, which is the outer nuclear. And the oblique fibers at the fovea are called the Henle's layers. What's most important is the 4 outer retinal bands from the external limiting membrane, the ellipsoid zone, the interdigitating zone, and the RPE. Below is the choroid with the choriocapillaries right below the RPE, the hallus, satellus, and the junction. So when you look at a normal OCT, you're looking at all these structures, you're looking at the foveal contour, and you're looking at the vitreous if it's separated from the retina. This is what a normal OCT should look like. So how do we interpret it? We'll interpret it from right from top, from the vitromacular interface onto the inner retinal layers, then the outer retinal layers and the choroid. Based on what generation of OCT you're using, each of these structures can be visualized. So we'll move on to a few examples now so that we can understand how we can look at different patterns on OCT. So this is a case of vitromacular traction. In vitromacular traction, the central 3 mm of the retina, the vitreous does not separate. And you can see different changes happening like cystoid spaces or a neurosensory detachment happening. It can be focal or it can be broad-based based on the size, which is at 1500 microns. And this is sort of a alteration in the vitreoretinal interface. I think inner retinal changes, moving on a little bit further, when the vitromacular interface interactions worsen, then you have what is known as a macular hole, where the internal limiting membrane separates the retina and the traction from the vitreous in the internal limiting membrane leads to a macular hole. This patient actually had asteroid hylosis, so we were not sure why the vision was poor, but when we did an OCT, we could find the macular hole, so that explained the vision for us. Moving on, macular edema is something which we very commonly associate with the OCT. It's an inner retinal change. Here you can see a lot of hyperreflectivity and edema in the retina, but the fundus photo speaks for itself. You have a vein occlusion inferiorly. So you have edema only on one side while the other side is absolutely fine. Compare this with a CRVO where you have hemorrhages all over the retina and you have edema diffusely in the retina and inner retinal hyperreflectivity. So this is something which you can tell just based on the OCT how much of the retina is involved in the occlusion. Diabetic retinopathy presents with multiple markers today. There are lots of changes in OCTs which are used as markers and treatment guidelines. You have multiple cystoid spaces with hyperreflective dots, with cystoid edema, spongy edema, and neurosensory detachment. So you have a lot of OCT variations within the diabetic macular edema spectrum, predominantly occurring in the inner retina. Look at this patient, 1 week vision loss, came to us saying suddenly she lost vision. It was a known hypertensive. You can quite clearly see he had a CRAO with a lot of ischemia happening. Look at the OCT, very typical. The entire inner retina has become white, suggesting the blood supply from the central retinal artery is cut off, leading to ischemia. You see some shadowing here because of the dual circulation, but the entire area is completely hyper-reflective. Very typical of a CRAO. This was a young male who came to us. He had a history of fever 1 month back and he presented like this to us. A lot of these cotton wool spot-like lesions and macular edema was the presentation with some disc edema. So when we looked at the OCTs, again inner retinal hyperreflectivity, you could have confused it easily for a CRVO or a CRAO with some edema. But then the history was very typical here. So OCT alone is not going to help you. You need to also have a history background here. This was a post-fever retinitis. And when you look at the scan through the retinitis lesion, you can see how white it is. So you can easily confuse it for an occlusion. So everything which is white in the inner retina is not an occlusion. You need to sort of attach it with the clinical history associated with it. Moving on to the outer retina, this is something which we see very commonly, sort of a central reflex, and the patient says they're seeing a black spot. Normally young males, and you see this is a typical case of CSR with a bit of a thickened choroid here, though the choroid is not very clearly visualized. This is an enhanced depth imaging, but we're not able to see the choroid properly. This was another patient who 1 week post-op had 2 meters vision after an uneventful cataract surgery. So when you look here also you have a large neurosensory detachment with a small PED-like lesion and a shallow PED. But to our surprise, when we saw the OCT, there was a huge PED sitting below and the tissue below it was pretty dark. So we were a little bit confused because this area sort of looked like a CSR leak, but we sort of did not understand this, and there's also a small double layer sign here corresponding to the PED. So we called him for an OCT now. So this was again a very tricky case which post-operatively in a general ophthalmologist clinic can confuse you. So an OCT is really helpful in this situation. This was an elderly male who had received multiple injections for his left eye and had a typical CNVM. This is a PED with multilayering and subretinal fluid. He had an injection in Jan and had a dry retina then, and now clearly OCT is helping us understand that he needs to be re-injected. There's a clear sign of activity on OCT. Another interesting case, pretty common in the uveitis clinics, disc edema with multiple neurosensory detachments and a detachment at the fovea. Patient was diagnosed with VKH. Unfortunately, we could not get the OCT at baseline, but on follow-up, we found that the fluid had nicely come down with oral steroids. Still, the choroid had some bumpy appearance. The RP had some bumpy appearance, and we are not able to visualize the choroid properly here. But in a swept source, you would see granulomas sitting in the choroid, which are suggestive of choroidal inflammation. This is the other eye of the same patient. This is the last case I want to show, a young female who had redness and vision drop in one eye. The other eye had a few subvascular pigments. This eye had some active lesions in the periphery and some disc edema. This was her autofluorescence showing the active area here. We investigated her thoroughly. We did a MAN2, we did a PCR for the vitreous, and we did a IGRA, all came out to be negative. She started off on oral steroids, but the OCT was quite typical. All the areas where there are active lesions, you see there's outer retinal burnout, and the choroid was quite thickened with large, granuloma-like lesions sitting there. But they're not like typical granulomas, but the choroidal hyperreflectivity had gone up quite significantly. So this is another interesting case where the OCT sort of told us what to expect visually because of all the outer retinal loss which happened. So to take home, it's a very non-invasive and a repeatable imaging which you can do on every visit. It's a very useful tool for structure function correlation. You're not able to understand why the vision is not matching up. OCT invariably helps you, and it's of high utility for the general ophthalmologist in various situations like a poor post-operative visual outcome. Thank you very much for patiently listening.
Thank you, sir, for that very informative talk. So we'll head back to the OR to join Apurva ma'am once again.
So I'm going to show this membrane dissection now, which is superotemporal, and then you can take another talk. So this is something I started now that my blood has all gone. So this is how it comes very nicely. I hold with forceps in one hand and I am cutting with my other. So this is typical of a bimanual surgery. Yeah, clean.
Very
So again I've started getting some oozers here.
Was there any underlying break, Apurva, there?
No, no.
No. Okay. You are blessed to have a very good assistant. She is reading your mind actually.
Yes, absolutely.
There are some bubbles in the periphery. If,
Yeah, I'll just clear that.
Just
I'll
clear
clear
that.
1 second. Plug forceps.
That's behind the IOL.
Yeah, yeah. Good. So even small bubbles tend to be quite problematic and they have to be cleared. It's usually also because there's some vitreous there to which the bubbles, air bubbles come and stick. So very carefully we need to deal with them. So I'm just going to do a cursory check and I'm going to go back in again. Hold. Yeah. So let's see. Yes. So again there is some bleeding.
Yeah.
So I'm going to clear that. You can meet me at the other side of a talk maybe. I'll finish.
Yeah,
And
can
since
go
I
ahead
showed
with
one
the
step of
next talk.
bimanual.
So we'll go over to our keynote speaker, Dr. Manisha Agarwal, for her talk on posterior segment complications of anterior segment surgeries. And then we will come back to you, Dr. Apurva ma'am.
So I request Dr. Manisha Agarwal to please come up on the dais. So Dr. Manisha Agarwal is the head of Vitreoretinal and the clinical services at the Shroff Charity Eye Hospital, New Delhi. She finished her fellowship from Shankar Nethralaya, Chennai. She has 100 peer-reviewed publication and 7 book chapters. She is also the secretary of Uveitis Society of India and Vitreoretinal Society of India. She has won many awards, to name a few. The Prevention of the Blindness Endowment Award, Best Lady Fellow in Vitreoretinal Award at Shankar Nethralaya, the Spirit of Humanity Award for Diabetes by American Awards, Mumbai in 2011, Best DOS Monthly Clinical Talk of the Year, Award for HR Development by Mongolian Ophthalmic Society in 2019, and the runner-up award for the Best VR Surgical Video in the AIOS 2020. So I think it was a long way for her. She started her journey at 3 a.m. in the morning to come from Delhi, and we welcome you, madam, for this event gathering.
A very good afternoon to all of you, and at the outset I would like to thank M.M. Joshi Eye Institute, Dr. Guru Prasad sir and Srinivas for their kind invite. It's been a long-term dream of mine to visit Hubli, and finally I've been able to make it to Hubli finally and to this wonderful meeting. We've been seeing some very wonderful surgeries since the morning, and I have come midway in between Apurva's excellent ongoing diabetic vitrectomy. So in the coming few minutes, I think we have a number of anterior segment surgeons already sitting here, and we've had a whole session on phaco surgeries in the morning. I would be briefly touching upon the posterior segment complications of anterior segment surgery, and I think none of us can skip this. So any anterior segment surgery has the potential risk of having a posterior segment complication, and though we know that the techniques have really evolved in the last few years, but still they are high volume surgery, especially cataract surgery, and if you are a surgeon, you are bound to land up into complications. We would realize that the posterior segment complications can happen at any stage. Even before you have started the surgery, you can land up with a globe perforation during the peribulbar block. You can have intra-op complications in the form of vitreous loss, nucleus or IOL drop. I was looking forward to Guru Prasad sir's talk on first aid management of IOL drop, and also an expulsive hemorrhage during the surgery. Post-operatively, of course, you can land up with cystoid macular edema, retinal detachment, and last but not the least, the most dreaded complication of any anterior segment surgery being endophthalmitis. But I think the most important take-home message from my talk would be that you have to really assess the situation and decide for any further intervention, and we don't have to really panic and stay calm and take a wise decision. Because sometimes out of our panic and to handle, because you have promised your patient that you are going to put in an IOL, you want to meet up that expectation, and you land up, creating more mess. So leave that space for your VR surgeon to, handle and clear up the situation better. And believe me, the visual outcomes can really be surprising if they are handled well. So let me go through can I have the sound, please? So this is a 65-year-old male patient with a history of cataract surgery and multifocal IOL in the left eye 4 days back. The vision that he presented was as low as counting finger, close to phase with vitreous hemorrhage. The patient on B scan had RD. I think the sound is still not there. Had retinal detachment with choroidal detachment, and the possibility was that probably the patient had landed up with a globe perforation during the block. During peribulbar block could not be ruled out. The retina was detached with early PVR changes. PVD was induced, which was found to be tightly adherent. Pre-retinal hemorrhage was also removed along with the vitreous. So this is probably the site where the block had created a globe perforation. Perfluorocarbon liquid was then injected over the posterior pole and membranes were peeled to open up the peripheral retina. This was followed by more injection of the perfluorocarbon liquid to flatten the retina. Fluid air exchange was done and more membranes were removed from the retinal surface. However, a huge choroidal mound was seen on the temporal side involving the macular area. Dithermine was then used to make a full thickness drainage retinotomy through the choroid. A passive suction was then used with the help of a flute needle. Gradually, the choroidal mound was found to subside down. Laser barrage was subsequently done to the drainage retinotomy, followed by silicone oil injection. Post-operative follow-up on day 1, the retina was found to be well attached, and follow-up at 3 months, the vision had improved to 636 N18 with a stable retina. So this is a one-eyed patient and he presented with aphakic bullous keratopathy, and the corneal button was removed. Since he was one-eyed, we had to make a desperate attempt, and a temporary keratoprosthesis was placed. View through the keratoprosthesis showed a closed funnel retinal detachment with extensive PVR changes. A small bubble of perfluorocarbon liquid was injected to open the funnel, however it failed to do so. Membranes were peeled to open the funnel. A small foreign body was found floating in the vitreous cavity, which was delivered out. And more membrane peeling was done. Subretinal gliotic bands were removed, followed by laser photocoagulation, and perfluorocarbon liquid silicone oil exchange was done. Finally, the corneal transplant was completed. At 6 months follow-up, there was a well-attached retina with a vision of 636 N36, and this made the patient ambulatory. So this is another one-eyed patient who apparently had an expulsive hemorrhage. Patient had undergone a multiple penetrating keratoplasties, and this was the 5th one during which he landed up with an expulsive hemorrhage. On the B scan you saw there were massive kissing choroidals, as we call them. So here an external drainage of the suprachoroidal blood was done, and this was then followed by the VR surgery where you had a retinal detachment along with PVR changes. Again the membranes were peeled. PFCL was injected to stabilize the posterior retina, and finally this was followed by a fluid air exchange and silicone oil. This is another patient who presented with IOL drop along with the entire bag, and you see this dangling in the vitreous cavity. So this was just caught up with the forceps, and now with a handshake technique it was held with the left hand, and opening was made at the limbus, and this entire complex of the IOL with the bag was delivered out. And in the same sitting, we went ahead and did a glue IOL for the patient. This is another patient who presented with IOL drop with a total rhabdomatogenous retinal detachment. You again find the IOL which has gone back. And probably the surgeon tried doing a little bit of fishing of the IOL, which apparently led to some element of vitreous traction and causing a retinal detachment. So here it's important that before we try to really pull out the IOL, we release all the vitreous attachments to the IOL, make it a free-floating IOL. And then subsequently, after we have injected some amount of PFCL to protect the posterior pole, we go ahead and pull out this dropped IOL. And then the routine steps of settling down the retina. So this was a patient who just presented to me last month. A PCIOL had been placed in the anterior chamber. The patient had also, had a full thickness macular hole, and you see there are multiple breaks at the posterior pole. So some amount of fishing had been done after the nucleus had dropped back, and you see there's quite a hard half piece of the nucleus which is lying at the posterior pole. Apparently, when this patient was referred to me, I was just told that it's just a nucleus drop. But when we cleared up the media haze by clearing up all the vitreous with shreds of cortex and nucleus, we realized there was multiple breaks at the posterior pole. So this again tells us that it's best that we avoid any kind of fishing. If it's gone back, let the VR surgeon take over. So after we delivered the nucleus, we went ahead and did an ILM peeling to close the macular hole. And finally, we did a laser barrage to the multiple retinal breaks which were present at the macular area. And this is my last complication, which is the most dreaded complication, is post-op endophthalmitis. And I think it's always a good idea to err on the side of endophthalmitis whenever we see an undue reaction after any anterior segment surgery, rather than, erring that it's just an inflammation. You find that there's a thick membrane which is there over the IOL. And this is actually a good specimen to be sent for culture. We went ahead and we did a core vitrectomy along with intravitreal antibiotic injection, and if you intervene early in these cases, you find that the visual recovery can be really good. So I just end my talk by saying that complications may happen in any anterior segment surgery. Timely diagnosis and management is of utmost importance. Holding your hands back with a timely intervention by a VR surgeon can actually really have a great impact on the final visual outcome, and it can avoid medico-legal complications for the surgeon. And at the end, I would just take the opportunity of inviting all of you to our forthcoming annual VRSI conference from 2nd to 4th of December this year at Nagpur.
We have a great scientific program lined up for all of you and with some safari to see a tiger. So I just welcome you all for this annual conference. And thank you once again for the opportunity.
Thank you, ma'am, for that talk. So now we'll go over to the last talk of this, second last talk of this session by Dr. Pooja Sinha on managing ischemic CRVOs.
Put up the slide. Thank you, Manisha madam. Those wonderful videos. I think we'll have a little discussion later on. But one thing, if you have any such complications, first I think you can refer it to Joshi, and then second to Delhi. Second to Dr. Shroff Charity Hospital. Wonderful videos, madam. Thank you very much. And next we have another speaker from Patna, Dr. Pooja Sinha, who is the head of Vitreoretinal Services at ABI Institute, Patna. She is also the ex-VR fellow from Shankar Nethralaya, Chennai. And she has finished her training at Stanford Eye Hospital in USA and Oxford and Hull Eye and Ear Infirmary, UK. Recipient of Dr. D.K. Bose Gold Medal and IRSI Gold Medal as well. So thank you, Dr. Pooja Sinha madam, for coming all the way from Patna, and I would like you to continue with your talk. Thank you.
Thank you, Dr. Srinivas. It's always a very nostalgic feeling to come to Karnataka because this is where I did my MBBS from KMC Mangalore and then subsequently my post-graduation from Manipal. And I'm so thankful and grateful to Dr. Srinivas and all the organizers of Joshi Eye Institute for this warm hospitality and warm invite. So this evening I'll be speaking on managing ischemic CRVO, taming the untamed. All the medical retina associates and colleagues who are sitting in this hall will agree with me that ischemic CRVO is sometimes a very difficult and complicated disease entity to treat, especially when it becomes chronic. So macular edema is a frequent cause of decreased visual acuity in patients with CRVO, and the factors in the development of macular edema are increased venous pressure, elevated levels of VEGF with subsequent breakdown of the blood-retinal barrier, upregulation of the other inflammatory mediators, interleukins and interferons, and dysregulation of the endothelial tight junctions. So coming on to steroids as monotherapy, steroids decrease the expression of VEGF and several inflammatory mediators and are therefore indirectly reduce VEGF levels in the vitreous cavity. They offer an anti-inflammatory role, reducing the vascular permeability, inhibiting leukocyte movements, stabilizing endothelial tight junctions, inhibiting prostaglandins and other cytokines. So 3 major steroids are currently being used in the treatment of CRVO, they being triamcinolone, dexamethasone and fluocinolone. So just a slide on SCORE study, what was it? It was a randomized controlled trial which compared 1 milligram and 4 milligram doses of preservative-free triamcinolone versus observation for visual loss seen in macular edema and CRVO. And the results were that both 1 milligram and 4 milligram yielded better visual outcomes over 12 months than observation. However, the 4 milligram group had a higher rate of cataract formation and the IOP elevation. So the DEX implant is a potent water-soluble corticosteroid delivered in the vitreous cavity. There was a 6-month study which evaluated the efficacy of 0.35 milligrams and 0.7 milligrams compared with sham. And the authors concluded that DEX implant reduces the risk of further visual loss in CRVO and increased chance of improvement in visual acuity. And it is well tolerated, and increase in IOP is less than 16% of the eyes. So this is the Orthodex implant as we all have seen, and this is on the left hand side is the plunger through which the pellet is released into the vitreous cavity. The other modalities of treatment of CRVO and in fact the first line modalities are anti-VEGF agents. The mechanism of macular edema is upregulation of VEGF, as we all know, in response to retinal ischemia. So the bevacizumab is the recombinized humanized monoclonal antibody by the name of Avastin, and the study by Epstein et al. Showed that injection of Avastin every 6 weeks for 12 months increases the visual acuity and reduces macular edema compared to sham. This is the Avastin injection that we most commonly use. The ranibizumab, which is more commonly being used nowadays, is humanized VEGF antibody fragment. To support that was the CRUISE and the Horizon study. Then the aflibercept is also a very popular anti-VEGF agent, which is a fusion protein, and it had to its agreement the Copernicus and the Galileo studies, where patient gained 15 or more letters from baseline at week 24 compared with placebo. So in our study, we had 4 patients with recalcitrant CME secondary to CRVO between February 2019 to February 2022. The inclusion criteria being that all the patients were previously treated with at least 2 injections of anti-VEGF. They all were pseudophakics. There was no previous history of glaucoma. The average central macular thickness was greater than 250 microns. Average BCVA was less than 6/36 in the affected eye. And after anti-VEGF agents, the treatment was then switched to 0.7 milligrams of the DEX implant because of non-responsive or persistent CME. And because this was also overlapping the COVID era, we made sure that there was no history of previous COVID-19 infection. The mean interval between anti-VEGF injection before the initiation of intravitreal steroid was 1.5 months. And the mean interval between the injection increased to more than 4 months after initiation of steroids. So that was one plus point. We also investigated the BCVA and the CME on OCT. Scatter laser had to be done in 2 out of 4 cases for peripheral retinal non-perfusion and recurring CME, as we did FFA in the later stages once the hemorrhage had cleared. And re-injection of steroid implant at the end of 4 months had to be done in 1 patient. So the results were that the mean anatomic outcome was significantly improved after initiation of steroids, along with slight improvement of the mean functional visual outcome in chronic cases, because these are all chronic cases which had not responded to anti-VEGF agents. Findings may be secondary to chronic CME, ischemia, and irreversible damage to the photoreceptors. There were luckily no steroid-related intraocular complications like secondary glaucoma. So this was my first case, a 64-year homemaker, hypertensive for 5 years with increased cholesterol. And you can see this blood and thunder appearance of the retina with multiple hemorrhages. This was the corresponding OCT. And you can see this marked intraretinal edema and macular fluid, which caused the loss of vision. She had received 2 injections of anti-VEGF, and she was not willing to take more monthly injections, so that is why we opted for the DEX implant. This was the other eye, the right eye. And so you can see that she did very well with Ozurdex implant, and after 2 months and after 3 months, you can see that how nicely the foveal contour was regained. And this was the clinical picture after 3 months. This is the comparison. The case 2 was a 55-year-old professor. Vision on presentation was poor. It was counting finger 3 meters in the right eye. You see all these hemorrhages. And the edema was massive, almost, going out of the picture. It was a massive intraretinal, subretinal edema. And after 1 month of Ozurdex injection, you see that the edema has started coming down. And this was after 2 months. This was a recent case, so I'm sure the patient will do better. This was my previous case when I had the previous OptoView machine before I acquired the Triton. And this was a 70-year-old retired general from the armed forces, hypertensive, vision very poor, counting finger 3 meters, and you see this corresponding OCT. And then the vision improved to 6/36 after 2 months. And this was the last case. I just correlated, I just included it to show that every time it's not a rosy picture. This was a 58-year-old social activist, hypertensive, with ischemic heart disease, vision very poor, counting finger 2 meters, had not done well with anti-VEGF injections. You see this lumpy, bumpy appearance of the retina. After 2 months of Ozurdex injection, vision improved to 6/60. The OCT picture looked favorable. This was at the end of 3 months. But at the end of 4 months, again, there was a massive bleed with the vision again dropping to counting finger close to face. And these are the kind of patients which we know we have lost the patients, because no matter what you do, the vision doesn't regain. So this was after the second Ozurdex injection. The OCT was in a respectable shape, but the vision was still very poor. So just to summarize in my last slide, as monotherapy, steroids alone have not proven to be superior to anti-VEGFs. So this is what I want you to take home. But with a higher incidence of side effects, especially after repeated dosing, anti-VEGF still remain the first line of treatment for medical CRVO. However, role of steroids as an alternative therapy in resistant cases alone or in combination with the anti-VEGFs is a viable option. Thank you so much for your patient hearing.
Thank you so much, ma'am. That was a lovely talk.
Thank you.
So before we go into the discussion, we're just going to join Apurva ma'am in the OR.
Sure, thank you.
And
Please.
over to you, ma'am.
Ma'am, your mic on, ma'am.
Please wipe. So, can you all hear me?
Yes, ma'am.
Okay, so I'm doing laser now. If you notice, this is a retinal fold, and varisthira ಸ್ವಲ್ಪ. If you see, there are no membranes anymore. 1 second. Okay. Centration, please. इसको So, can you all see the, can you focus please? Yeah, the filter off. Okay. So, this is a fold. This is a fold that you can see here, and I have dissected the membrane here. These are dithermy spots. In case you are wondering what the whitish thing is, it's not a membrane. So I'm going to go ahead and use an Intra-op OCT now to see if it is a membrane or not. Use focus. Yeah. Not happening. Change that also, no? Second. Think he's not able to achieve a scan. Okay, good. Cutter. Remove the biome. Cornea scrape. I'm scraping the cornea now because it has got a lot of epithelial edema. Once I scrape it off, it's going to really help in my visualization. You will see the difference. Yes. Visco. Yeah. Wait, Rajri, wait. Okay, there. Self kelag. Slow. Yeah, somewhere there. And the left one, left glider. Yeah. No? You are getting something there, no?
Forget the OCT. The OCT is not working. Last 3-4 days I've been seeing. It's
Okay,
not,
switch it off.
Yeah.
OCT off. Yeah. So, Any comments on this part here? Varustira?
Probably I think you have dissected almost all the membranes. That's a chronic fold which is there.
That is a chronic fold, I agree.
Since I think the
So
macular
if you-
tractions has been released.
So if you see here also, maybe this is a membrane. Okay.
Yeah.
So itori bimanual. Good. Show me. Yes. No, I think this is thinned out retina only. I'll just see again. It's very tricky here because there is no discernible plane between both of them. Okay.
That's an excellent dissection, Apurva.
Thank you, sir.
I think Apurva is the youngest surgeon to operate on angioplasty. The two live surgery on angioplasty. I think
I had a break just as you were praising me.
touch wood.
Just a second, let me see what is going on.
It's very thin underlying retina. It's very difficult, tricky.
Yes. So, yeah, I'll just use my cutter at this point. Light pipe. Okay, I have a big bleed there, so I'm going to probably cauterize it.
I think Apurva, as you have removed almost the membranes.
Yeah.
That's an excellent surgery. It's a feast to watch your surgery. It's a difficult case which you have chosen. Actually, it is a live surgery. It's very difficult to manage. You managed it very well. Apurva.
Yes, sir.
Meanwhile, we will continue with the talk.
Sure,
if we like at the end of the surgery, you can just come back and you can show us.
Please go ahead.
Yeah.
Please go ahead.
So we'll have our next talk by
Extrusion.
none other than our very own Dr. Guru Prasad sir. He'll be giving a talk on IOL drop first aid. Over to you, sir.
We can have some lights in the auditorium. I don't know whether everyone is awake or is slept.
Can we have the lights, please?
Yeah. You have full lights.
All lights.
Very like.
I think about Dr. Guru Prasad's this talk, first aid. I think it's the most pertinent talk of the day, because for all we anterior segment surgeons, we can probably reduce the woes of the posterior segment surgeons by doing the first aid properly.
Great, no? Yeah.
So, thank you very much, KP, for that comment. Dr. Manisha has already given us a comprehensive talk on all the complications of posterior segment surgery. Anti-segment complications of posterior segment complications of anti-segment surgery. KP has a joke about this. He says there are also anti-segment complications of posterior segment surgery, and he is overloaded with them because of our department being very active. So, nucleus drop is a panic situation definitely. Like PC rent is one, this is another in in ophthalmology, and I'm sure you heard these several other complications which Dr. Manisha Agarwal just alluded to. So first of all, it is out of jurisdiction of the anti-segment surgeon. It is a situation where a second surgery is required from another specialist. Additional expenses involved on the part of either the doctor or the patient, depending on who is going to pay for it. There is a delayed visual recovery. Normally the patient recovers vision a few hours after cataract surgery, but in this particular situation, patient has to wait for visual recovery. There is a possible chance of irreversible complication happening in the form of either retinal detachment or endophthalmitis or a chronic CME, and of course it all amounts to failure to deliver the promised result. So what I want to present today is the purpose of this presentation is what can be done to optimize results and get 6x6, mind you. It is possible to get 6x6 vision if properly managed, and what you should do to get this is what I'm going to tell you about in the next 3 to 4 minutes only. What should be done to help the VR surgeon to pass on the baton smoothly. Basically it's passing on the baton. So how to pass it on smoothly is what I'm going to talk about. So firstly, you should know what not to do. Of course, Dr. Manish has already told about what you should not panic. You should not manipulate excessively. You saw those retinal breaks, those big chunks of, multiple chunks of nuclear material sitting on the retina, and the big breaks that had been caused by them. Don't chase the nucleus beyond the retropupillary plane, and this is what I mean by retropupillary plane. If you are chasing the nucleus beyond the retropupillary plane, you are likely to cause a tear in the vitreous base area by causing an undue traction. And so what to do? What not to do is just heard. What is to be done? You should stop. Stop, take a deep breath. Think about your VR friend. Withdraw the handpiece slowly. Assess the size of the lost nucleus. See, sometimes it is not possible to assess also, because the pupil would have come down, the cornea would have become hazy because of several factors, because of delay in prolonged surgery and all that. So at least you should be honest to assess and convey to the VR surgeon as to how much nucleus was lost. Sometimes it is difficult for the VR surgeon to actually assess. It's not very important, because anyway he has to go in and remove the nucleus, but you should convey whatever was the finding on table. The size of the PCR is very important, the location of the PCR is very important for you to manage initially. I'm going to show you how to manage also. And also the amount of residual cortex that is present. Try to dilate the pupil, check the site of the PC rent, check this amount of residual cortex that is left behind. And of course you have to call the VR surgeon. If there is a backup in your own institute, you have to immediately inform the vitreoretinal surgeon. So what to do if the nucleus is just behind the pupil? If it is just behind the pupil, use liberally dispersive viscoelastic. Vectis retrieval is possible only and only if the nucleus is still just behind the pupil. Don't use the vectis if it is deep down. Infusion or viscoelastic injection through the pars plana is something that is rather uncontrolled and can be used, provided again it is just in the retropupillary area, and follow the basic guidelines of anterior vitrectomy. Anterior vitrectomy is a separate topic by itself, which I have given in several fora, but here I will not touch upon that. Limited vitrectomy is what I would like to put it in a nutshell, and suturing is very important. So the 3 S's: stop, suture and send. This is what I want to tell all the comprehensive ophthalmologists here and the postgraduates and fellows, that don't dabble too much. Stop, suture and send. Same day if possible, but there is no need to rush. You can send the patient as soon as corneal clarity permits good visualization for the vitreoretinal surgeon, and an optimum gap is about 10 days. I'll tell you why it is 10 days. In the meantime, if it is 10 days, then what you have to do is to examine the patient, or at least teach the patient the signs of inflammation and IOP, and suppress them with adequate anti-inflammatory drops or tablets and anti-glaucoma tablets or drops. There's no need to rush or panic, as I said again. Counseling is the key. So you have to reassure the patient that nothing has gone, nothing much has gone wrong, nothing serious has gone wrong. It is possible to manage and get back vision, but it's a matter of time. So should an IOL be implanted is another question which many anti-segment surgeons ask me. I said, look at this video, you will understand why an IOL should not be implanted. Many times the IOL also gets dislocated and you have a double dislocation. You have a dislocated nucleus and you have a dislocated IOL as well. Another reason why is you cannot visualize the plane of implantation. The IOL can get dislocated as you just saw. But yes, if the capsular support is good, if you are able to see through the clear cornea, if you are able to see the capsule, if the PC rent is very small and central, then probably you can implant an IOL. That is by experienced hands only. And the choice of IOL is also very important. A 3-piece large diameter, 13 millimeter lens is important to be implanted because that is the one which gets into the sulcus snugly. With time, the capsule becomes better defined and stiffer in 10 days. In those 10 days which I was alluding to, the capsule becomes stiffer and whiter, more opaque and more visible for you to implant later more safely and with more confidence. So this is what I mean. The capsule becoming white, opaque, fine-nosed also to some extent, giving you more area for support for the IOL. And these are some examples of how beautifully the lenses can be implanted after successful management of drop nucleus. Post-operative follow-up is very important. I think you should remember one thing. You should see the patient the same evening, the next day. These are all patients who can go in for endophthalmitis, and therefore it's very important to catch endophthalmitis at the earliest. And what we follow is an exercise called SAVE, which we teach the patient. So loss of vision is something that we sensitize the patient to, meaning if there's any drop in vision, the patient has to report immediately, and we hand out a chart and ask the patient to close the good eye and see the chart through the other eye, through the operated eye. So teaching the patients this art of SAVE is very, very important for them to realize, for them to understand and report to you a complication such as endophthalmitis. So the bottom line is, if the nucleus has dropped with proper management, it is possible to get 6x6 vision. That is, if you don't try too hard or if you don't go fishing, or just leave it to your VR friend to manage. Thank you very much.
Thank you very much, sir, for that very vital talk. Now
I just have a question to Dr. Guru Prasad, sir. Sir, what is your modus operandi? Let's say I send the patient same evening. Like cornea is clear, there's a drop, not much of you have done a vitrectomy and you have sutured it and sent it to you. What we should tell the patient to expect? Like what will be your plan to manage the dropped nucleus?
My plan?
Yes.
Right. So what you should be telling the patient is, you can be very positive. One thing is, you can tell the patient that it's not, nothing is lost. Okay. Nothing is lost because there has been a complication. That is provided you have not gone fishing, you have not meddled too much with in the anterior chamber, you have not done an AC wash, you have not tried to remove the cortex, you have not rubbed the iris. All these things can cause unexpected or expected post-operative inflammation, and that in turn can result in a delay in the VR surgeon taking over, because until the cornea gets clear, until the iris gets less, the inflammation comes down, it is impossible for the vitreoretinal surgeon to have a good visualization for his vitreoretinal surgery. So it's very important that you don't dabble too much, or don't fish, or don't go hunting for the nucleus. So that unless it is just behind the pupil, don't just do anything, just allow it to sink. Allow it to sink is my bottom line. So that is the point. And yes, how we manage? Well, we have to search in the vitreous cavity for every small particle, not just the nucleus, the drop nucleus, but every small particle which is adherent to the vitreous base inferiorly. We indent the vitreous base, look for those small particles inferiorly, and get out all the vitreous, all the cortex, all the nuclear fragments that are stuck there, and do a thorough peripheral examination to get a good view of retina and to rule out any retinal break that would have inadvertently happened during our surgery. And then dilate the pupil, even if it amounts to putting iris hooks, dilate the pupil, get a good view of the capsule that is available. Usually it would have phimosed by 8 to 10 days. That's the best part of waiting. Waiting for 10 days is very, very helpful. So one thing is waiting helps in opacification of the capsule. Secondly, it helps in better visualization. And third, it phimoses. So because of these three things that are happening to the capsule, it is possible to implant the lens in a more controlled fashion, in a more controlled environment. And that is how we are able to place the lens accurately.
I think I'll ask this question to Dr. Srinivas. He's already in the podium. Srinivas, this is about, he had first slide where he said that second surgery is going to cost also. There's some extra expenses. So how do we manage this part for anterior segment surgeons? Like who will pay the vitrectomy charges?
So, of course, we have some good relation with the anterior segment surgeries. That's how we try to manage it, and most of our friends here will believe it. We usually don't charge their surgeries, but the only trick is you have to keep referring to us. just joking. So usually what they do is, what surgical cost is being taken for the cataract, I think that some surgeons pass it on to the vitreoretinal surgeons. But to look at the economics of the situation, minimum it costs around 30 to 35,000, even if you have to do, because now with the constellation and the packs itself has become 23 to 24,000. And if it's an end of case, we just have to throw out. We cannot use that case at all. And along with that, you have a lot of other, so minimum cost comes, cut to cut is around 30,000. So at least that much, they need to have a good memorandum of understanding between the retinal surgeon and the cataract surgeon. That will probably help us go a long way. And I have seen some surgeons, they say that if they are affordable, then you can convince, you can counsel the patient that, as your famous dialogue goes, it's not an infection, it's an inflammation. So some kind of counseling tricks, if you use the proper words of not using the word actual infection, then I think those kinds of patients will agree, and then we'll do that. I think in the evening we can discuss.
I think I have a suggestion.
Our Justice Mr. Krishna Dikshit, he just sent me a message in the WhatsApp day before yesterday that doctor's negligence, it cannot be called as a doctor's negligence. I'll share you all that we are in the group. A very nice judgment had come where even in the negligence also, you are not supposed to be sued under the court. So that is what the new judgments are coming out in the favor of doctors, and probably that
I think there's a simple practical solution. I think let's say what is your drop rate? Let's say 1 drop in 100 cases. So let's say we pay 50,000 to Dr. Srinivas for a vitrectomy for a drop nucleus. So you can divide that cost. It's like an insurance company. So you pay a premium. Like if you have morbidity, comorbidities, your premium goes up. Similarly, like if you consider that, you say 500 rupees you charge extra for a normal cataract. In 100 cases, it will become 50,000. I think you can probably have that so that you are paying that 50,000 from your pocket to Srinivas. Still, no patient thinks that he has been charged twice.
But I have done most of it free, sir. I think we can ask a few of our surgeons 1 or 2 minutes. Dr. Shravan Pandit and Dr. Vijay Sajjanar, what do you expect, sir, for a vitreoretinal surgeon? Should we charge or should we not charge? In general point of view, I am asking. What's the single practitioner's mentality? What is it?
I want to share on this, and I want to share my what I learned from Dr. Krishna Prasad a few years back. Nobody can say that I'll never have a complication no matter how senior or how experienced you are. But I remember one of his words from many years back: if you have a complication, stop the other surgeries that you are going to do, call the patient party in the pre-operative area, and tell them then and there of the complication that has happened. Once the patient goes to the ward and you have finished all your day's work, and in the evening you go and try to explain that this happened, that happened, or during the next follow-up day, that doesn't work. On the first day, as Dr. Krishna Prasad saying, in that very moment, the patient is ready to hear the bad news. If you have called them to the OT, they know something bad has happened because other attendants are not going. And in these 7-8 years, once I had a complication and I called the patient and they understood. And I said you will have to go to a VR surgeon and you will have to get this surgery done and it will cost. And at that point of time, they are so receptive, they listen to everything and they agree to everything that you say. So the point that he is trying to bring up of how much should be charged is if you tell them over there and then the patient goes to the VR surgeon and he is told that it will cost 30,000, 40,000, he is ready to pay. And what Dr. Guru Prasad said is once it falls, don't touch it. Complication can happen anywhere. But once we start messing it up, once we start trying to hide from the patient, that is where the whole problem starts. Thank you.
Just one last comment I would like to make, that our institute has always been friendly to our fellow ophthalmologists. So far in my 40 years.
And my 10 years, sir.
My 40 years. We have always been kind and not a single case has been charged if it has been referred by a fellow ophthalmologist with a complication.
But including endophthalmitis, sir.
Including, of course, not just drop nucleus, all posterior segment complications of anti-segment surgery. But one request I have to all of you is that when you expect a drop pre-operatively, please counsel the patient so that patient will be receptive, patient will pay you, maybe pay us also. So this is one thing, because many of the cases of drop nucleus which have been sent to us are actually cases of posterior polar cataract which have dropped during surgery. Any mature cataract, you should always probably tell the patient that this is a possibility that the nucleus drop can happen. So if you can assess the cataract and tell the patient beforehand that this is a possibility and maybe charge a little more, or tell the patient that second surgery may be required, I think the patient will be very happy. That makes us happy as well.
Yes, sir. Quickly. Yeah, the mic is on, sir. There. Can you switch on the mic, please, Gilbert?
Hello. Sir, I think the best thing that any surgeon can do is be very honest. Immediately call the patient's closest relatives, explain to them what has happened, tell them that you are with them, refer them to the best center, most probably Joshi. And I feel from your side, as soon as the patient is received, you should first assess the patient's financial condition. If the patient is well off, you can explain to them how much you charge, how much it would cost. And then at last, come to a final conclusion of how much you should charge, and don't send the patient without surgery. Because you should remember that you are helping like an elder brother or big brother to all of us, whoever who refer to you. That way, your name also will come up, and we will always be thankful to whoever who have saved us at the time of problems. Thank you.
Thank you, sir. Very novel thought. Thank you. So I think the discussion can go on after we finish our talks. I think we can have, because it's a very debatable topic. And yes, it's a very prominent question which Dr. KP has brought out. We would love to know from what the ophthalmologists also feel, because usually they are under obligation. So definitely we would love to listen from you as well. So I'm getting a warning from organizing chairman, Dr. KVS sir. So we all know that when they did the ASRS preference and the trends, that's called as a PAT survey, insufficient fluid resolution was the cause for repeated anti-VEGF injections. And coming to the new design, I would like to thank Novartis for this, and this is the brolucizumab molecular design. As you see, this is the full length antibody, as you see the Avastin. So here you have a variable length and the light chain, that is VL, and the variable length heavy chain, VH, right? So only this and this part is taken to make the brolucizumab molecule. So here you get also the additional of the CDRs, what they call it. It is extracted from the mice, and this CDRs is nothing like a sticking agent that they try to put it in the novel CDRs of the anti-VEGF. This is the proprietary human SCFP scaffold, what they call, is the VL and the VH, that is the VL light chain and the heavy chain, and this CDRs is being made to put on this, and that's how this becomes a very low molecular weight anti-VEGF. So that's why the another thing is here is, you can see the difference between this. The least molecule of the aflibercept, that is Eylea, ranibizumab, bevacizumab or brolucizumab, this becomes the least molecular, and because of that they also have the higher injection molecules, that's around 11 molecules per injection. So probably that could be the answer for higher potency and also the longer acting, because it has a better depth penetration because of being a low molecular weight anti-VEGF agent. So that's how it makes the brolizumab a little special. So few of the case I just wanted to run here. You can see here, these are the case with it look like a chronic edema here. You can see this is the case of CNVM. You can see the pipette here, and with one shot you can see there is complete resolution. Here you can see there was a very large PED. It looked like there was no PED at all. And here also you can see in another section there is a complete flattening of the PED. So that's the wow effect we get with these injections, especially the brolizumab. So here also you can see the SHREM, that we call it as a subretinal hyperreflective membrane, which it's again completely flat. Here you can see the pipette here, that's also completely gone. You can see in all the three sections there is complete resolution of the fluid. And this was again a case where it was buckled before, and the patient had CNVM. Now you can see the multi-layer pigment epithelial detachment, what we call it as a MULPED, with a type 1 CNV. With the injection of the Paginax or the brolizumab, I think we had a very good response. So here, why I am presenting this is most of these cases, IRF spaces over the scar. They are usually either the degenerative scars or the chronic cases where usually the patient, the doctors doesn't want to go ahead because of non-responsiveness. But with this new molecule, again, we have seen a wonderful result even on the scar as well. So this was the another case diagnosed as PNV. This is a few of the other cases where this patient nearly worked for around 4 months. So the longest interval I have seen is working till around 5 months in our institute. So this was on the day of presentation. Here you can see the polyps even on the OCT as well, and received multiple aflibercept on the OCTA. I think OCTA is a new armamentarium where you can classify what kind of appearance you have, a medusa head appearance or a dead tree kind of appearance, filamentous appearance. So based on that, you can decide whether to inject or not inject in these cases. So we thought since it's a dead tree, then let's leave it. But the patient insisted that let me try with this injection. But to our surprise, definitely the patient had a very good improvement in this. So these are the peripheral loops, as you can see here. I'd like to thank Dr. Rajashri for bringing these up. This is peripheral loops which shows the signs of activity on the OCTA. And here you can see this is the whole bunch of neovascularization, and here you see there is completely a less network post-injection on OCTA. So well-defined branching dense capillary network, presence of anastomosis and perilesional intense halo are considered to be the signs of activity and where you can go ahead with these longer acting anti-VEGF. Thank you very much, and KVS sir, I finished in 3.5 minutes. Yes madam.
So very nice results, Srinivas. I just wanted to ask you that these patients anatomically look much better with the resolution of PD. What about the visual recovery?
Very good question. So there was one orthopedic surgeon, I would not like to name him. So he came with the type 1 CNVM, and he was still operating, and then his vision almost was around 660. So then I was very reluctant in the before days because of that, but now I am giving it even in naive cases and to my relatives also. So when I gave it to him, his vision is 636 parts, but what he says is the contrast sensitivity has increased. And even though the fluid drying effect, because he has taken multiple injections of Avastin, ranibizumab and aflibercept, but what change he said in this case was there was early betterment. So the early drying effect, even the Hawk and Harrier has also said that when we try to compare, of course head-on trial is required to completely say which is a better molecule, but looking at because he's a doctor and he's an operating surgeon, I believe that the contrast sensitivity at least increases, and some patients have said the scotoma comes down.
I just want to tell you that Srinivas Sadda in AO presented a subgroup analysis where he has shown, apparently he's done a small series which probably he would be publishing this year, where after the resolution of PD, because that has been the hype created for brolucizumab that it really resolves the PD, they've actually found that the vision decreases after there is a decrease in the PD. So, and even whatever limited experience I have, though the patients look very good on OCT, But apparently the visual recovery is not
Not that great.
great after the PD
But only thing
resolution.
is, just a PD, I don't think it's an indication for giving the injection.
Absolutely.
Of course, there are the other signs of activity is when we look at
No,
it.
what I meant, if the PD collapses, it actually results in a visual loss.
Even though there is a resolution of the
Yeah,
IRF and the
yes,
SRF.
yes.
Okay, interesting. Would like to look into those papers.
Nobody still knows about it, that what is the possible cause of it.
So now we move over back to the OR with Apurva ma'am as she closes the case. Over to you, ma'am.
Yeah, so I'm doing laser now. There is a bleed here, but I'm extruding it periodically so that it doesn't clot. There seems to be an active bleed from a major vessel, but you can see, look at that. PFCL, no wait, I'll just, there seems to be a major bleed, but I'm going to finish my laser wait and I'm going to show you the end result at the, after I put oil, I think. So because this is going to take time, I have to be patient, and I've removed all the membranes. Now I just have to tackle this active bleed, and I'm going to do that while you probably continue.
Right. So, ma'am, if that's okay, we'll move over to the next segment.
Yeah.
And as and when you all are nearing the end, we'll come back to you.
Yeah.
Okay. So, I'd like to thank all the moderators and chairmen for chairing this segment. We move on to our fifth session of the day, surgical khichdi. So, thank you all of y'all for all the chairmen for this session. A round of applause, please. So, I'd like to call on the chairpersons for this segment now, Dr. Girish Masurkar, Dr. Sudhakar J. Do we have you all here? Dr. Chananagowda Patil. And the moderators would be Dr. Satyajit Sinha and Dr. Rekha Mudal. Can we please have you all in the front row? Lights, lights please.
Good afternoon, everybody. I will be speaking about keratoconus and advanced keratoconus. So, as we all know, that keratoconus is an asymmetric progressive ectatic condition which can lead to significant visual impairment. So, there from times, the last 20 years, there have been various classifications. Some are relatively old, some are new. But in most of it, it has been seen that the correlation with the disease severity was not there, and it would not reflect the actual burden of the disease. So there have been various criteria to discuss about the progression of keratoconus regarding the steepness of the keratometry, flattest keratometry, everything. But from what we know or what we can follow clinically is that whenever there is a steepening of the anterior corneal surface, the steepening of the posterior corneal surface, and an associated thinning or increase in the rate of corneal change, we would say that it is a progressive keratoconus. The evolution of the topography has also evolved from the first time Robinovich came up with this diagram way back in 1998. So we have seen that the evolution of keratoconus classification from Amsler-Krumich to the recent ABCD has happened over a period of time in order to identify early, middle and probably late keratoconus. So what is advanced keratoconus? So the precise definition of advanced keratoconus is still unsettled. But what we can fairly agree upon, it is at a stage when sufficient correction with spectacle is not possible, continued contact lens use is intolerable, and the visual acuity is falling down. So advanced keratoconus has a relatively working definition where it has to be reasonable, useful, no gradation, and there is no need of specialized imaging. So this is a major algorithm wherein once you have diagnosed a keratoconus, you see the presence of a deep scar or the presence of a very thin cornea. If both of them are associated with a low visual acuity, you would go for a dark or a penetrating keratoplasty. However, when there is a progression and there is an acceptable visual acuity, you could follow up with preventive strategies and collagen cross-linking. But if there is still a progression with and they are not able to do, then probably you need to do something like CXCL+. So this is an article by Dr. Vardhaman, which I think he will be dealing about regarding where he has given a very nice flowchart regarding the diagnosis and progression, how we would like to approach the patients depending upon the stability and the progression and other different treatments which are available. The next following speakers will be dealing about it. So basically for the general public, we should know that whenever we are talking about keratoconus, this is a brief chart. Whenever we see the keratometry on the flatter, steeper side, we need to go for more invasive surgeries like DALP or PKs. However, if it is on the flatter size, we can go for conservative strategies. Same goes for refractive errors and also for the corneal thickness. The thicker the corneas, the better the leverage we have. The thinner the corneas, the more invasive surgeries we do. So what are the invasive surgeries which, with the strategies which are replacing the surgeries? So there are three things which I am going to talk about. One is the ICRS, that is the implantable corneal ring segments, which helps to regularize the corneal shape. They reduce the corneal astigmatism and the higher order aberrations, improve the visual acuity to acceptable, and they try to delay the keratoplasty. So these are the different, this is the cross section of the ICRS, and basically it depends on two principles, that is the Barracuer principles and the Lavatsky principle, wherein you have flattening and steepening on opposite angles. So you consider these when patient is having a decent visual acuity, he has an intolerance to contact lens, and more importantly an absence of corneal scarring. There are different models which are available and they are continuously evolving, right from the intacts to the Carrara rings, Ferrara rings and the Mayo rings. The second thing which is coming up newly is the femto-assisted implantation of the corneal stromal lenticule. Now, there are a lot of different techniques which are done initially manually, but more importantly with the use of femto-assisted techniques, femto-laser assisted techniques, you can go for a donut ring shaped lenticule, a concave lenticule or a convex lenticule. The role of these things is that they tend to add to the stromal augmentation and make it a more regular surface. But the problem being faced is that we are not able to have a definite normogram, and this is still evolving. The recent technique which has come is the Bowman's layer transplantation. So basically what we can do is either place the Bowman's layer on or just below the recipient donor, and this is a short photograph which is showing how you are harvesting the Bowman's layer after the epithelial is removed and making a small pocket after the Bowman's layer is stained with Trifen blue, you can implant it. So what we can expect in the future is that there has been continuous evolution in the diagnosis as well as management. In terms of diagnosis, we have the newer imaging modalities like the epithelial thickness map and the corneal studies based on corneal biomechanics, whereas in treatment we have more amount of collagen cross-linking plus surgeries and customized CXCLs, and in case of keratoplasty we are evolving from stromal augmentation and Bowman's, and newer cellular therapies are coming. Thank you for your patient hearing.
Thank you, sir. So now we have a talk on special contact lenses for corneal disorders, which will be given by Dr. Rajeshri. This is anterior segment Rajeshri. What you saw in the video was posterior segment Rajeshri.
Mohan did not mention that. Good evening, everybody. My name is Dr. Rajeshri. So mainly we'll be focusing on contact lenses in keratoconus. As we all know, keratoconus is characterized by progressive corneal thinning and steepening. Tomography is crucial to diagnosing KC at an early stage. It also helps us to understand the severity of the disease, the morphology of the cone, and the parameters that is required for choosing the size of the contact lenses. HVID and K1 and K2 is important for us to choose the size of the contact lens. Vision is deteriorated because of irregular astigmatism and in both eyes having non-orthogonal axis. Whereas some patients may be adapted to the blurry image despite the 6/9 Snellen's vision, Most patients are unhappy with the quality of the vision because of distorted vision due to higher order aberrations such as vertical coma, which causes glare and monocular diplopia even in the early stages of the disease. Now, contact lenses in keratoconus remains the first choice for treatment for visual rehabilitation after collagen cross-linking. It forms a tear meniscus under the contact lenses. So the different types of contact lenses that can be used are soft lenses, RGP lenses, hybrid and scleral lenses. Soft contact lenses only improve the vision quantitatively, but the patient will be left with a blurred image even after achieving 6/9. So there are majorly 3 types of contact lenses, that is corneal, which is entirely a cornea bearing lens, corneoscleral, which shares the bearing on the cornea as well as the sclera, but the third type is scleral, which is entirely bearing on the sclera. So the back vertex distance or the power of the contact lens will be much lesser than the spectacle, because it is much closer to the nodal point, and there is a formula which calculates it. The base curve is the posterior curvature the posterior curvature of the contact lens, and diameter is the edge to edge overall size of the contact lens. So the rule of thumb is if the base curve reduces, there will be steepening, and for the steepening, every 0.05 mm steepening, there will be plus 0.25 increase in the power of the tear meniscus lens. So in the preliminary assessment, dry eye evaluation and slit lamp is very important for us to rule out whether the patient can tolerate a contact lens. So the first type, the most commonly being used, is the RGP lenses. It is an entirely cornea bearing lens which can be used only in early or mild keratoconus, and as the disease becomes more advanced, RGP lenses do not give the ideal fit. The keratometry and the corneal topography is very important, because the flat K is what decides the base curve and the power of the contact lens. So an ideal fit is when there will be a central alignment, an even distribution of fluorescein. Mild mid-peripheral bearing should be very mild, and the edge band should be 0.8 mm, and the movement after the patient blinks, it should be 1 to 1.5 mm. If it is too steep, there will be heavy mid-peripheral bearing, as you can see here, and there will be a severe central pooling, and a flat fit will excessively touch the apex of the cone, and the patient will not tolerate the contact lens. We should allow an adaptation period of 30 minutes after contact lens application and check for the static and dynamic fit, and an over refraction is done for the improvement of vision. So rose scale lenses are used in advanced keratoconus where it is a multi-curve design and it fits better on advanced cones. So there are 3 steps to fitting a rose scale lens. There should be a feather touch at the apex. There should be 0.5 to 0.7 mm of edge clearance, and overall supported by both upper and lower lid. So we are also using scleral contact lenses for mainly pellucid marginal degeneration, post-traumatic scars, and patients with SJS and OCP, which has corneal scars. The scleral contact lenses should have the ideal size based upon the HVID which we see in the corneal topography. It should have a limbal clearance and an edge lift. This is important so that the contact lenses do not impinge on the limbal vessels and causes low tear exchange behind the contact lens. So this is the way the contact lenses fit into the eye. And a sagittal depth of at least 250 microns is important to have an ideal fit. That is, we can just compare it to the thickness of the cornea and understand whether there is enough tear meniscus behind the contact lens. Thank you.
Thank you, Rajashri. So our next speaker is Dr. Shilpa Malay. It's a talk on practical pearls for C3R management. Over to you, ma'am.
So, good afternoon everyone. I will try to keep it as simple as I can. Cross-linking, naturally it is seen in cases of natural aging process and diabetes mellitus, where we see advanced glycation end products. That is the reason we do not see keratoconus in cases of type 1 diabetes mellitus. Artificial cross-linking, the idea came from a dentistry department. So artificial cross-linking is seen in case of dentistry, also in case of prosthetic valves, and in ophthalmology as in C3R. So whenever we are going to post a patient for cross-linking, the two important factors to be remembered are the progression and the age of the patient. So there is one school of thought which says any patient who is below 20 years of age is having a keratoconus should be cross-linked. Between 20 years of age to 30 years of age, depending upon the topographic features and associated factors, we decide whether we are going to do immediate cross-linking or we are going to wait to confirm the progression of the disease. And after 30 years of age, really we need to answer why are we doing cross-linking in this patient. The contraindications being a significant scarring, the poor or very good best corrected visual acuity, herpetic keratitis, ocular surface ailments as in severe dry eye, and diabetes mellitus and pregnancy and lactation as for the obvious reasons. The topographic features that we must keep in mind when we are planning or posting a patient for cross-linking is steep K values. Anything that is below 58 diopters of steep K is an ideal candidate for cross-linking. The chances of failure increases in between 58 diopters to 60 diopters, and the complications are very badly seen in cases where we pose a patient of 60 diopters, diopters of steep K values. Also, the thinnest pachy is an important factor. When the thinnest pachy is below 370, we are not going to do a cross-linking. In between or above 400 microns, isotonic riboflavin solution of 0.1% is used. In between 370 to 400 microns thickness, the thinnest pachy, we can use a hypotonic or hypoosmolar solution which is used for increasing the stromal swelling and thickness so that it becomes 400 microns and the cross-linking is done in a safe way. So the two important things that we need to have when we are doing cross-linking is riboflavin. Riboflavin acts as a photosensitizing agent, and ultraviolet A rays that we are going to use, the non-toxic peak of absorption of these rays is 365 to 370 nanometers. That is the reason the UVA light that we use is 370 nanometers. So during the process of photosensitization, we generate free radicals which are catalyzing the reaction and forming covalent bonds which are called as crosslinks. So the standard Dresden protocol, we use riboflavin diffusion into the corneal stroma after epithelial denudation. So why it is 30 minutes? So during 3 minutes of time, only anterior cornea or subepithelial cornea is diffused with the riboflavin, and at the end of 30 minutes it reaches to the posterior stroma. You can see the purple arrow where epithelium is not denuded. The riboflavin that reaches the posterior stroma is very negligible. So during this process, multiple covalent bonds are formed and UVA absorption is very much reduced because of stromal swelling, and the damage to endothelium and the intraocular structure is minimal. In this process, reactive oxygen is very important. So we know the standard Dresden protocol. We will not talk about this. We can check for the diffusion of riboflavin onto the slit lamp. In the first 6 to 8 minutes, it is diffused only into the anterior stroma or subepithelium, and after 30 minutes, you can see it has diffused into the entire stroma of the cornea. So what is the evidence of action? We see a demarcation line definitely onto the anterior segment OCT. The topographic changes that we see are initial increase in the K values, so do not get affected if the pre-op and post-op K values do not coincide or make a sense to you. Later on, up to 6 months to 2 years post-procedure, the regression in the K values and astigmatism keeps on happening. The complications, the majority of the complications are attributable to the longer exposure time after the epithelium denuded. So how do we treat? How do we treat the thinner corneas? We get an hypoosmolar solution. Also, the permeability enhancers are being used in transepithelial CXL, where proparacaine is used 2 drops every 5 minutes or 15 minutes, and the standard procedure is followed. There are other things that can be discussed are iontophoresis, where intralace CXL, where corneal pocket is made with the help of an femto suit, and 100 microns depth, which is open to 5 degrees, and 2 minutes of riboflavin is injected into the pocket, and the cross-linking is done according to the standard or conventional resident protocol. Here the cross-link bonds are seen 60 microns anterior to the pocket and 200 microns behind the pocket. So it is as comparable as to EP-off technique. Iontophoresis, where keratometric regression and demarcation line are not as comparable to epithelium off technique, but they are definitely better than EP-on technique. So according to photobiology rule, we can increase the time and milliwatt, where we can plan an accelerated CXL, where higher energy is used in a shorter time duration, so the complications are least, and the healing and the patient comfort levels post-operatively are better. Also, there was a thing that oxygen that is needed or required for the mediation of the procedure gets depleted in a 15 to 20 seconds post starting of the irradiation, and repletion takes a little longer time. So there are different regimes of on and off protocol where you get time for the oxygen to be replenished. Thank you. The Athens and Creton protocols will be discussed by the next speakers.
Thank you, ma'am. So now that we have the basics of C3R covered, we have Dr. Aniket Shastri coming in to shine some light on the combination procedure of a trans-PRK with C3R in keratoconus.
Good afternoon.
What should I do?
Let's see, everybody is waking up or not.
Leave it.
I think tea had to be served now, probably. That will probably wake up everyone.
Huh?
So good afternoon. I'll just touch upon what's PRK with C3R. You may be wondering what are we doing with the refractive procedure in a corneal cross-linking. So this is something which has been covered. It's a progressive disease. Treatment options when it came before, until the beginning of the new millennium, it was always keratoplasty or glasses and contact lenses. And this treatment paradigm for keratoconus is now added. We had the C3R, which was the only thing, and which is the only thing which we have that halts the progression. Now after the progression is halted, now what? How will the vision improve? That is where these procedures that come that improve the actual vision. Either you have the intracorneal ring segments, you have phakic IOLs, or you have a topo-guided C3R. Now this procedure to improve the vision post cross-linking combined with refractive surgical procedures is what is called as CXL plus, and it includes topo-guided TPTK or the Creton protocol, the PRK, the intracorneal ring segments, and phakic IOLs. Basically, when we are talking about refractive surgeries combined with cross-linking, we are only talking about trying to give a better vision with glasses, or a person who is intolerant to contact lenses tries to accept the contact lenses. So why CXL plus? When CXL alone is done, it causes stiffening and stability of the keratoconus, we know that. But what about the surface irregularity that is there? For that we used to give contact lenses. Now what for patients who are not able to accept the contact lenses, that is when we have refractive procedures along with CXL that regularizes the cornea, and therefore we have a double effect of stability along with functional gain. So how does the topo-guided PRK work? Basically it's a combination of myopic and hyperopic ablation. And this causes a cone to be more flatter and broader, and further this effect is further enhanced by cross-linking. If you see this photo, this is the first photo of keratoconus with a clear case of a moderate keratoconus here, and then this is the here where this is the ablation on the cone, and this is the hyperopic ablation, combination of a myopic hyperopic ablation, and this is the post-op topo, where directly looking at the topo you will not even realize that this patient had a keratoconus. So general guidelines is
of course, it is still in mild to moderate keratoconus. We don't advise in advanced keratoconus. There has to be a pre-op thickness of at least 450. We'll come to that why. We do not ablate the whole refractive error. We ablate around 70 to 80% of refractive error. That comes, but at least maintain around 50 microns of ablation. Emetropia is never the goal, and of course, this is followed by the C3R. So this is what I was telling about. After taking out 50 microns of epithelium, we correct the astigmatism, which is around 70% with ablation, so that 50 microns of ablation is maintained. And then after everything is done, you have a residual thickness of at least 400 before, but we can stretch till 350 now with the present riboflavin with HPMC. And then you have the C3R to be done. So basically the indications are any progressive keratoconus where the vision is unacceptable or the patient is unwilling to wear glasses or contact lenses post C3R, or a person where in later stages where it is a stable keratoconus but still has an unacceptable vision or is not tolerating contact lenses. So it has been proven that it is definitely possible to do a PRK with CXL and the cornea tolerates well, and more than 3 to 4 years of data is been there with us by Canalopolis group, which shows that it improves the UVD and spherical equivalents. Nowadays we are doing simultaneous topoguided PRK and C3R on the same day. It was Kinemios and Canalopolis, there was the one that came up with the Athens protocol, and they have pioneerized this treatment. So on the Schwein platform we don't have the topoguided PRK, so what we have is something called as the wavefront guided tissue shaving ocular wavefront guided PRK algorithm. So in that it creates this double myopic hyperopic ablation, and these are the results. So it causes better visual acuity, safe, flatter K values compared to only C3R, having a better refractive. So this is our protocol. We started doing this in January of this year, and we are doing the ocular wavefront guided trans PRK with tissue saving algorithm in early to moderate keratoconus with a PACI of 450 to 470 microns, and we are using the accelerated C3R with no MMC. This is one of our cases, last 3 cases, the 6 slides. So you can see a large globular nipple cone here, and he had a trouble with advanced fitting of the contact lenses. So we started correcting only the higher order aberration that bothers C3 cross-linking, the keratoconus, that is coma. And this is ablation profile. It's flattening here and steepening here. And once you see this K maps, see there is a central flattening, and it just makes the patient tolerant for contact lenses. Another patient with asymmetric bow tie with inferior steepening. And this you see, there is regularization of astigmatism here. Though both these case 1 and case 2 patients are moderate keratoconus, and they may probably require contact lenses or ICRS for better vision. And it works best when it is an early keratoconus. If you see, post surgery you don't even realize that this patient even had keratoconus. So this is quite a promising procedure, and not in a non-advanced keratoconus, and a better visual rehabilitation compared to CXL alone. Thank you.
Thank you, sir. So now moving on to the most awaited talk of this segment, we go to Dr. Vardhaman Kankaria, who is the director of Asian Eye Hospital. He was a gold medalist at KEM, and then he was the outgoing resident of the year in SN. He is the first and only Indian ophthalmologist to undergo fellowship in advanced refractive surgery in the University of Crete in Greece. And after that, he completed 1 year of corneal refractive surgery fellowship at Boston Palmer. And you don't need him, you don't need me to say anything about his surgical finesse. We already saw him display it this afternoon with the ICL. So over to you, sir, for your talk on refractive surgery.
Thank you, Rohan. Just before he starts, we have 3 or 4 more interesting talks. One is by Dr. Harshul Tak. He'll be showing some interesting videos, and then we have Dr. Cyrus Mehta, who will try to confuse us on the multifocality, whether to convince the patient or confuse the patient. I think it's the best talk suited for him. So he'll be covering that very soon, and after that we'll have a 3D show by Dr. Santosh Honavar about the simple oculoplastic surgeries as well. So these are the talks lined up, and after that we have pole to pole 3-3-minute videos, right from pterygium surgery to the foreign body. It's around 5-6 topics are there, and hope we end up this session before 6:30. Over to Dr. Vardhaman, please.
Thank you, Dr. KB. Again, thank you to MM Joshi Eye Hospital and the team for the kind invite. I'm going to take you through what has been discussed in the last couple of talks, but I will go more in details of the same. I have had honor of working with Professor Kimionis. He was the second professor with Professor Palikaris in Crete. This group has been the pioneer of CXL plus procedure in the world, and we have published, the group has published more than 75 international papers only on CXL plus. So I'm going to take you through some of the results of all these technologies and how we choose each technology for each patient. So what I'm going to talk to you about is this whole concept of how we can combine the refractive surgery with collagen cross-linking in keratoconus. And in the beginning, of course, everybody asked us, are you really serious about this concept? Because this started back in 2005. So as we all know, collagen, the keratoconus is a progressive thinning disorder of cornea which leads to irregular astigmatism, that in turn leads to aberrations and deterioration of visual acuity, both qualitatively and quantitatively. It has been well proven already that collagen cross-linking has been successful in stabilizing keratoconus successfully. However, the most important question is that is only stabilization enough for our keratoconus patient, or should we actually aspire for more? So looking at one of our first patients, Swati, so as you see, she came with a decently moderate vision of 20/80 and a moderate keratoconus, had a good corneal thickness of 480 microns, and she was not tolerant of contact lenses. So in those times, we did a resident protocol for her. So upper is the pre-operative, the lower is the difference map. You can see that after 5 years of cross-linking, she was not only stable, but her keratoconus had shown a bit more flattening. However, Swati was completely unhappy because now this time Swati did not have good functional vision, although she was stable. So we realized that in these patients, although we are actually achieving stabilization, but we are not giving them good functional vision, especially if they cannot tolerate contact lenses. So this was the whole concept of combining stabilization of keratoconus along with visual rehabilitation. This came to being is called as cross-linking plus or CXL plus. So our group with Kimionis, we published an editorial in JRS, and this concept of cross-linking involved combining the cross-linking process with topographic guided PRK that we have just discussed, transepithelial PTK, the phakic lenses such as ICL and ISRS or intacs, and give rise to not only stabilization but also improved vision for our patients. So I'm going to come case by case basis, how are we actually choosing our patients for all these scenarios. So let us look at this patient. This patient had come to us with what is called as a mild keratoconus with a best visual acuity of 20/40. He had a very good corneal thickness of close to 480 microns. So in this scenario, as it was discussed in 2009, Kimionis et al. And Konolopoulos both at the same time published for the first time that topography guided PRK can be combined with collagen cross-linking, not only to stabilize the keratoconus but also improve the topography of the cornea and improve the functional vision simultaneously. So once this paper was published, then we published another paper in 2013, which was a long-term comparison of this Athens protocol versus Dresden protocol. So this included in all aspects comparison of 30 eyes each between Dresden protocol for one eye and the Athens protocol for the other eye. And when we looked at the long-term data, we saw that not only the best corrected visual acuity, which was substantially better in the Athens protocol group with the topo-guided treatment, but also the corneal topography had substantially become so much better. You can see the below and the upper maps which can show the improvement. But it is very important to know that these are only the therapeutic modalities to improve the functional vision, not a refractive correction. So you should never go more than 50 microns of ablation and never choose a patient who has less than 450 microns of corneal thickness. So with Athens protocol for our same patient that I have shown, you can see the lower map which is pre-op, the upper map which is post-op, and the difference map on the left side, the vision improved from 2040 to 2020, and the patient is very, very stable even after 5 years. What we have seen so far is that if you want to really combine topography guided PRK with collagen cross-linkage, you are actually ablating the cornea. If you want to ablate the cornea, you should not want to go below 450 microns. But if you look at the reality, many of our keratoconus patients do demonstrate or do come when the corneal thickness is already lower than 450 microns. So if that is the case, the next question was, how can still we give them better functional vision with stabilization in spite of having cornea which is actually thinner? So there came the concept, and the question is that can we do something about the method of epithelial removal itself? Can the method of epithelial removal itself improve the functional vision of this patient when we combining with the collagen cross-linking? And then we studied a paper which was published by Dan Reinstein. Dan Reinstein does a lot of work on the high intensity or high frequency ultrasound. You can see what he has shown, that corneal epithelium is very thin at the apex of the keratoconus, and it becomes thicker as we go along the way. So this differential of corneal thickness we decided to use, and the hypothesis was that if we use a transepithelial PTK blanketly for 50 microns, we will be actually using this differential epithelial thickness as a masking agent. That means we are going to not only remove epithelium, but we are also going to top up a bit of Bowman's membrane and a bit of stroma that is going to enhance and flatten the steep area. So if you look at this case that we had published, you will see the left side of the topography and the right side of the topography. So the left side of the topography shows the apex of the cone, and if you just look at PTK, we have not done any topography guided treatment, we have just done a PTK, but just looking at the PTK you will see that the ablation of the Bowman is actually mimicking very similar to what we have seen on topography, and the second topography that you see is the post-operative outcome. So we have actually had a topo-guided kind of outcomes without doing a topo-guided treatment. This came known as Creighton protocol. So this Creighton protocol is combination of transepithelial PTK with collagen cross-linkage. We have recently published a long-term study of that. Before that, we did a comparative data between resident protocol with mechanical epithelial removal versus the PTK and CXL, which is Creighton protocol. And we have demonstrated and proven that the Creighton protocol gives rise to much better visual acuity and much better topographic indices as compared to only the Dresden protocol. So this was the thing in which you can go up to if you have a moderate keratoconus. Now let us look at this case. This case has a moderate to severe keratoconus or very high astigmatism. So this case has 15 diopters of astigmatism. So this case is definitely not suitable for Creighton protocol as well as for the Athens protocol. So if you get such a case, of course, you have to combine collagen cross-linkage with Intacs. Intacs, as we have discussed in the past presentation, is basically intracorneal ring segments. They go in the mid-periphery and they cause a bit of buttress effect, and they flatten the central cornea, lower the higher order aberrations as well. So they give rise to not only stabilization with cross-linking, but also improved topographic outcomes with the Intacs. In this particular case, because it has a very high astigmatism, we have used a single Intacs SK, and the astigmatism has dropped from 15 diopters to close to 4 to 5 diopters. And the visual acuity has improved from 20/100 to 20/40, which is a very good best spectacle corrected visual acuity to give rise to good functional vision. Coming to the last case scenario, we have seen now what is a mild, moderate and advanced irregular astigmatism and how to correct it along with collagen cross-linkage. But many of our patients actually have a very high myopic astigmatism but very small irregular astigmatism, although they are keratoconic. This is very, very indicative of what is called as a central cone. So if you look at this case has a very high myopic astigmatism, minus 12 diopters of myopia, minus 4 diopters of astigmatism, but a very good best corrected vision of 20/30. So if you have a patient which has excellent best spectacle corrected vision, but has a very, very high myopia or myopic astigmatism, these cases are best suited for performing cross-linking first to stabilize the keratoconus, and after 6 months of stability, you can perform a ICL procedure that we have demonstrated also in the morning, and that can give rise to much better visual outcomes. So this whole thing about not only stabilizing our keratoconus patients, but also along with stabilization, we actually try and improve their functional visual acuity, especially if they cannot tolerate contact lenses, with the help of topo-guided PRK, transepithelial PTK, which is the Creighton protocol, Intacs, or the phakic lenses. This is the new concept. This is what is giving, again, the full let us say, treatment for keratoconus, and not only stabilizing them. So refractive surgery in keratoconus. So as we see, yes, we are serious. So, and if anybody is interested to have any of the papers which we have published, I will be very happy to email it to you. Thank you so much for your kind attention. Thank you. Thank you.
Thank you, Dr. Vardhaman. I think Dr. Vardhaman Kankaria is a big name in the field of refractive surgery in India. He is known for his dynamism, very prolific surgeon, a big name, and done a lot of research. There are a lot of papers behind him. and still is going strong in that field. And thank you very much, Dr. Vadhavan, for making it to Hubli.
Thank you, sir.
And for sharing and also doing a wonderful ICL surgery in the morning.
Thank you, sir.
Taking IOL.
Thank you so much.
Thank you so much for being with us and sharing your experience. Now, for a short while, we just go back to the operating room where Dr. Apurva is concluding a surgery. Dr. Apurva, can we...
Yeah.
Are you
Can
there?
hear me? Yeah.
Okay.
So you can see that I flattened the retina, but there is a small clot at the back. I flattened everything. There's a film of blood. I have put oil already, so that's the end of my surgery. I'll just show you. Yeah, there's a break there. So I am going to do an early SOR in the next week itself and flush this blood out and flatten the posterior pole and do my extra laser. So that's my approach for this. So this break is getting lifted, I know, but that's why I'm going to plan an early SOR and do extra laser and flush out this blood clot. Yeah, that's it. Done. ಸ್ವಲ್ಪ oil ಕೊಡ್ರಿ.
Apurva, we should congratulate you to doing such a complicated case, and you have a very good patience also. You have been tackling one after the other, the bleed and everything.
Thank you, ma'am. Thank you so much.
I think a VR surgeon with patience will have patience, right? More patience, more patience. Okay, thank you, Dr. Apurva, for really showcasing such a wonderful surgery, which is so intricate, and you have given us the exact idea like how difficult is the life of a vitreoretinal surgeon, and still at the end of the day you come out with such flying colors. And with this we go to the next talk. So let me take pleasure in introducing the another star, a giant personality in ophthalmology. He is known for not only his achievements within ophthalmology, even beyond ophthalmology. So introducing Dr. Harshul Tak. He is a man from Jaipur, has been in the field of ophthalmology in anterior segment surgeries. He is again another prolific surgeon. He is known for showcasing his skills, surgicals in various fora and the symposia. And he is an avid sportsman, probably plays all sports at the greatest level, and he has gone a huge, probably one of the biggest ophthalmic group called Life Beyond Ophthalmology, where every ophthalmologist who have their talent beyond their ophthalmic skills showcase it, and Dr. Harshul Tak has threaded all these talented ophthalmologists in this big group, and he has been still spearheading this movement, which is growing from strength to strength every day. So thank you, Harshul, for coming all over from Jaipur, for spending your time here, and over to you for your talk when things...
Yeah, thank you so much, Dr. KP, for your kind introduction. And at the outset, I'd like to thank the entire team of Joshi, Dr. KP, Dr. Satyamurthy, Dr. Srinivas for this wonderful opportunity. It's always a pleasure to come to Hubli. So I'll be sharing few videos with you, and let's see. Can I have my presentation, please? It's not coming. Yeah. No, it's not coming. Yeah. Cancel. Okay, just a minute. Okay, right. No audio, right. So this is the first case. This case I call a double trouble. You can see that there was a subluxation of the white cataractous lens. This was post-trauma. And there was a fibrotic anterior capsule. So two problems were there to tackle. So whenever you have a fibrotic capsule like this, it's always a challenge to make a good capsulorhexis. So after staining the capsule with dye, I use a scissor to initiate the capsulorhexis, and using a microforceps, rhexis forceps to start capsulorhexis. So when you reach the fibrotic area, it's always advisable to go ahead with the micro scissors from another side port to cut through the fibrotic area, because if you try to pull on that fibrotic area, rhexis may run out. So here I am using different hands, changing my hands again and again. And in this area, as you can see, the subluxation is there. You need a good capsulorhexis margin to put capsular hooks. So you need to be careful that you have good edge, almost 2 millimeter of the edge from the equator of the lens, because you're going to place the capsular hooks to support it anterior-posterior direction. So after doing a capsulorhexis, now we need to stabilize the entire this back complex. So here I am putting capsular hooks so that I can stabilize it in the anterior-posterior direction when I am doing phaco. So here goes the 3 capsular hooks. So once you put the capsular hooks, it is stabilized. Then you go ahead and do phacoemulsification. As it was a softer white cataract, phaco was not a problem here. But still you need to be careful. And once you finish the emulsification, now you need to stabilize the capsular bag in the horizontal as well as in the anterior-posterior direction for long-term stability of the IOL. So once I take off the nucleus, now there is no role of these capsular hooks here. So I take them off, put OVD in the capsular bag, and put a CTR ring. So either you can use injector to put CTR, or you can use a freehand technique like this. But use a Q-glance hook from side port once you are dropping the trailing eyelet there. So once the CTR ring goes, it gives stability of the capsular bag. It gives equatorial stability to capsular bag, as you'll see here. And after I go ahead and finish off aspiration of all the cortical matter which is there, clean up the capsular bag. And because the zonular dialysis was more than 4 clock hours, we need to put either a Sioni CTR or a capsular tension segment along with CTR ring. So CTS is of course easier to use. So here I use a CTS segment. So this segment, it's made of PMMA. It's very easy to insert. So once this CTS segment, it goes in the capsular bag, the eyelet which is there in the center, it remains above the anterior capsulorhexis margin. And you have a 90 proline which is tied there in the central eyelet here. And then you make a groove 1.5 millimeter behind the limbus, pass a 26 gauge needle or a 30 gauge needle, and dock both the arms of the proline, 90 proline. And once you have taken out both the arms, you tie this CTS to the scleral wall. So you can see we have a perfect centering of the capsular bag. And now this bag is ready for implantation of the IOL. This is a single piece IOL which goes in capsular bag. take off all the OVDs and close all the incisions. So that finishes the case. There's one more case I want to show. So this is the case which had undergone penetrating keratoplasty and came up with the total white cataract here with some synechias. So this patient had minimal astigmatism. So decide to go ahead and do phaco in this. So here I put irrigation cannula and through the side port and releasing all the synechias from the Kugel's hook, going from another side port and maintaining the chamber with the irrigation fluid so that we can get a good staining of the anterior capsule. So once you have released the synechias, then I go ahead and put dye to stain anterior capsule. And now we need further dilatation. So in this, you need to use any expander device like Mulligan ring or any other device of your choice. This is my preferred device. So here I am putting Mulligan ring. So the leading scroll it goes, engages, and the lateral scrolls come out. So when you have a small pupil as well as the peripheral iodectomy, it's become a little tricky because so you need to use bimanual technique. From one hand I am pushing this iris here and from other hand I am pushing the Mulligan ring scroll here. But once you have this Mulligan ring in place, it becomes like a routine cataract surgery. Do capsulorhexis, take off the nucleus, do IA, and put the IOL. So after putting IOL, you can, so another advantage of using these devices is you can assess the size of the capsulorhexis is proper or not. Because these lenses, they need a proper centering. For that, you need a perfect size of capsulorhexis. So I go ahead and enlarge the capsulorhexis to proper size. And to release it, you need to de-engage all the scrolls one by one. And once you have released all the scrolls, either you can use the same injector or you can just use the Kugel's hook, invert it and take off this Mulligan ring. And this finishes the case. So I think with this, I'll finish my talk here. Thank you very much for this wonderful opportunity.
Thank you, Dr. Harshul. It was magical, Harshul, there. Again, showing some of the toughest cases where his surgical competence and, quick thinking comes into play. Thank you so much, Dr. Harshul, for that wonderful videos.
Thank you, Dr.
Here now we go with the next person, Dr. Cyrus Mehta, who's come all the way, just landed from Mumbai. Dr. Cyrus is a well-known cataract surgeon, refractive surgeon, and a glaucoma surgeon, and he heads the Mehta International Institute of Ophthalmology in Mumbai, started by a very illustrious father, Dr. K.K. Mehta. And Cyrus is a fitness freak, avid cyclist, biker, and whatnot, and he has an eye for the future. So, Dr. Cyrus, you can start confusing us.
Thank you very much, sir. First of all, I'd like to thank all the staff of Joshi Eye Hospital for calling me here and so nicely inviting me to come and talk. Well, I didn't know what I was going to talk on, so I asked Srinivas, what should I say? He said, I'm going to make a topic and send you, you have to speak on that. Otherwise, I would be showing you some videos like Harshul, instead of which I've been given the topic, tips for multifocal practice, the art of convincing or confusing. This somehow sounds like we're trying to confuse the patient. So let's see. See, the basic issue is that no one wants to grow old anymore. See, there used to be these 4 stages of life where you're supposed to be a student till you're 25 years old. And then after 50, you're supposed to go so that other people can take your place. Basically, that was the whole idea, And then after 75, you're not supposed to be seen around there anymore. Unfortunately, all these things have changed now. And nobody wants to grow old. And this old chap here just bought himself a new Lamborghini with his money because he's been making money for 75 years. Again, the whole The whole object of private practice now in the metros has become patient wants to be spectacle free. I used to be a rather heavy person about 2 years ago till the COVID pandemic came, and then there was a lot of gymming because there was no work. And Srinivas said you have to show all these workout videos also, that's why I put it here. So then I always wanted to do this. I wanted to be Arnold Schwarzenegger when I was a kid. So I never had the chance because I went straight from post-graduation into private practice and there was no time. But Corona gives you time to do all these things. So patients also want to be like this. We think that people just want to grow old. Now they'll just wear spectacles and sit in one corner of the house. Not really. They want to be spectacle free. In the olden days, we used to suggest monovision to people because there was no other option. Now you have every trifocal lens in the world is available in India because we are a huge market. And now the EDOF lens has come, which is when less is more. Basically, patient sees less, still requires reading glasses, but then you take more. So now, how to convince people that they must have multifocality? When patient says, well, you know, I'll be happy with reading glasses, fir gaya. How are you going to pay for that 2 crore rupee microscope after that? And that 60 lakh rupee phacoemulsifier and that catalyst? It's impossible. So luckily there are many live examples to follow in society. You show them examples of famous people, celebrities, and say that XYZ is 55, 60 years old. Where do you think his spectacles went? Remember, your patients are the same people who believe that face cream can make you fair, Pepsi can make you into a cool dude, and Cadbury's chocolate can get you chicks. So remember, don't forget about the power of advertisement. You can advertise and sell anything. You can sell ice to Eskimos. And there was a very famous circus at the turn of the century in New York called Barnum and Bailey. And they had a motto, there's a sucker born every minute. So what they did was, there was a circus tent and there was an entry on this side and there was an exit on that side, on the other side of the tent. They charged $1 for everyone and they said, we'll show you all the different freaks in the world. So when the person entered, there were 2-3 normal people and curved mirrors of different shapes. So one would be curved, person would see a distorted image of a person and say, when you go out to the other end and say, "To apne ko to ullu banaya." Because here there weren't any freaks, they were just distorted images in mirrors. But the trick was that he couldn't come back to the other side again. So they kept taking $1 from this side and shooting them out the other side. So this is the American way. So most of the companies are American and we have also learned over the years how to do this. Always remember about the power of suggestion. If you tell a person that they are unhappy or they look unhappy, they actually become unhappy. If you keep on telling a person that they are unhappy, after some time they may kill themselves also. And that is called abetment to suicide. When they go through their things and they find all kinds of letters where you have written that they are nasty and you know they are such and such. After some time, some people take it to heart and that's how they end. So once you tell people that you have to have a trifocal lens, just like a fancy handbag, that thought sticks in their head. And they shouldn't decide in 5 minutes. You have to give them this idea. Your optometrist has to give the idea. Then when they go for OCT, the person running the OCT machine has to give the idea. And see, Vardhaman is smiling so much there, I can see. And then finally when they reach you, now this idea has taken root in their mind that why should we be wearing spectacles? We should also be spectacle free. Hum to kisi se kam nahi hai. How nice you will look without glasses. You have to tell everyone this. Even if you feel stupid saying it, get your counselor to do it. Because most people look better with the glasses. Give options. Now remember that most people go for the middle option. So when you go to a car showroom and you see the same car, the company decides that if you have 12 lakhs, I'll sell you this car. If you have 14 lakhs, I'll sell you the same car with one more screen in the front, which costs 5,000 rupees. And if you have 16 lakhs, I'll sell you the same car with some different colored light in the front. The marketing shows that most people will go for the middle option, not for the very expensive one. Unless they live in Delhi, then they will always go for the most expensive one. So remember that most people go for the middle option. always give a very cheap option like an Indian cheap trifocal, and you have to tell them this is a cheap trifocal. You can be sure that most people will not go for it because nobody wants to be a cheapskate. This was why the Tata Nano failed in India, because it was seen as the car for cheapskates. This was the whole problem. It was marketed as, I buy this car because I just can't afford anything else. So people bought second-hand Maruti instead, and nobody bought Tata Nano. And that is why the car actually failed. It was bad because of poor positioning and poor marketing. So then you give option number 2, option number 3, option number 4, best in the world. Once you tell somebody best in the world, you will always have 2-3 people out of 20 who will go for that. Everybody will go for option 3. Because no one wants to be known as a cheapskate. Also, extra smart people will always go for option 4 and then ask for discount. And incidentally, option 4 is the same as option 3 in most cases. Try not to write the name and model of the lens in the counseling sheet. Because remember, you are here to sell trifocality. You are not a lens salesman. The lens salesman is the guy who sits outside in your clinic at 7 o'clock and tries to bribe you with chocolates and says, I'll take you to America for ASCRS. You are not the lens salesman. We get confused and we have become lens and machine salesmen. Use generic terms. Very few people will insist on a lens brand, like XYZ will come and tell you that we want only Alcon lens. Then you are stuck. You have to give them Alcon lens because some other doctor has already done the marketing for you. But 8 out of 10 people will accept what to say, especially if you look convincing. How you look so convinced and all when you tell the spouse, I love you best, even though you may be thinking something else. So that's the power of looking convincing. Remember that. The world runs on this. Acting is important, which is why a top actor makes a lot more money than a top ophthalmologist. Always say, in the FDA study, only 20% of people wore glasses after trifocal implants. There is no study in the world which says that after you implant this lens, you will be 100%, all 100 out of 100 people were spectacle free and everybody could read N5. It's rubbish. Plenty of people will still need some kind of glasses, and that's what all the studies show. Remember that after COVID, whatever you tell people backed by the FDA, people will believe it. Because for 2 years, Arnab has been shouting on TV, the CDC said, the FDA said. And our educated public who sees that will understand that once the FDA says it, it's got to be right. If they get glasses after trifocal or EDOF lenses and make bad faces at you, remind them about the FDA. Remember, these are the same people, the FDA and the WHO, who gave you chloroquine to kill coronavirus. When I came back to Bombay from America and I had my first talk in I Advance, my father's conference, I didn't know anything. I was just like a fresh postgraduate. So I said, but I told my dad's colleague, Dr. Kirit Modi, how can I go on stage and say all this, I'm doing this glaucoma surgery, I'm doing this and that. People will start asking me questions. Goras in the audience will jump up and say, isko kya malum hai? So his golden words were, when anybody asks you anything, you say, not in my experience. And always act like you know more than them. Also, when you use multifocal implants in your practice, please try to do bilateral trifocal surgery, especially if you do RLE in 48 and 50-year-olds, which I do routinely. Because if you put a trifocal lens in a person who's emetropic, sometimes, and you don't do the other eye, sometimes they end up seeing better with the unoperated eye. Beware of the -1 patient. Avoid, avoid, avoid. If a person is -1, never operate them for RLE, because whatever vision you give them is going to be worse than what they have already. And God forbid you do one eye, you had it, he'll every day come and tell you that he sees better with the unoperated eye. Avoid anyone less than 48 years old. Make sure that you have a good OCT to detect macular abnormalities before the surgery. If there are anything wrong with the person, no multifocal ever. After the surgery, if you find any disease in the retina, remember, patient feels you have caused it, whether it is ERM, macular hole or anything else. Avoid trifocals in certain people. Those who want to see how good one eye is after surgery, then only I'll do the other one. Then they find someone else to do it. Number 2, I had a very important VIP patient. And he came to me with a very important looking lady with a notebook. So I said, who is this? He said, this is my head of research. Whatever you say, she will cross-check it. Then number 3 is, don't forget that after 2 years of COVID, a lot of people have obvious depression and mental disease that was borderline and has now kind of become manifest. So you don't want to end up being the target of that. It has happened to me, that's why I'm warning you. So whenever you look at the person and you look that very, very jittery, something seems off, try to avoid multifocal lenses. Even today, vision at all distances is the holy grail of cataract surgery, and this is what every patient wants, rich, poor, whether they say it or not. Ensure perfect biometry. If you don't have optical biometer and you don't have access to the readings, don't put multifocals. Always do bilateral. Let's not go through these videos because this will bore you to death. Harshul has already shown you lots of nice videos. So basically my talk was how to counsel people for multifocal lenses. And remember that one happy presbyopia patient sends another happy patient, but one disgruntled presbyopia patient tells the whole colony not to go to you. Thank you.
Yeah, thank you, Dr. Cyrus. I think we're all convinced how to confuse people now. Thank you so much for sharing your gems of experience. And now it's the time that our home faculty will be presenting and yet another a series of very well-edited short videos of surgeries from pole to pole. Starting from blitz up to the optic now, you have a very short 3-minute videos coming one after the other in a chain. And we'll be starting with Dr. Manohar Putana, who will be starting with some of the adnexal surgeries. And we have one very important keynote still waiting. Dr. Santosh Honawal just landed. And he will be coming and telling us about the minimally invasive orbital surgery. And this is in 3D, so please search for your glasses, dark glasses. And also when you are leaving the hall, please drop it here and go. And don't forget that the best part of the day is still pending. At 7:30 in the poolside, just the lawn next to this hall, we have a fantabulous program waiting for you. It's called the Saturday Night Fever, the musical night extravaganza, where you have lots of music, fun, entertainment, and please be there for the banquet, for the dinner fellowship. And now we start with Dr. Manohar, who will be, just look for your glasses and please wear it. And we will have the surgeries one after the other by our home faculty. When Dr. Santosh Honawar comes, we will kind of break in for the keynote address. And this will be the last program of the day today. So please wear your glasses, and Dr. Manohar, please start.
Yeah. Good evening, everyone. Welcome to the pole to pole session. I'll be showing 2 videos. First of the video is about DCR. It's about 4 minutes, so please bear. Please wear the 3D glasses. So after an curvilinear J-shaped incision was made, orbicularis was dissected, and to the surprise, there was an angular vein. So we were able to manage, because this is one of the most important complications of DCR surgery, wherein it will bleed. So the angular vein was held with an 2 artery forceps, and it was cut. You can see the angular vein here. So the angular vein was cut. So next, after angular vein was cut, next important step is to file the medial pupillary ligament, that is the MPL. The MPL, as you know, it is inserts to the anterior lacrimal crest. So once MPL is identified, the surgery becomes very easy, wherein you can dissect the soft tissues along the anterior lacrimal crest. So once the area is cleared, you can see here, this is the anterior lacrimal crest area. So once the soft tissues are dissected from the anterior lacrimal crest, you can see that white part, that is the bone, that is the anterior lacrimal crest. So from there, the periosteum is elevated. Once periosteum is elevated, along with the sac, the lacrimal sac is moved laterally so that the lacrimal fossa is seen. So at this time, a osteotomy is made at the junction of lamina propria and the lacrimal bone. So this osteotomy is enlarged to make a very big, that is a thumb rule osteotomy. This is very important. So once a large enough, that is the size of the thumb, osteotomy is made, next is to make the lacrimal sac is cut by introducing a Bowman's probe through the lacrimal punctum. So this is creating the lacrimal flap, that is the anterior and the posterior flap. The posterior flap is cut so that this may lead to the failure of the DCR. So next step is very important, making a nasal flap. H-shaped incision is made on the nasal mucosa. You can see here, this is the nasal mucosa. This is the nasal pack, what you are seeing. So this is the nasal mucosa. So making an H-shaped incision, creating an anterior flap. So the excess of the nasal mucosa can be cut so that once you suture the nasal mucosa to the cut end of the sac, the wound will be tight, that is, it doesn't sag. So now the excess of nasal mucosa has been cut. So then 2 or 3 sutures with using Vicryl 60 is used. So that was the nasal end, nasal mucosa, and this is the cut end of the lacrimal sac, where both are tied. 2 or 3 sutures, such sutures are passed. So this completes the anastomosis of the nasal mucosa and the lacrimal sac. So next is the suturing of the orbicularis, and the next step is the suturing of the skin. So this was about DCR surgery. So I'll be showing next video. Next video is the upper lid tear involving the upper canaliculi. So how to repair a canalicular injury using a monocanalicular stent. This was a RTA case, 3 days old. It's very difficult to find the cut end of the canaliculi, but by using air bubble technique or the Bloom and Triffin Blue technique, it's very easier to find the cut end of the lacrimal canaliculi. So this is the, you can see here, once the cut end of the canaliculi was made out, we did an syringing to confirm it, and monocanalicular stent is being used. If it is the correct passage, then it goes very smoothly, very easily. If it is a false passage, then it's very difficult to, that doesn't go. So once the monocanalicular stent, the stent we have used is Oro stent, no financial interest. So once the canaliculi, the monocanalicular stent is passed, the pericanalicular sutures, 2 pericanalicular sutures are applied to this is the stent, and the 2 pericanalicular sutures are passed so that the stent is stabilized. So once pericanalicular suture is passed, the rest of the procedure, like the orbicularis is sutured and the skin is sutured. Thank you.
Thank you, Dr. Manohar. I think I request Dr. Abhishek Baudekar to continue this string of videos. Dr. Abhishek Baudekar is our cornea and anterior segment surgeon.
Going to speak from here.
So what are the surgery that you are showing, Dr. Abhishek Baudekar?
I'll be showing 3 different surgeries. One is a C3F8 desmetopexy and a C3F8 desmetoplexy in the case of acute eye drops. Just a minute, let me...
Desmetopexy for a descent detachment during cataract surgery?
Yes.
Okay.
One is a desmetopexy in case of a descemet membrane detachment. And then a... Okay, so this was a case of post-cataract surgery descemet membrane detachment. Here we have the intraoperative OCT which is showing us the superior descemet membrane detachment. So we use the OCT to localize the descemet membrane, especially in case of a hazy cornea, the IOCT. And once we have located it, we try to go to the opposite side, and you could see in this case there was a descemet membrane detachment at the mouth of the tunnel, sclerocorneal tunnel.
Is it the intraoperative OCT that you are showing, overlapping?
Yeah, that is the intraoperative OCT which I am using. So we make a side port inferiorly, and then using the C3F8 gas in this, we have just put in a full chamber. You could see some amount of air leak has gone in the subconjunctival space, but that could be removed. But we are using the intraoperative OCT to confirm that the attachment of the descemet membrane. So especially when we are using Ingenuity and you are using this intraoperative OCT, it makes our work much more easier. Now this is another case when we are using the C3F8 for keratoconus patients with an acute eye drops. We can see that there is a lot of scarring which is there and the corneal edema which is there. And if you focus on the intraoperative OCT, you could see the descemet membrane detachment which is there, the ragged torn edge of the descements. So in these cases, this intraoperative OCT along with Ingenuity helps us to make sure that we can see that, localize how the extent of the torn detachments. And in this we are going for an oblique insertion. So, and just going through using a 26 gauge and slow insertion of the intraocular gas. And now you can see that the clarity has improved on the intraoperative OCT picture which is overlapped. And then we just confirm whether the attachment is there. Some amount of corneal clearing is also seen. And once it is there, you can easily close the case. Okay.
All acute eye drops need this?
C3 desmetopexy is preferred in acute eye drops. The same video playing again. It's a loop. So if you are having an access to the intraop OCT, it makes our work much more comfortable. Now this is just to demonstrate how a corneal tear, how deep the incision we can, how deep the needle bite is taken. Okay, so this was a case of an open globe injury with a traumatic cataract. So we are just making a side port. The corneal tear is also seen. Okay, we'll just localize it. So you could see that there is some amount of iris incarceration in the wound. We just sweep using a repositor. Some amount of fibrin which is there, which is also swept off. And then using a 10-0 nylon interrupted suture, we just tie the tear and bury the suture. Okay. So the third video which we are showing is a glue BCL. This was a case of a sterile male patient who was having a rheumatoid arthritis. And here you could see the corneal thinning. We just remove the epithelium from the edge of the thin part and the perforation so that the cyanoacrylate glue can stick firmly to the raw stroma. So once there is dyed, When the bed is tight, we could use a drop of cyanoacrylate glue. And allow it to dry. It polymerizes very fast. So one of the mistakes people make is putting a big drop of glue. You don't need that amount of glue. Hardly 0.05 ml is sufficient. And then you just form the AC anterior chamber using a side port. So in this case, you had also the bit of the, we just sweep so that there is any iris adhesions to the internal tunnel, internal wound is removed. Be careful not to touch the cataract, and just replace it with air and close the wound.
You have to put a bandage contact lens?
Yeah, we'll be putting the bandage contact lens at the end of the surgery.
For how long it has to be kept?
We can keep it for up till 3 months, but ideally we have to replace it every month and keep the patients on long-term antibiotics.
Now what happens to the glue there? That glue deposits?
Once the glue polymerizes and the wound heals, then the glue gets loosened up and it can be easily removed once this heals properly. Okay? Yeah. Thank you.
Okay, thank you Dr. Abhishek Bowdekar. Now we have yet another corneal surgeon coming in to show a few more short edited videos of the cornea procedures. Suresh? Okay. Okay, now we just switched to slightly backwards to the retina. Now we have Dr. Suresh Babu. Dr. Suresh Babu is a vitreoretinal surgeon in MM Joshi Institute, Hubli, and he will be showing some of the exploits of the retina department.
There is a case of ocular trauma, status post corneal tear repair. So after the corneal tear repair, we examined that there is a large IOFB. Giraj, play. So this is the intraocular foreign body. So good vitrectomy was done, and then the vitreous around the foreign body was cleared, and then the foreign body was slowly separated from the retina and the surrounding vitreous. Then because the foreign body was so big and irregular, so we tried removing it through a sclerotomy. Sclerotomy was made, and then using a magnet we tried removing it through the sclerotomy, but then it was quite big, it wouldn't come. So we planned to remove it through the scleral tunnel using a handshake technique. You see that the foreign body fell, and then we used another magnet and tried bringing out through that. It wouldn't come. Again, we used a forceps, and because it was so irregular and large, even the forceps couldn't hold it. So the last option was to use a vectis and bring it out. So the foreign body was brought into the anterior segment, and then with the help of a vectis, it was supported, and then it was slowly brought out. So vectis and dialer, so like how you deliver a nucleus, you can see that the foreign body is so large and irregular. So that was the reason that it was not coming out through that incision. So we had to use a vectis and a dialer.
It was a metallic piece.
Yes, sir, metallic piece. And then again the VL surgery was continued. Although the cornea was so bad, we still had view to see the retina. So you can see that peripheral base shaving is being done, retina is being settled with PFCL.
I think this is the beauty of Ingenuity digital visualization, that you such a bad cornea than doing a vitreoretinal surgery.
Yeah, we can do a vitreoretinal surgery. Also there is a MAC hole. We could even do a macular surgery. So put blue, we could peel the ILM and then close the MAC hole. So this is the best part about Ingenuity. So even through hazy corneas, we can get a pretty good view to do VR surgeries. So after the ILM peel was done, you can see that base shaving was done and retina flattened, lasered, and oil was injected. So this is peripheral base shaving. and then lasered all the breaks. Barrage laser being done. Then you can see that the retina is flat, well attached, and oil injection. So despite such bad corneas, we could complete the surgery. Thank you.
So I'd like to thank all the moderators and chairmen for this session. And now before we move on to following videos and also including Santosh sir's video, I'll call on the next set of chairpersons that will be moderating the session. So I'd like to call on Dr. Pooja Sinha, Dr. Savita Kanakpur, thanks, Dr. Lakshman Dasar, Dr. Vishwanath Reddy, and Dr. Vinay Dastiko. If you all can please come on stage. And so we'll start this with Dr. Giriraj, who is going to be displaying a video wherein we're doing an IOL explantation with a secondary IOL in the form of a scleral fixated IOL.
So I just wanted to show this video because many people say operating on NGNT, especially a sutured surgery, could be difficult. So this was my first IOL explantation SFIL surgery, which I did independently around 2 years back. So if novice surgeon like us could do it, it should not be difficult for others to adapt. So basic steps, we separate the IOL from the vitreous adhesions, put in PFCL so that you avoid switch off the lights please, macula from any trauma, explant the IOL from an SICS tunnel. Then with the help of handshake technique using 9-0-proline, you just place the suture in place and bring it out through the main tunnel. You cut it, then the eyelets are threaded, and the procedure we are showing is a 2-point fixation technique for scleral fixated IOLs. The leading haptic usually goes to the right side and with the slight pull to the thread so that you will get proper centration and the IOL won't dance inside the vitreous cavity. And after that you can suture it to the scleral bed under the scleral flap. Many a times if we choose the site of suture wrong, it can bother the patients by exposed SF knots. So if the scleral flap is good, then we avoid those problems, removing those remaining PFCL, and in the end we can see a well-formed anterior chamber and a well-centered SFIL. Thank you.
Now we have the keynote address by Dr. Santosh Honawar. I take great pleasure in inviting Dr. Santosh Honawar to the stage. Dr. Santosh Honawar, of course, needs no introduction. He is a man with great sense of humor. I think he is one of the brightest ophthalmologists the world has seen. Probably his list of honors and the achievements run into pages, and probably the brightest of the probably we are very proud of Dr. Santosh Honawar at the global level. He is a teacher par excellence, a very immaculate surgeon. Even though he has, dabbled in glaucoma and other things, but presently he is into ocular oncology and oculoplasty, and he is from Hyderabad. Of course, he belongs to entire India. Thank you very much, Dr. Santosh Shunawar, sir, for please go ahead with your, of course, he is...
Of course, everybody knows him, but to name a few awards, is awarded with the Shanti Swarup Bhatnagar Award by the Government of India, Jerry Shields Award by Asia Pacific Academy of Ophthalmology, and the first Indian to receive the Lifetime Achievement Award by American Academy of Ophthalmology in 2019, and the Honorary Fellowship of the Royal College of Ophthalmologists UK in 2020. We all know how the Indian General Ophthalmology has scaled through over the years, and he is the man who has really brought it to the great heights. Over to Santosh, sir. Go ahead, please.
Thank you so much. I first congratulate you all for this wonderful show, and thank you for being so kind to me. I'll be talking about minimal access orbital surgery, and would like to cover non-surgical approaches, injections, target therapy, and conjunctival approach to orbital surgery. Looking at this patient, you might be wondering, what is this patient doing? If he has an orbital tumor, he should have proptosis, but he doesn't have. All he has is loss of vision. He's an airline pilot and is failed in the most recent medical exam because of this orbital tumor that is located right at the orbital apex. He doesn't have proptosis because it's been a very slowly growing tumor pressing on the optic nerve, causing this visual field loss. Now, looking at the MRI, it's very clear that it is a cavernous hemangioma. Cavernous hemangioma is a surgeon's delight. You would like to operate on it. But look at the location of the tumor. It is right at the superior orbital fissure, abutting on the optic nerve, causing this visual field loss. Would you want to operate on this pilot who doesn't know anything else except to fly planes, and he doesn't want any visual morbidity? Possibly not. So there you choose something non-surgical, that is stereotactic radiation. Even benign tumors shrink a lot with stereotactic radiation, and as you see, tumor has shrunken to about 20% of its initial volume, and visual field loss has also reversed. So very carefully you choose a particular approach in a given patient. Going on to injections. This young lady wants cosmesis. She has subtle proptosis of the right eye and recurrent conjunctival, subconjunctival hemorrhages because of a lymphangioma that is located all around the optic nerve and the extraocular muscles. If you were to operate even by the safe supratemporal approach, there could be residual diplopia, there could be post-operative hemorrhage. So short of it, you inject picibanil or bleomycin. Picibanil is a very good drug but currently not available in India. This patient received picibanil, 2 injections, and you can see clearance of the tumor from the orbital apex, intraconal space, and also the extraconal component of the tumor has resolved, and she got the cosmesis that she very badly wanted. That is the post-treatment appearance. Now, if you have a larger lymphangioma with a chocolate cyst or macrocystic lymphangioma, then you aspirate blood under ultrasound or CT guidance, and if it's anterior, you don't have to need radiological guidance, and inject an equal amount of bleomycin into it. This is one such patient where somebody had attempted a biopsy and intraoperatively they had encountered bleeding. At that point, we realized that it was lymphangioma, and all that was necessary was 1 injection of bleomycin. This was a patient again with acute proptosis because of minor trauma leading to secondary hemorrhage in a pre-existing lymphangioma, treated with aspiration and bleomycin. This is an anterior lymphangioma. Again, this patient did not need surgery. All that was done was bleomycin injection. Going on to slightly more interventional procedures. This is a patient who has a large tumor with loss of orbital roof and also involvement of the dura there. Now, what do you think it is? It's possibly in a young child like this, you think of all malignant tumors, of course, but one tumor that behaves like this is eosinophilic granuloma. But unless you biopsy, you can't be sure what you're dealing with. If you were to curate it, then you risk neurosurgical intervention because dura is already affected. So what we do in such patients is to biopsy from a safe zone by a transseptal approach, confirm the diagnosis, and inject a corticosteroid. Here, triamcinolone was injected. So when you do biopsy from this safe zone, obviously you avoid all complications, And following injection of Transloan, 3 months later, you can see partial remodeling of the bone. 6 months later, it's as if the bone was never involved. Bone is completely remodeled. So this can be achieved by just a 40 rupee drug, Transloan, without any major surgical intervention or complications. One more similar child with eosinophilic granuloma, typically it presents with resorption of the bone and it completely remodels over a period of time. Now going on to dermoid. Dermoid, of course, is a surgical disease, we all think, right? But this lady does not want any scar. Now how can we approach it? Transconjunctivally it is not possible. It's a supratemporal dermoid. She can't get a lid crease incision because it is temporal to the lid crease. She doesn't want any scar. She's very particular. So in such patients, we do what is called foam sclerotherapy. So this patient also had extra-orbital component and intra-orbital component. That is sodium tetradecyl sulfate. You mark the center of the lesion and the entire extent of the lesion. Then you aspirate the contents of the dermoid. For this, you definitely need a dermoid without any hair and pultaceous material. It should be liquid content, which you pre-operatively determine by doing an MRI or a CT scan, and make a foam out of sodium tetradecyl sulfate. That is how a foam is prepared, by repeatedly passing the drug through 2 syringes. The needle is held in place after aspiration, and all that you need to do is foam injection. And this is how she behaved post-operatively. This is pre and this is post. Her dermoid resolved or sclerosed. This is a form of sclerotherapy. And we do foam injection because foam has a larger surface area. You can inject a smaller amount of drug with surface tension because there are bubbles. They'll go and destroy the lining of the dermoid. Now, target therapy. This is a patient who has lymphoma of the orbit. Of course, the anterior subconjunctival component can be removed. But what about something that is posterior to the equator? You can't chase it because it's intraconal, very close to the extraocular muscles. One solution is radiation. But if you want to avoid radiation, then you excise the anterior component, which is subconjunctival. And for the posterior component, you inject perilesional rituximab. We know that in malt lymphoma, rituximab is the drug of choice even if it is given systemically. But now we can inject the same drug perilesionally every 3 weekly, 6 injections, and the tumor completely resolved. Now for melanomas, we have the entire mutational spectrum worked out, and many of these drugs are currently available in India. Expensive, but definitely available. For each of the mutations, you have specific target therapy. Now, in the literature, there are cases that are appearing of extraocular melanoma resolving with target therapy. This is a patient with squamous cell carcinoma where erlotinib was used. This is again from the literature. This patient was inoperable because of his age and systemic morbidity, and following erlotinib, the tumor partially stabilized and remained like that for the rest of patient's life. So patients who are inoperable can be treated with this drug, and this drug is currently available in India. Closer home, we have sebaceous gland carcinoma. If you have a patient with such a large sebaceous gland carcinoma, sometimes orbital exentration is the only choice. Especially if a patient has regional lymph node metastasis, then you obviously want to do radical neck dissection as well. But short of radical surgery, you can reduce the tumor by doing systemic chemotherapy. This is a magical response of chemotherapy to sebaceous gland carcinoma. You can see a large lesion with anterior orbital extension. After 1 cycle, the tumor has partially reduced, and after 3 cycles, all that is left is in the lower eyelid, that too in the medial half, and amenable to local tumor excision. Now, coming on to surgery, earlier we were used to lateral orbitotomy, bone cut, all that. Now that is a story of the past. We don't do bone cut. Very rarely we have to do it only for excess, otherwise we don't do it. This is a young child with orbital teratoma, which was on both the sides of the optic nerve, lateral as well as medial, and the child has visual potential. This child was operated at about 2.5 months of age. There we did what is called a transconjunctival orbitotomy with a lateral canthotomy and inferior cantholysis. That is the lateral cystic component of the tumor. That pearly white structure is the optic nerve, And this is the medial component of the tumor. That was the groove through which optic nerve was running. And this could be done with very good visualization because of the panoramic view that we got. And that's the post-operative appearance. Of course, strabismus needs to be fixed, but the child has reasonable vision. This is transconjunctival orbitotomy, where we approach the orbit either by medial, inferior, or lateral extension of the inferior orbitotomy. This is done by the pharyngeal approach. This is a video that shows transconjunctival orbitotomy. It's the lateral canthotomy. About 5 to 7 millimeter lateral canthotomy, which gets hidden easily. Inferior cantholysis to get egress to the inferior fornix. Then you make an incision all across about 4 millimeter from the lower tarsal margin. Not really in the fornix, just short of the inferior fornix. Retract the tissues, palpate the inferior orbital margin, and make an incision about 1 millimeter or 1.5 millimeter from the inferior orbital margin, not to disturb the infraorbital nerve. Periosteal incision all across. Dissect the periorbita. Endpoints are apex of the inferior orbital fissure and the infraorbital nerve, both of which are not supposed to be damaged. So dissect until you reach these endpoints, and then take time to cauterize the bleeding blood vessels, which are perforating blood vessels coming through bone channels, making sure that the field is completely dry before you progress further. Now make an incision in the periorbita in the quadrant where this intracorneal tumor is located. Retract orbital fat, localize the tumor, and dissect it to the extent of about 2/3 to 3/4. And then apply a cryoprobe for a good purchase of the tumor, anteroposterior traction, and gently wriggle the tumor out. There is absolutely no hurry while watching the pupil. There should be no pupillary dilatation during the entire process. And as the tumor comes out, you look at the posterior part of the tumor for a vascular pedicle, which should be cauterized, otherwise the patient may have secondary hematoma. All that we need to now close is the lateral canthotomy incision, which beautifully heals over a period of time. There is no external scar that is visible. And of course, we put in a few sutures through the inferior pharyngeal incision as well. And this patient obviously did well following surgery. I'll show post-operative pictures. And this is a younger individual with a cavernous hemangioma by transconjunctival approach. This is the patient of whom I will show the video. This is 3 weeks later with no stigma of orbital surgery at all. So that's possible with transconjunctival approach. This is a younger patient again with neurolemoma, transconjunctival approach. This is neurolemoma of the infraorbital nerve in an older individual with transconjunctival approach, and this is a fibrous histiocytoma. Going on to thyroid orbital decompression, I just want to stress that if the disease is inactive at the time of surgery, then primary surgery would be very successful. So orbital decompression, basically I'll just go to the video skipping all this, the minimal excess approach again, by a partial lateral lid crease incision. This is the patient who is up for orbital decompression, that is the pre-operative CT scan. Skin incision is being marked, that's exactly at the lid crease. Then we tag the lateral and the superior rectus muscles, brittle suture so that we don't damage the muscles during the process. This is partial lid crease, only to the lateral 2/3 of the eyelid crease. Dissection of the orbicularis. All through I am using radiofrequency electrode to make sure that there is minimal bleeding. Minimal bleeding would mean maximal visualization, and that is the key to success. Exposure of the periosteum about 3 to 4 millimeter above the orbital margin. Periosteal incision 3 to 4 millimeter above the orbital margin. We are doing a deep lateral decompression here, which has minimal post-operative new onset strabismus and minimal complications. Periosteal dissection. In thyroid eye disease, periosteum is more strongly adherent to the bone because of the fibrosis process, inflammation. So you put a lot of effort in sometimes dissecting the periorbita. That's the arcus marginalis, beyond which we go and expose the entire superotemporal and the lateral orbital wall. Dissection is stopped little beyond the lateral and the inferior wall junction. Tractional sutures. This surgery has three components. One is creation of what is called a lacrimal keyhole. This is the lacrimal keyhole. In the supratemporal, you burr the overhanging supratemporal orbital margin to create a keyhole through which you see the rest of the orbit. So keyhole helps in visualization of the posterior orbital wall. And then you go ahead and decompress the lateral orbital wall without destroying the orbital margin. So you don't take off the orbital margin at all. You thin it nevertheless, but you keep it intact so that your post-operative exophthalmetry will have a baseline. Keep on burring until you reach the sphenoid, and the sphenoid is burred to the extent that very little bone, maybe 0.5 millimeter or 1 millimeter thin bone is left to cover the dura. If you have any kind of doubt about how deep you have gone, you can always use intraoperative navigation. So very gradually bone is thinned out to create space, and laterally you go full thickness so that the orbital contents prolapse into the temporal fossa. All this is done with a high-speed burr, and once bone decompression is over, you open the periorbita. All this fat that is waiting to come out comes out, spontaneously prolapses out. Without pulling much on it, you excise fat. So it is bone plus fat decompression. If you just do bone alone, then you get possibly 2.5–3 millimeter of decompression. If you do bone plus fat with deep lateral decompression, you can achieve about 4 to 5 millimeter reduction in exophthalmos. Lacrimal gland is visualized and preserved. You're not supposed to touch the lacrimal gland or damage it. Then the patient will have inflammation or dry eye. And once that is done, you kind of settle the orbital contents back and simply have to close the lid crease incision. So it's a fairly quicker, safer surgery than doing a 2-wall or a 3-wall decompression. 2-wall decompression leads to new onset strabismus, and if you do the floor, then obviously the patient will have hypoglobus. Especially if it's a unilateral decompression, then doing a 2 or 3-wall can be leading to asymmetry. And this is how these patients look post-operatively fairly well. But of course, the lid is the last. Finally, you have to correct the lower lid, and if the patient has upper lid retraction, you have to correct that as well. Decompression comes before the lid surgery. This one more patient, worm's view, showing the effect of decompression. So in conclusion, I would say that in orbital surgery, currently we believe in the concept of less is more. Minimal intervention leads to maximum benefit. Thank you so much.
Thank you very much, sir. I think every time we listen to Dr. Santosh, we learn new things, and he always keeps us, informed of the latest things in the oculoplasty and the orbital surgeries that's happening. Thank you very much for coming over once again and giving such a wonderful talk, sir. I think there are a few announcements I would like to make. The Saturday night favor, the banquet fellowship dinner will be at 7:30 sharp in the lawn poolside in the same premises. Please, you have the banquet coupons with you. Please, we'll be happy if we can bring it along to get the entry. At the same time, please relax yourself. You had the whole day of a lot of, very high density talks, live surgeries, discussions. So the time to unwind and have some real fun time after 2 years of hibernation, 2 years of, the whole world is now divided into BC and AD era. BC means before Corona. Now that we have to regain and reclaim, probably redeem all the lost glory. So let's really, say goodbye to Corona. Let's enjoy and, relax. In the evening, we expect all of you to be there. Lots of music, lots of fun, lot of dancing. So be there. And also the moderators and the chairpersons who have really helped us in conducting a smooth deliberations of the whole day. We want to felicitate them with the memento as a token of affection in the banquet, not here in a much, more relaxed environment. So please be there to receive that. And with this, we thank everyone, all the guest faculty who have traveled far and wide to make this happen, and all the delegates who have come in big numbers and with a big encouragement to this, because we had this in January, it got postponed because of this third wave, and we have braved it again, and thanks very much for really encouraging us, turning up in such big numbers. So, and we have a feedback form also in the kit, so try to fill it up and please pass it on to us tomorrow so that we'll be able to organize these things much better. So with this, we end the first day's session of the IFEST 2022. Thank you very much, and please be there at 7:30 for the Saturday night fever. Bye.